Good morning, doctor.
Good morning. Good morning.
Yeah.
Harshit, Harshit,
Yes,
right?
sir.
Yeah, good
Yes,
morning.
sir. Good morning.
I'm Dr. Manjunath, eh?
Yes, sir.
Yeah.
I've seen you in previous conferences.
Yes. We have hosted quite a few. Right.
Yes, sir. When will Dr. Malcolm be joining us, sir?
He's joining. He's joining on the other side because
Okay.
I have joined through Wi-Fi. To be on safer side, we have a LAN connection. So he's joining from the LAN side.
Okay, sir. No issues. I'll just share my screen once, just to see how if you're getting the audio, video. Let's check that once before everything starts.
Sure.
I'll do it, sir.
Yeah.
Can you see it, sir?
Yes, I can.
Okay. I'll play once, check whether audio and all is working properly, sir.
So a very good morning to everyone. I welcome all of you to this case discussion on bullous diseases. Our esteemed faculty for this session are Dr. Raghvendra Rao, Professor and Head Department of Dermatology at KMT Manipal.
Okay, then that's it, sir.
Will it change when it goes to the other link? It will be exactly same, right?
Same, sir. Yes, sir. Sir, Dr. Savita is calling me. Let me take this.
Yeah. Please take it.
Hello. Please, sir, let me hear.
Just see how is that from our side.
Very good morning to all of you. I welcome the students, the residents, and the faculty members.
I can hear, sir.
On behalf of the.
Sir, who is this Atul, sir? Do you know him?
Yeah. He's our PG. He's also from our side. Yeah, you can take him.
Okay. Yeah. I can hear your video, sir.
Yeah. I'll stop sharing. No, this is the inaugural video.
Okay, sir.
Yeah, because it's 2.4 GB, 3.5 minutes video is 2.4 GB. That is the reason why I didn't want.
That's fine, sir. It's okay. You can just join in 9:45 or 9:50 and you can play it once.
No, it's not just a play. There is some part is live, some part is video.
So okay, sir. You join, you can talk live and then you can play however it is convenient for you.
Yeah. That's exactly the plan.
Okay, sir.
Hello.
Yeah, Dr. Malcolm, we can hear you. Yes.
Yeah. Hi,
Harshit. On the video. Switch on the video.
Yeah, just a minute.
Hi, Dr. Malcolm.
Yeah, Harshit, can you make me the co-host?
Yes, I'll be doing it now. It was written as Atul, no? So I didn't know it was you or.
Yes, no problem.
You can rename Dr. Malcolm.
Yeah, you can rename yourself.
And also, every moderator should rename themselves.
Yeah, Harshit, just a doubt. Can you read out like what videos are there in the backend for the pre-lunch session?
For what session?
The pre-lunch session. Can you just read out the videos which you have arranged with yourself?
Okay, it is case 1, bullous disorder.
Okay.
Then theory paper by yourself.
Yes.
Then there's an inauguration.
Okay.
Then a break.
Yes.
Of 15 minutes. Then spotter 1.
You have the video of spotter 1?
Yes, I have it.
Yes. Okay.
Then case 2, leprosy.
Yes.
Then STD 1.
STD 1. Okay, fine. So all this is fine. Okay.
Yeah.
So only one thing which I want to tell you is after spotter one, there is no break. I mean, there is no question answering. Okay, so after spotter one, I'll just mention like what you said. What was that? We will resume. We will resume with the next program shortly. Stay tuned in.
Okay, okay. Sure.
That's what I will do. Okay.
Yeah.
Okay. Sir, anything else?
That's it. I think there's nothing much. Only thing is, we will have 2 minutes kind of interaction before the program starts. Then you start announcing.
Yeah, that is fine,
now,
sir.
yeah. Now we are actually we are not we are offline, isn't it? Now currently we are
Now
not.
we are not on anywhere, sir. We are not on the platform.
Good morning, sir.
Yeah. Good morning, Dr. Savita.
Good morning, Dr. Malcolm.
Good morning, ma'am.
Savita, video on ಮಾಡಿ.
Sir, video on ಮಾಡೋ state ಅಲ್ಲಿಲ್ಲ. Kitchen work.
Kitchen work. Okay, okay. That is also an instrument, is it? ಅದನ್ನು ಒಂದು ವೈವ ಮಾಡೋಣ. Yeah.
Dr. Savita, I've added the names which you have sent, and I'm sending the mails now. So, Dr. Malcolm, you know about how we are going to have a break between sessions, right?
Yes. So during the break, what I will give, we will resume the next program shortly. Stay tuned in.
Yeah, that's all. And when I say I'll be communicating with you on WhatsApp,
yes,
just keep it open. When I say speak, you can start with the next presentation.
Okay, that you will be messaging me, isn't it?
Yeah, I'll be messaging you. I'll be like 30 seconds to live. And when I say like 10 seconds to live, and when I say speak, you can start speaking.
Yeah, we can go live at 8:28.
8:28, huh?
Yeah. Just a minute.
Okay. Then I'll put a 5-minute timer at around 8:20.
8:28 can we go live? 8:28 will go live. Yeah, 8:28.
And keep the phone numbers.
Phone numbers and Gilly. I'll tell the people.
But they should keep one phone numbers and one watch it. Just get you on WhatsApp.
So I'll put a 5-minute timer at around 8:22 or 8:23. So at
8:28 will go live. Yeah.
Okay. And so I'll be telling you like 30 seconds prior, like when to speak. And when I say speak, you can start speaking.
So these are all WhatsApp messages, isn't it? Okay.
Yeah, everything is on WhatsApp. I won't be talking to you on Zoom.
Okay,
nothing
fine.
except for sharing my screen. I won't be doing anything else.
Okay, fine.
Yeah.
Mr. Harshit.
Yeah.
8:21 night. What is the time by your watch?
8:21.
8:21.
Yeah.
Yeah. One more thing is, audience questions you will be sending on WhatsApp only. I'll keep giving message.
Yeah, I'll send you on WhatsApp, so you can filter through the questions, because I won't know which questions for you to present, right?
Yes.
So we'll do that.
So is the first lecture ready in the backend?
Yes, it is ready.
Yeah. So when I say
I shared with Dr. Manjunath, so he could check whether the audio video was coming for it.
Okay. So the last sentence will be, I request the host to connect with the residents. After that, you can play it.
Yeah. The video is for 54 minutes.
Yes.
Yeah, so we won't be doing anything.
Yeah. So as soon as you stop sharing, then we will.
I'll let you know 1 minute before the video ends.
Okay. Perfect.
I have put on a timer, so 1 minute before the video ends, I'll let you know so that you can switch on your video. You can be ready.
Yes. Okay.
But
Okay, the timer has started, Dr. Malcolm.
Yes. Speaker really, yes, you can see. Yes. 2-3 people can be. So that you just have to see whether Raghvendra is also.
Those monitors are there.
The virtual background.
Oh, no, we can log in from home.
Sir, I have started the timer. In another 4 minutes, we'll be going live.
Harshit,
Yes, sir.
I have added to a group where our faculties are there. Okay, we have created a faculty group. Okay.
Okay.
Yeah, any information you can paste there.
Sir, like within the faculty group, it won't be proper to coordinate with the hall coordinator. So I'll be texting hall coordinator
you can
personally. If there are any other queries, if I want, I'll post in the faculty group if you add me.
Faculty. Yes.
So can you send me that other link for other faculty to join?
Yes. I'll message it to you. That's everything.
Okay, sir.
Morning I remembered. So yesterday night, then I forgot again. I'll do that.
Fine.
Just keep your WhatsApp on, Dr. Malcolm.
Yes, it's on.
Two minutes to live. So I'll be muting myself from now on.
Yes.
So all the communication will be on WhatsApp with you. And I have made you the co-host. You can see and
Yes.
can admit everyone.
Two of our postgraduates will be there. Ashwati, you can mute yourself and just see that Dr. Raghavendra Rao and Dr. Gata ma'am are informed. Is it okay? Harshit, as soon as you say we can go live, I can start speaking, or you will say like speak, you will message me.
I will message you like 3 seconds before you go live. I'll message you saying speak and you can start.
Once you message me speak, I'll speak.
Yeah.
If you reference joined by last 15 minutes only recording, sir.
Dear delegates, a very good morning to all of you. I welcome all of you to DERMAADVANCE. DERMAADVANCE is a priming program for the exam-going dermatology postgraduates. This is a flagship program of the IADVL Karnataka. As a part of today's pre-lunch session, we will have discussion on cases of bullous disease, leprosy, and a case on genital ulcer disease. We also have a session on spotters and a lecture on how to prepare for a theory exam. During this case, I request the audience to type in and send in your questions via the chat box. These questions will be taken up at the end of the case with our respected faculty. So without further delay, let's begin with the first case on bullous disease. I request the host to connect with the residents and the faculty. Thank you.
So a very good morning to everyone. I welcome all of you to this case discussion on bullous diseases. Our esteemed faculty for this session are Dr. Raghvendra Rao, Professor and Head Department of Dermatology at KMC Manipal, Dr. Sujay Khanpur, Professor of Dermatology at All India Institute of Medical Sciences, Delhi, Dr. Gata M. Upadhyaya, Professor and Head Dermatology Department at Kasturba Medical College, Mangalore. The postgraduate residents who will be participating in the session are Dr. Swati and Dr. Shivam from Kasturba Medical College, Manipal, Dr. Anila from AG Institute of Medical Sciences, Mangalore, and Dr. Anchita from Kasturba Medical College, Mangalore. I now request Dr. Swati, postgraduate resident, to start sharing her screen and presenting the case.
Good morning, everybody. I'll be presenting a case on the topic autoimmune blistering disease. Coming to the history, my patient is a 38-year-old male hailing from Davangere who is a farmer by occupation. He presented with fluid-filled lesions over the body for the past 6 months with recent aggravation for 5 to 6 days. There were painful lesions in the oral cavity for the past 5 to 6 days. My patient was apparently normal 6 months back. He developed fluid-filled lesions over the abdomen first. Then he noted similar lesions over the groin, thighs, and back in a span of 1 week. There were 3 to 4 blisters in a day, the patient noted. The blisters increased in size and rupture occurred in 2 to 3 days. It was associated with trivial trauma or even spontaneously it ruptured. There was serous discharge coming from the lesions. The blisters upon rupture formed raw areas which had a tendency for peripheral spreading onto the normal looking skin. And the lesions were noted over normal looking skin only, and he had severe pain associated with it. He also had painful lesions in the oral cavity for the past 5 to 6 days. It was associated with difficulty in eating and burning sensation. He also had discomfort and burning sensation in the eyes. However, there was no aggravating factor attributed by the patient, be it photosensitivity or no relation with the food. There was no history of the following. There wasn't any prior drug intake to the onset. There was no loss of weight, loss of appetite, or breathlessness noted. There was no blood in urine or blood in stool. The bowel habits were not altered. There was no altered bowel habits of constipation or diarrhea. There was no pain or fever, joint pain or fever or fatigue. There was no itching associated with any of the lesions, and there was no urticated lesions noted prior to the onset. And the lesions did not persist for more than 3 days. There was no predilection for any trauma-prone areas or healing with scarring or milia formation. The patient had taken treatment from outside for the past 6 months. He was put on oral steroid and oral antibiotics. There was improvement, but the improvement was only partial. Upon tapering the steroid, patient developed new lesions. Coming to the past history, there was no history of any comorbidities as diabetes or hypertension. There was no past history of tuberculosis or viral hepatitis noted. The personal history, he consumes a mixed diet with good appetite and sleep. The bowel habits were regular and he had no addictions to smoking or alcoholism.
Yeah, thank you, Swati.
Thank you.
Was there an history of photosensitivity? Did you ask? Was there an history of photosensitivity?
So there was no history of photosensitivity as per the patient.
Okay. I think that was not mentioned there, but anyway, that is also an important history. So, based on the history, what differential diagnosis you want to consider?
So based on the history, I would like to give a differential of autoimmune blistering disorders, mainly pemphigus vulgaris.
Okay.
And
Anything else do you want to consider? There is 6 months history of blistering disease, and the patient had blisters in the skin as well as he had oral lesion. So pemphigus vulgaris is the likely diagnosis. Okay. Anything else that you want to consider? Any other conditions which can be seen in a relatively younger age group in this decade? Pemphigus is the commonest one because the patient had lesions in the mouth and the skin. Do you want to consider bullous pemphigoid?
Bullous pemphigoid. Yes, sir, I can consider because, but yes, sir.
Or any other subepidermal condition?
Which can? MMP also, sir.
The MMP usually starts in the mouth first rather than in the skin. So the other condition is epidermolysis bullosa acquisita, which also can be seen in the 3rd or 4th decade of life. That is the common onset. Okay, but then you said there is no history of trauma-prone blisters occurring over the trauma-prone areas, isn't it? Okay.
Can you consider 1 minute? Can you consider drug-induced pemphigus?
The patient did not give any history of drug intake, and he was not on any drugs prior to this. Like he had no comorbidity, he was not diagnosed with hypertensive.
What are the drugs commonly produce pemphigus-like lesion?
Sir, ma'am, we have like 2 thiol groups and non-thiol groups, ma'am. The thiol groups include penicillamine and AC inhibitors like captopril, and non-thiol group include the penicillin, cephalosporin.
Okay. The patient doesn't give. Yes, sir.
Please go ahead. What's the non-thiol group called? What's that group?
The phenol.
Yeah, patient doesn't give history of any of these drug intake, right?
Yes, ma'am.
Okay. How did you rule out bullous pemphigoid in this? Because your diagnosis after the history was only pemphigus, isn't it? So how did you rule out bullous pemphigoid?
There was no history of itching, and there were no urticated lesions prior to the onset of the fluid-filled lesions.
Okay.
And yes, ma'am.
Age group?
The age group is more seen in the older age group. So he is a younger age group, 38-year-old male.
Okay. What type of blisters did the patient complain of?
The patient complained of blisters, ma'am, which were like flaccid, which ruptured spontaneously or with trivial trauma that did not last for more than 3 days.
Okay. So is that a reason why you considered pemphigus?
Yes.
Blisters. What type of blisters do you get in bullous pemphigoid?
Then we get dense blisters in bullous pemphigoid where the lesions will persist for longer duration of more number of days.
What happens to the lesions once they rupture? Once the bulla ruptures, what happens to the lesion in bullous pemphigoid? What happens to the lesions in pemphigus vulgaris?
The lesions upon rupturing pemphigus will have tendency for pedicel spreading more, whereas in bullous pemphigoid the pedicel spreading will be absent.
What will be the state of the patient? Which type of patients will be sick among the two? Sick.
Which group of patients will be more sick comparatively?
Patients with pemphigus patients, the fatality is more, and the general
they will have more of complications. And bullous pemphigoid usually, if it is mild, it can be self-limiting also. So you won't see that kind of a complication in case of bullous pemphigoid. Yes. So these are the points with which you have come to a diagnosis of pemphigus vulgaris after taking a short history.
Yes, yes.
So, Swati, can you discern from the history what the probable level of the cleft or split is? What are the points on history that tell you what the probable level of the cleft is?
The blister being flaccid, the probable level of cleft will be intraepidermal, sir.
Yeah, so one is the flaccidity of the bullae. Anything else that tells you that the cleft is intraepidermal?
The peripheral spreading, sir.
Right. So peripheral spreading of the erosion is also another point. Now, you mentioned specifically that you found the lesions occurring on normal looking skin.
Yes, sir.
If instead of the vesicles in the bullae occurring on normal looking skin, if they occurred over erythematous base, with everything else being the same, would your diagnosis be different?
So, yes, sir, I will consider EBA more because it is bullous pemphigoid is more in the older age group, and EBA, 15% of the patients will have urticated lesions at the onset.
No. So the question is not on an urticarial base. The question is if instead of the vesicles, unlike this case where they were on normal looking skin, if they were present on an erythematous base, would that have changed your probable diagnosis of pemphigus vulgaris?
So, no.
Can you get pemphigus vulgaris on erythematous base?
Yeah, that is the question.
Yes, sir.
You can get sometime, yeah.
So about 20 to 25% of the cases you can get on erythematous base very commonly. Do you think this 36-year-old age group of an Indian patient with a probable diagnosis of pemphigus vulgaris is an unusual age group?
No, sir. It's predominantly seen in the 4 to 6 decade of life.
Okay. So this is 36-year-old. Maybe if this was seen at the age of 26 or 20 years, would that have been an unusual age group?
Yes, sir.
So you must have seen a lot of pemphigus vulgaris. What's the age group in which you see Indian pemphigus vulgaris? Do you see in elderly patients like the Western population, or do you see it in a relatively younger population in India?
For the Indian population, we see it in a relatively younger age group, sir.
Right. Okay. Please, we can go ahead.
Yeah, we can go ahead with
one question. How did you rule out paraneoplastic pemphigus by taking the history, after the history?
Ma'am, paraneoplastic pemphigus patients will have more systemic features of loss of weight, appetite, or breathlessness were absent, and the lesions will usually start in the mucosal aspect, ma'am. There will be severe mucosal involvement in paraneoplastic pemphigus.
What type of skin lesions do they have?
And they will have a polymorphic type of skin lesions ranging from EM-like lesions or lichenoid eruptions can occur.
But what kind of malignancy usually it is associated with?
And it is associated with non-Hodgkin's lymphoma, CML, thymoma, Castleman's, and...
Okay. Good, go ahead.
And what's the commonest that you see in India associated with paraneoplastic pemphigus?
Non-Hodgkin's lymphoma.
Don't you see the Castleman's disease as the commonest underlying malignancy?
Yeah.
Okay, no problem. Please go ahead. Yeah.
Coming to the examination, the general physical examination was within normal limit and the vitals for the patient were stable. Her weight was 50 kg. Cutaneous examination, the morphology of the lesions comprised of vesicles, bulla, erosions, and crust, and the lesions were distributed in a bilateral symmetrical involvement with involvement of the scalp, back of trunk, upper, lower extremities, and oral cavity. There was relative sparing of the front of the chest with 18 to 20% body surface area. The examination in detail, scalp, he had a solitary erosion with hemorrhagic crusting over the occipital area. In the face, he had multiple discrete as well as confluent erosions with hemorrhagic crusting over the forehead, on the by upper and lower eyelid and the mustache area. He had purulent discharge from both eyes. The back of the trunk, there were multiple erosions with areas of normal appearing skin in between, which involved the entire back. The erosions were of variable size. The smallest one was around 1 into 1 centimeter and the largest one was around 7 into 4 centimeter. The erosions were moist, glistening on an erythematous base. Few of them were covered with crusting, which were hyperpigmented to violaceous, and there was peripheral spreading noted in the lesions. The few of the lesions even showed healing with post-inflammatory hyperpigmentation, and there were areas of re-epithelialization noted in few of the erosions. There were few flaccid bulla, which were discrete, partially collapsed with clear to turbid fluid on the back, predominantly on the lumbosacral part. There was a solitary, partially collapsed bulla on the left upper back, which had a collection of pus in the lower dependent area, classical of hypopyon sign. The front of the trunk, there was relative sparing. The patient, however, the lesions were confined to the lower part of the abdomen, where there was a large, around 7 to 4 centimeter erosion with covered with hemorrhagic crusting, which had violaceous discoloration, with a few discrete erosions at the vicinity of the lesions in the lower part of the abdomen. The involvement of upper limb and had more of discrete erosions which were covered with hemorrhagic crust of the size around 2 into 2 centimeters. The lesions were confined to the upper outer arm on the medial aspect of the forearm on an erythematous base. The lower limb, the lesions were mainly confined to the anterior part of the thigh and medial aspect. There was a large erosion with hemorrhagic crusting of size around 5 into 4 centimeters, with a few crusted erosions at the periphery of the lesions, which had violaceous crusting on the anterior thighs and medial aspect. There was relative sparing of the lower leg and lower part of the thighs. The Nikolsky sign, direct and indirect, was positive in the patient. The bulla spread sign was negative. Coming to the mucosal examination, first is oral cavity. The patient had hemorrhagic crusting on the bilateral angle of mouth and on the lower lip, which can be seen in the figure. In the mucosal aspect of the oral cavity showed multiple erosions of varying sizes predominantly seen on the palate, bilateral buccal mucosa, and dorsal aspect of the tongue. There was also whitish plaque noted on bilateral buccal mucosa. The mucosal aspect of genitalia was normal. The nails and periangularia were normal, not affected. The palms and soles were not affected in this patient. The systemic examination of this patient was within normal limit.
Okay, so Swati, did you do a general physical examination? Did you look at the temperature, blood pressure?
Yes, sir.
Right. Why is this important in this particular case, doing a general physical examination?
Sir, pemphigus per se, the general condition of the patient can deteriorate any time. So we should, the vitals of the patient is very important before we initiate the treatment, as well as when we monitor the patient.
So what are in other words, what are the causes of morbidity and mortality in a patient of pemphigus vulgaris?
Can we ask a question to other students also? Dr. Ankita, can you answer?
Most commonly sepsis, sir.
Yeah. So what changes you would expect in these parameters?
So when there's extensive pemphigus, there's almost like an acute skin failure, isn't it? So then how does one is sepsis? You're absolutely right. Sepsis is the most important cause of significant morbidity and mortality. Other causes?
Shock.
With extensive erosions.
So septic shock because of sepsis. When there is a breach in the skin barrier as a result of erosions and there is a lot of crusting and exudation, can something happen because of that too?
Second is skin
Besides
infections.
sepsis. So yeah, so you mentioned sepsis, skin infections leading to sepsis.
Anything else?
Lot of fluid loss, exudates. What can it lead to?
Electrolyte imbalance.
Right, very good. So electrolyte imbalance is another important cause. Anything else? We like to maintain temperature of these patients, isn't it? Make sure that the temperature around is conducive, it's warm around. So why do we want that? Swati, can you answer that? So any other cause of mortality and morbidity, significant morbidity, that in general measures you need to take care of?
So, secondary infection, septic.
So Anshita has mentioned secondary infection, sepsis, septic shock, electrolyte imbalance. Any other thing you want to add? Something happens to the temperature?
The hypothermia.
Yeah, hypothermia. So there's temperature dysregulation and hypothermia occurs. Okay.
Swati, one more question. In the general physical examination, you didn't mention about the odor, anything, if it is present. In pemphigus vulgaris, usually such extensive erosions, when you enter the patient's room, what kind of odor do you get?
So, ma'am, there is a classical order of pemphigus.
Yeah. Was that present in your patient?
Yes, ma'am.
That should have been mentioned, because usually pemphigus patients will have a classical odor. When you enter the room itself, you will get that odor. Okay.
What's another name for bulla spread sign and how do you perform it? Can we take that to Shiva? You're also answering. Shivam, can you answer that question? What's another name for the bulla?
Bulla spread sign is also called a loop sign.
Is there another more common name for that? Named after this?
Asbo-Hansen sign is there.
Right.
So first, for bulla spread sign, we apply tangential pressure on the bulla, and then we check for the extension, whether it is angulated or it is rounded. So in case it is rounded, it's most probably subepidermal blistering disorder like bullous pemphigoid. In case of pemphigus vulgaris, we see an angulated extension. As for Hansen sign, we apply perpendicular pressure to the bulla, and then we check for the extension.
So before you check for the extension, do you do anything?
Sorry, we mark the margins and then we check for the extension.
And how do you perform the Nikolsky sign?
So Nikolsky sign, there is direct Nikolsky sign and indirect Nikolsky sign. So indirect is also called as marginal Nikolsky sign. So the marginal Nikolsky sign is performed in the skin nearby the erosion, and there we apply a shearing pressure on the skin, and then we check for the skin, which is the split of the skin. And the direct Nikolsky sign is performed on a distant site on a normal appearing skin over a bony prominence.
Which area should you avoid while performing the Nikolsky sign? So I agree with you that you should apply it especially on bony prominences, because the shearing of the skin on tangential pressure would be best appreciated on those areas. Which one should you avoid? Which are the areas where you should never perform a Nikolsky sign?
Genital, like close to the genital or face.
Anything better? Genitalia, we wouldn't usually perform that. Anila, do you want to take that?
On an erosion, is it?
No, which site would you not like to perform So you usually do not perform on distal extremities, because what you're doing is you're creating an erosion, isn't it? By performing the Nikolsky sign, you're artificially creating an erosion. So on distal extremities, you're making that area more, because those areas are more amenable to secondary infection since they are on the distal extremities. So by creating more erosions, you are making the patient more susceptible to infection. There's more breach in the continuity of the skin. So try not to perform the Nikolsky sign on distal extremities.
Swati, you said the diagnosis is pemphigus vulgaris, isn't it?
Yes, sir.
Can you tell me the points which favor the diagnosis of pemphigus vulgaris in this patient?
Yes, sir. My points of view, one is the age group, means younger age group, and as mentioned in the history, the lesions were located mainly in the upper part or upper torso of the body, and they had a tendency of rupturing with real trauma and in a short span of days.
What type of lesions?
Yes, sir. The patient had classical fluid-filled lesions of bulla, erosions,
No,
involvement.
what type? That is also important, isn't it? Is it tense or flaccid?
Tense, also flaccid bulla.
Flaccid bulla, mostly on the seborrheic areas of the body, young patient. And what are the other points?
Sir, involvement of oral cavity is one point in favor of the diagnosis.
Okay.
The demonstration Nikolsky sign in the patient with that lesions is 1 point in favor. Yes, the age group, upper torso distribution, the classic lesions, flaccid lesions, then going on the oral cavity.
Okay. Okay. Now, how will you proceed with this case? These are the important points, isn't it? Important points which tell us that this patient is probably suffering from pemphigus vulgaris. Okay, so you should write down in your exam. Once you write the diagnosis, it is very important to write down the points which has helped you to make a diagnosis. So these are the points in this particular case which will tell us that this is probably pemphigus vulgaris. Okay. So
one question to Dr. Anila. How frequently do you see oral involvement in pemphigus vulgaris? Is it a must?
Very frequently, but it's not a must.
How frequently? What percentage of patients do you see oral involvement?
Oral involvement is seen in around 60%.
Okay, 2/3 of the patients. Usually, do they present with oral involvement first or skin involvement?
Usually with oral involvement first.
It can be anything. Either the patient can present with the oral involvement in the beginning and later on develop the skin lesions, or simultaneously it can be seen. But usually 2/3 of the patients will have a oral involvement.
You know the reason why there is in a majority of the patients there is first oral involvement?
Because of the desmoglein that's present in the oral cavity.
Which is what?
3.
Right.
Yeah, oral cavity is rich in desmoglein 3. That is why most of the patients will have oral involvement. So in about 50% of the patients will present with oral lesions, and almost all patients will have mucosal lesions at one point in time. Though there is a cutaneous pemphigus vulgaris, there is an entity called cutaneous pemphigus vulgaris that is not very common. So most of the patients will have either lesions confined to the oral cavity or mucocutaneous lesions. It is unlikely that they will have only cutaneous lesions. That you should remember. Okay?
Yes, sir.
Yeah.
Thank you, sir.
Dr. Anchita, can you tell me the diseases wherein you see Nikolsky is positive other than pemphigus vulgaris?
We can say false and pseudo-Nikolsky.
Correct. Continue.
Yeah.
Pseudo-Nikolsky site, when there's TEN or Stevens-Johnson syndrome, because of the necrolysis, not because of the acantholysis, we can see a formation of erosion. And in false Nikolsky site, the remnant of the bulla, like in bullous pemphigoid, that will leave erosion. So that we can see.
So Swati, here you have looked at the extent, you looked at the severity of pemphigus vulgaris by calculating the body surface area, which was 18 to 20%. Do you know of other severity scores for pemphigus vulgaris?
Sir, we have PDAI score, abscess score.
What is PDAI? Can you expand?
Pemphigus disease area index, sir.
And what about abscess?
The autoimmune blistering skin disorder intensity score.
Does PDI include only skin or both skin and mucosa? In your department, you're doing PDI more often or the abscess?
So PDI more.
So then, are you aware of? It's a combination of both. So
combination of both.
Both mucosal and cutaneous scoring. Okay, fine.
The investigations for confirmation of diagnosis, just listing out the main investigations. One is a bedside Zang-Smear. Then we can do a biopsy from the lesional from the bulla for histopathology, and biopsy for direct immunofluorescence from the perilesional area. And we can take serum sample for indirect immunofluorescence and also serology for ELISA to determine the anti-desmoglein 1 and anti-desmoglein 3 antibodies. And for initiation of treatment, we should do a complete blood count, the liver function and renal function test, the baseline blood sugars, urine routine, and the chest X-ray should be.
Here, Dr. Anchita, this patient had multiple lesions, isn't it? He had multiple lesions over the back. Now, which site you would choose for histopathological examination and why?
The one with blisters, intact blister.
Yeah, if the patient has got multiple blisters, you have seen the clinical photos. So, fresh lesion, fresh blister, isn't it?
And whether would you choose a vesicle or a bulla?
Vesicle.
Right.
What will happen if you choose a whole lesion? Why you should not choose whole lesion?
The immunoreactants may be consumed.
No, this is histopathological examination, isn't it?
Inflammatory infiltrate will be there, so there will be increase in infiltrate, so the cleft may not be visible in biopsies.
Why would the cleft not be visible in a biopsy of an old lesion?
Increase in inflammatory infiltrate.
So how would the increase in the inflammatory infiltrate have a bearing on whether the cleft is present or not?
Shivam?
Sir, in case of an older lesion, there can be reepithelialization.
Yeah,
so the slit cannot be easily visualized and determined where exactly it is.
Yeah, that's because of the reepithelialization rather than inflammation. Okay, yeah, good.
Shivam, can you tell me how to do a Zank smear?
Okay, ma'am. So for a Zank smear, we take a blister and we de-roof it, and then we empty the blister and we scrape the floor with the blade, and then we take the contents and we
only the floor or even somewhere from somewhere else? Floor and under surface of the roof.
Yeah, okay. Yeah. Then we take the contents and put it on a glass slide, and then we smear it. Then we fix dry it. Then stain it with Giemsa stain. Stain it for 30 minutes, and then we examine.
How do you do Giemsa? Tell once again.
Giemsa stain, ma'am. We prepare a fresh solution of Giemsa stain is taken, and then we stain it for 30 minutes. Then
how much do you pour the whole Giemsa content of the bottle into the slide, or how?
Diluted solution of Giemsa stain is taken, ma'am, and fresh prepared diluted solution of Giemsa stain.
How much dilution?
1:10 dilution.
Right. Yeah.
Okay. How long will you keep?
30 minutes it is kept on.
Different people.
You can keep it for 10 minutes also.
10 to 15 minutes. Yeah. Usually one drops of Giemsa, 10 drops of water, keep for 10 to 15 minutes. Okay. Then after that, what do you see in the Zank smear?
Ma'am, in case of pemphigus disorders, we look for acantholytic cells. And so acantholytic cells will be actually the keratinocytes, the rounded up keratinocytes will be visible with condensed nucleus and hypochromatic nucleus, perinuclear halo, and a condensed rim of cytoplasm. Basophilic cytoplasm will be visible.
Okay. What is this acantholysis due to? What is acantholysis actually?
A separation of keratinocytes. So because the keratinocytes have separated, they
why do they get
rounded.
separated in pemphigus vulgaris?
So because the desmoglins connection is lost. So because the side-by-side connections of the keratinocyte is lost, so they get separated and then get rounded up because they have lost their integrity. The intracellular integrity is lost, so they become rounded, and the nucleus also becomes hyperchromatic and condensed.
What are the types of acantholysis you have heard of?
There's primary acantholysis, a secondary acantholysis, and there is one drug-induced acantholysis also.
Where do you get primary? Where do you get secondary acantholysis?
So primary acantholysis we get in pemphigus group of disorder, and in secondary acantholysis we get in infective conditions like herpes simplex virus, chickenpox.
Okay.
And
do you get primary acantholysis only in pemphigus group of disorders, or can you get it in others also?
Diarrheal disease in Haley.
So what's that group of conditions called?
What is the characteristic histopathology?
The core round formation is.
No, what are they called as? One word for that.
Dyskeratosis.
Yeah, correct. Dyskeratosis.
Right. So
dyskeratotic disorders, isn't it?
So just one quick question regarding Zank. So we know that the Zank cell or the acantholytic cell is a keratinocyte. Anila, what is the shape of a keratinocyte normally? Swati?
Polyhedral.
Right, they're polyhedral in shape. Then why is an acantholytic cell rounded? Why is it a round cell? Anila, Shivam, do you want to try?
Yes, sir. Actually, the desmosomes are the intercellular connections which are there. So, because the intercellular, the cellular structure is structural integrity is lost. So, the best structural integrity is maintained when the cell is rounded. So, that is why in case from polyhedral, they become rounded in shape to maintain the structural integrity.
Yeah, so any structure that loses its support always takes the shape of a structure which has the least surface tension. And we know from our physics knowledge that a sphere has the least surface tension of all geometric shapes. And that's why our keratinocyte, when it loses its support, it takes the shape of a circle or a rounded cell. Direct immunofluorescence, what is the appropriate site from where you do the direct immunofluorescence, Swati?
Direct immunofluorescence we should take from perilesional skin.
Perilesional. Any other you want to specify besides just any other adjective you want to add?
From a normal looking.
Yeah, that word should come, isn't it? Perilesional, normal looking skin.
Why don't you take from the blister? Why don't you take the biopsy for diff from a blister?
The immunoreactants will be washed, used up in a lesional skin.
Yeah, reactants would have been consumed. You will not be able to demonstrate them in the lesional skin.
Swati, when you take a biopsy, you will take two samples, right? One for histopathology, one for DIF. So which one will you pick up first? Whether you will pick up the DIF sample or histopathology sample?
We should first do DIF first, because if we do biopsy for histopathology first, there can be a chance of formalin contamination. Yes. So ideally, we should always start to do a DIF biopsy first.
How do you send this DIF sample?
Ma'am, DIF sample can be sent in Michel's medium, and we can also send in normal saline, but it should be used within 24 hours. The Michel's medium, ma'am, we can ideally it can be used up till 4 weeks, but it can be used up till 6 months. And then we also have this honey.
Yeah, you're right.
What does this Michel media contain?
Ma'am, it contains sulfate salts of magnesium, ammonium, citrate, distilled water.
So, Swati, are you doing indirect immunofluorescence in your department?
Yes, sir, we are doing, sir.
What is your substrate that you're using?
So we are using the human skin.
Which human skin would you use?
So either sometimes we take it from the
normal human skin.
So what is the ideal substrate? Yeah. So normal human skin is what we are taking these days, if at all one wants to do an indirect immunofluorescence. But what is the actual substrate for IIF?
So monkey esophagus for pemphigus vulgaris.
Right. Why are you not using monkey's esophagus?
Because of the ease of available.
Yeah, because the rules now don't permit you to take animal models, use animal models for investigations. The government doesn't permit that. So now you're not using animal substrates. Okay.
Which condition do you prefer to use a rat bladder?
We prefer in paraneoplastic pemphigus, sir.
Why do you want to use rat bladder there?
Transitional epithelium.
Yeah, right.
So then how does that help with this transitional epithelium?
So there is expression of desmoplakin, periplakin also in transmission epithelium. That is why.
Can you tell their molecular weights?
Swati, do you know what is the molecular weight of desmoglein and desmoglein 1 and 3?
For desmoglein 1 and 3, sir, I can tell us 160 and 130 kilodaltons.
And the antigens of paraneoplastic pemphigus?
The antigens of paraneoplastic will be desmoglein 1 and 3, enveloplakin, periplakin, and then BPAG 230, sir.
It's very easy to remember. They're all odd numbers in that way. So it's 170, 190, 210, 230. You know, it's like that.
So just increase by 20 values, that's all.
Yeah.
Dr. Anila, what do you see in the biopsy in this patient?
Will be a suprabasal split with root appearance.
Dr. Anchita?
Stone appearance
And
of
sub.
the basement membrane.
Anchita?
Stone appearance of the basement membrane keratinocytes along with suprabasal site. These are characteristic of pemphigus vulgaris.
Can you name some other conditions where you see suprabasal blisters?
In IgA pemphigus, we can see Darius disease, Haley disease.
Haley. What is Haley disease?
Autosomal dominant 2C2 calcium channel.
What is the other name? Other name for Haley disease?
Benign familial pemphigus.
Benign chronic familial pemphigus.
Anila, do you agree with suprabasal cleft in IgA pemphigus?
Yes.
Shivam?
It is subcorneal split there.
So that's one variant. The
What are the
variant.
types? Other type? There are two types, isn't it?
Yes, IgA intraepidermal neutrophilic pemphigus. They have two types. So there is a subcorneal pustular dermatosis type and intraepidermal neutrophilic type.
Not intra.
Intraepidermal.
Intraepidermal, IN type and SCPD type, isn't it?
Yes, yes.
So sorry to interrupt, sir. We have another 7 minutes so that we can discuss the management treatment.
Yeah.
Okay. So how would you manage this case? You did not, in your list of investigations, you did not mention serum electrolytes. Is that an important investigation to be undertaken? Swati?
Yes, sir. It is important.
Yeah, and we've discussed this point. Because electrolyte imbalances can occur in these patients with extensive disease. Okay. What is the commonest treatment that you are initiating in patients now with extensive pemphigus vulgaris?
So we're initiating oral steroid, corticosteroids, and along with rituximab infusion.
So are there any additional investigations that you should do as a baseline for initiation of treatment?
Yes, sir.
That you have not mentioned in your list?
Yes, sir. We have to do a cardiac evaluation with ECG, echocardiography, and then we should do viral markers for the patient of hepatitis, HBsAg, and anti-HCV.
Okay. Any other viral marker that you should now do? It's often not done because it's not easily available, but it should be done. And any particular reason for that? Shivam?
Sir, pertaining to rituximab, you're asking, sir?
Yes.
So is it JC virus due to HIV, HBsAg, anti-HCV we do, and then
yeah. So for hepatitis B, do you do anything else?
Core antigen.
Anti-HBE.
Core antibody. You do hepatitis B core antibody because sometimes hepatitis B surface antigen negative can show reactivation of hepatitis B upon rituximab because your core antibodies may have been positive, which were not done. So why do you do an echo ECG? Why are you doing cardiac evaluation?
So during the infusion, the patient can have develop arrhythmias. So a baseline echo is mandatory.
No, that's not an important cause. We hardly, if patient is arrhythmias don't happen to just any individual like that with rituximab. What is the main reason for a cardiac evaluation as a baseline for rituximab? which may not pertain to your 36-year-old man. You know, it's usually would be more beneficial if this patient was, say, an elderly individual. What is a cardiac contraindication to rituximab? Shivam?
No, sir.
Sir, hypertension and congestive heart failure.
Good. Congestive cardiac failure stage 3 or 4 is a contraindication.
Yes.
1 and 2 can still
Yes,
be.
yes.
There will be fluid overload, isn't it? That's why you want to get a cardiac opinion.
Swati, what is this rituximab?
Rituximab is anti-CD20 monoclonal antibody.
Okay. How do you use rituximab in pemphigus vulgaris?
Ma'am, in our department, we follow the rheumatoid arthritis protocol where we give infusion of 1 gram, 1 grams, which are given at 2 weeks apart.
How do you infuse?
Ma'am, we in the glass bottle we take in 500 ml normal saline we discard the 50 ml, and to the 450 ml we add the rituximab infusion, and it is given with proper monitoring of blood pressure, heart rate, and vitals. And we start at 50 mg per ml dose, and then we increase 50 ml.
Not mg. Okay.
50 ml we start, then we increase it every half an hour. We increase by 50 ml up to a maximum of 200 ml per hour.
So then the first instance, in how many hours would you finish the infusion? The first of the 2 doses.
We take up to 3 to 4 hours it takes for the infusion to get over.
Shivam?
6 hours it takes.
Yeah, it takes 6 hours, 5 to 6 hours. And if there is no side effect, there is no infusion reaction in the after the first infusion, then in the second, over how much time would you infuse your rituximab?
Then we would start at 100 ml per hour, sir. The starting, instead of 50 ml per hour, we start with 100 ml per hour.
So you finished the infusion in how much time?
Around 3-4 hours we finished.
Swati? So 2 hours. Within 2 hours, you can finish the infusion in the second if there's no problem with the first.
Dr. Anchita, if you are planning to give, not planning, you will be giving steroid. So how much of steroid will you give, and what are the complications do you expect in this patient?
We can start the patient on 1 milligram per kg per day, ma'am, for this patient. And initially, we have to maintain this dose till at least 80% of the old lesions have healed, or there are no formation of new lesions. And then we can taper up to 50% after there is no formation of new bullet.
How do you taper?
By 50%, ma'am, after 2 weeks.
Then
continue this tapering dose and monitor for.
How do you add anything else when you are tapering the steroid?
Yes.
Talking about this particular patient.
Non-steroid.
Steroid sparing drug. Yeah. Which steroid sparing drug which you would like to add?
I want to start this patient azathione.
Okay. Anything else? Cyclophosphamide. How much of cyclophosphamide do you want to add? You are not audible.
1 to 2 milligram per day we can start.
What are the side effects do you expect with this cyclophosphamide? So, are you doing per kg body weight in terms of daily oral cyclophosphamide? So, if this patient was what was the weight? 60 kg, right? Wouldn't you start on a specific one dose of 50 milligram once a day?
Yes.
You're strictly giving it per kg body weight. Is that what you're doing?
What do you do in our setup?
We start the patient on 50 milligram and evaluate the lesions, and then decide if we want to hike up the dose.
That's right. Yeah.
When do you give the cyclophosphamide? In the morning or in the night? And
Morning,
why?
Morning, ma'am.
Why? Why do you give the cyclophosphamide dose in the morning? Why not in the night? What is the important side effects of cyclophosphamide? I can't hear you.
Hemorrhagic cystitis.
Okay. So, what happens if you give the dose in the night?
Patient is advised to take a lot of water, and so we can flush that
Okay, night, usually they don't drink a lot of water and urine get concentrated in the bladder and then the complication worsen. Whereas if you give the tablet in the morning, they can, take lot of water and then drug can be washed out immediately. So you have to give it in the morning. Any other steroid sparing drugs you can use in these patients? You have told about azathioprine, you have told about cyclophosphamide. Anything else? Dr. Anila, can you just add up? Dr. Anila?
Mycophenolate mofetil.
Okay.
Cyclosporin.
Is there any other inexpensive agent that you can give in a non-affording patient? Because
Methotrexate.
Yeah. Okay.
Methotrexate.
Yeah.
Right. So what's the final treatment protocol that you're going to do in this patient? Patient is continuing to get new lesions every day. And you also mentioned in your history that upon tapering of the corticosteroid, patient again showed recurrence. So based upon these, what would be your treatment protocol? Swati?
So in this patient, we have started the patient on 60 milligram prednisolone, and we have administered rituximab 2 infusions, which were 2 weeks apart, which led to good clearance of all the lesions.
So in case if the patient can't afford rituximab, what is the other alternative? When the patient continues to get new lesions, but he can't afford to buy rituximab.
So we can give pulse therapy.
Okay, what is the name?
Dexamethasone pulse therapy.
Dexamethasone plus. Do you want to give cyclophosphamide also in this patient?
No, so patient is 38-year-old male, and the chance of gonadal failure is.
He is unmarried also, so you don't want to give cyclophosphamide, isn't it?
Yes.
Sujay, you're asking something?
Yeah, that's what I was asking. What was your decision based upon between giving DP versus DCP?
Yes, sir. DP, because of gonadal failure, we prefer DP over DCP.
So this individual was unmarried, so you're preferring DP. Okay. Are you adding non-steroid sparing immunosuppressive agent to this protocol of rituximab plus tapering doses of oral corticosteroid also, or you're not doing that?
Patient was maintained on steroids alone, sir.
So what will you do, say, after 6 to 12 months when the patient would develop a relapse? Because by that time you would have tapered and stopped the corticosteroid, and rituximab is effective for on an average, about 9 to 12 months. And the patient can again relapse.
Yes, sir. So we should give a second cycle of rituximab. If the patient is affordable, we can give 1 gram. If the patient is not affordable, we can even give a low dose of 500 milligrams.
So is there any disadvantage if you add a non-steroidal immunosuppressive agent right away from the beginning to your protocol?
Ideally, you should add one of the non-steroidal and azathioprine, mycophenolate. But in this patient, we have not given because his counts were on the lower side. So we did not want him to develop side effects once he goes home. So that is why we wanted to wait for 1 month.
Have you in any way changed your protocol during COVID times?
So we have given rituximab during COVID also.
Yeah, there is no need to change the protocol. Absolutely no need.
So as we conclude this session on bullous diseases, I would Dr. Raghvendra.
So we have Dr. Raghavendra Rao, Dr. Sujay Kanpur, and Dr. Gata ma'am, who will be addressing few of the audience questions that we have received. So the first question is for Dr. Gata ma'am. Ma'am, you have nicely highlighted the importance of noticing this presence of odor in a patient of pemphigus. So one of our delegate wants to know what is the mechanism of mousy odor in pemphigus.
Join the video. Sorry, he has not joined the video.
Ma'am, can you unmute?
Please unmute, madam.
Ma'am, can you unmute? Yeah, yeah. Now can you answer, ma'am? Yeah. You're unmute. Can you unmute, ma'am? No, ma'am. It's not audible. Yes, ma'am.
Now?
Yes, ma'am.
Am I audible? Yeah.
Yes, ma'am. Yeah.
Yeah, it's a nice question. Actually, even we don't know the answer clearly. It's not been described in any of these textbooks, the actual mechanism, but probably it is because of the colonization of the lesions by the bacteria, probably a Vincent's organisms or any other bacteria. But the same question arises when there is a toxic epidermal necrolysis or SJ, Steven-Johnson syndrome. When there is a lot of erosion, why don't we get this odor? So the actual answer is still not known. But most of the patients with severe pemphigus vulgaris will have the mousy odor. Same time, I would like to ask the participant, what are the other conditions wherein you get some specific odors? It may be dermatological disease or non-dermatological disease also. Do you get any specific odors in any other diseases?
The audience will not be able to answer because they can only put in the questions. Yes.
Okay, okay. Diabetic ketoacidosis, you may get fruity odor, or in uremic conditions, you get a specific odor of amino acids or urine odor. So these are some conditions wherein with the odor we make the diagnosis.
This question is for Raghavendra Rao, sir. Sir, in the management of pemphigus vulgaris as a second-line immunosuppressive, what is your best option and choice between azathioprine, mycophenolate mofetil, and cyclophosphamide?
Dr. Raghavendra Rao is not able to unmute, I believe. You may invite Dr. Sujay Kanpur.
Sujay, sir, can you answer this question?
Yeah. So if the patient's family is not complete, then my choice is azathioprine because it's a good immunosuppressive. It's inexpensive. If the family is complete, then cyclophosphamide can be given instead of azathioprine. Now, the advantage of cyclophosphamide over azathioprine is that it is more rapidly acting. The effect of cyclophosphamide comes earlier than azathioprine. However, in terms of safety profile, that of azathioprine is better than cyclophosphamide. Now, mycophenolate mofetil in a resource-limited setting as ours, for me, is the third line. The reason being that the efficacy of MMF is absolutely similar to azathioprine. The only advantage is that the safety profile of MMF is significantly better than azathioprine, which means obviously patients who have hematological or liver dyscrasias, we would prefer MMF over azathioprine. The other advantage of MMF is that the oncogenic potential of MMF is very, very low. So MMF can be given for very long periods of time. Other than that, if the patient's basic condition is okay, then I would prefer azathioprine over MMF because it is significantly cheaper.
And this question is for you. What are the clinical clues by which you can distinguish oral pemphigus vulgaris without cutaneous lesions versus an erosive LP?
This is a question to me?
For Gata.
Okay. Oral lesions in pemphigus vulgaris and erosive LP.
Yes.
Only oral lesions, maybe it is difficult, but along with the erosive LP, there may be lacy pattern or reticulate pattern. And pemphigus vulgaris, the lesions may be a little more deeper because there is a bulla which ruptures and maybe it is very painful also. But with only the oral lesions, it may be difficult to differentiate between the two. Maybe we will have to wait for the cutaneous lesions to develop.
So this question is for you. In spite of dermatitis herpetiformis, it's a subepidermal disorder. When most of the other subepidermal disorders present with the tense large bullae, why in dermatitis herpetiformis the lesions are relatively smaller in size and more of papillovesicles rather than the tense large bullae which you probably find in bullous pemphigoid or cicatricial pemphigoid? Sujay sir?
Yeah. So the answer is that if we look at the histopathology of DH, we will see that there are micro tip abscesses, the papillary tip abscesses. So a small vesicle is present only at the papillary tip in majority of the cases, and that translates as small papillovesicular lesions clinically. Unlike in cases of say linear IgA dermatosis or bullous pemphigoid or EBA, where there is a large subepidermal cleft, even histologically, that manifests clinically as a large bulla. Now, having said that, it is not sacrosanct that that all the lesions of dermatitis herpetiformis would be small vesicles. You can occasionally have larger vesicles to a bulla even in DH, which would translate histologically as a larger subepidermal cleft. So, because of the small size of the cleft in DH, in majority of the cases at the papillary tips, does it manifest as papillovesicular lesions.
Thank you, sir. This question is for Gata ma'am. What are the clinical indicators which basically indicate the progression of pemphigus vulgaris and that you may have to hike the dosage of steroids in a patient who is coming for a follow-up?
Main thing is the development of newer lesions. If the patient is admitted in the hospital, maybe you can do this by marking the existing lesions every day, and you can puncture the lesion so that the next day there will be collapse of the blisters. So if there is a new blister, you will know, because unmarked blister will be the new blister. So depending on that, you can make out that the patient is developing newer and newer lesions. So that is an indication to hike the dose. Then when the patient, if the patient is discharged and he's sent home and he comes back with the symptoms, maybe again the newer lesions and maybe the status of the patient, if he is becoming more sick or maybe other complications, maybe have to increase the dose of steroid. But it is mainly by the clinical findings that the patient develops newer lesions.
Thank you, ma'am. So this question is for you. In a patient of extensive pemphigus vulgaris, suppose he develops a steroid-induced central serous retinopathy, which is a relative contraindication for further steroid usage. What would be the best option in these patients to manage them with immunosuppressants if he's developed central serous retinopathy secondary to using steroids?
Yeah, if the steroid is a contraindication, maybe you have to go for a steroid sparing drugs like cyclophosphamide. Again, you will have to see what the age of the patient, whether the patient is young or old. So depending on the age, maybe you can use cyclophosphamide if the patient is not too young. Maybe you can use azathioprine, you can use mycophenolate mofetil. So there are other steroid sparing drugs which can be used in these patients. Even rituximab is a good alternative if the patient has very extensive lesion and steroid is contraindicated. So some of the other non-steroidal anti-inflammatory, steroid sparing immunomodulators can be used in these patients in whom there is a contraindication for oral steroid.
Sujay sir, any additional input?
Yeah. IVIG is another agent because I completely agree with Dr. Gatha. The non-steroidal anti-inflammatory agents are a little slow to act. So it takes about at least 2 to 3 weeks for the action to come. And we recognize that we add the initial oral corticosteroid because we want rapid action. Now, when there is a contraindication to corticosteroid usage because of the central serous retinopathy, yet we want a rapid action because there is a continuous increase in the number of lesions or extension of the existing lesions, IVIG acts as an agent which acts very rapidly. So unlike rituximab, where the action comes in about 3 weeks, the action of IVIG comes within a week. The only disadvantage of IVIG over rituximab is that the relapses following IVIG is quicker as compared to rituximab, and therefore we may, if the activity of the disease is too much, then IVIG may have to be periodically infused monthly. But IVIG is another agent, and in most of the government hospitals in Delhi, in army hospitals, military hospitals in Delhi, IVIG is intended from the hospital.
Resume with the next program shortly, so stay tuned in.
With this, we have come to the end of the session on the Bullous disorder. The next session will be a lecture which will give us an idea about how to write a theory exam. There is always a mismatch between what an evaluator wants and what a resident writes. So this is the usual thing, and that's why somebody with high knowledge and may not score a good amount of marks as expected by him. But as somebody with a fairly average amount of knowledge can probably score very high in the examination. The reason being the skill of writing the theory examination. To tell us more about it, so we shall connect with Dr. Malcolm Pinto, who will be telling us about how to write in the theory examination. Could we connect with Dr. Malcolm Pinto, please?
Dear students, I welcome all of you to this topic on how to prepare and write a theory in dermatology. Let's begin with the preparation part. These are the different resources which are available for preparation in the form of textbooks, journals, notes made by you or by your seniors, the different seminars which have been presented by you and your colleagues in the department teaching program. These are the different textbooks which are available for preparation, and I'm sure you've already decided as to which is your primary source of preparation. Now, the most common mistake which students make is due to time constraints, they tend to change their primary source of preparation. Always remember this point. Read a given topic from the same source till the exam. If there are any pending topics which due to time constraints you're not able to read from your primary source, only such topics should be read from a different source. These are the different journals which a student should go through during his postgraduate life, and in these journals I want you to focus on two important sections, review articles and residence page. So these two important sections of a journal provide comprehensive information, and many times questions are picked from these sections of a journal. How to read from a given source of information? The first method is make your own notes. Due to time constraints, from now on it may be difficult, but if you have made your own notes, that should be the best form of preparation. You can add extra points to the main textbook that you have chosen. For instance, if you take this example of IADVL textbook, if you go through this section on Porphyria cutaneous tarda, you will find that two important points, caterpillar bodies and festooning of the dermal papilla, are not included in the textbook. So what you can do is you can use sticky notes and add them on to your main text. Similarly, another method of doing this is using paper clips. You can attach pieces of information in the form of slips of paper. Here you can see an example of the Alarcon-Segovia criteria for MCTD, which is not mentioned in the book. So this will make your book comprehensive and all the information will be present at a single place. The third method here is most of the students nowadays are very comfortable with reading online or through PDFs rather. So you can also go for e-notes taking, summarizing the key points. Now this is important because there is a lot of content, and the day before the exam, if you want to revise, if you summarize the important points, you'll be able to easily go through the textbook and remember key points which are necessary for the exam. Let's now discuss specific preparation strategy. When you're preparing for the paper on basics in dermatology, you should be ready with diagrams for structure and ultrastructure of the various components of the skin, structures of the causative organism of various dermatological diseases. You should also be thorough with the various laboratory techniques, and immunology should be very strong. Always go through recent guidelines for treatment. For instance, if you see, the treatment of gonococci has been improvised on, and according to the CDC 2020 guidelines, the dosage of ceftriaxone now is 500 milligram IM based on the weight. And how do you prepare for the paper on recent advances? So these are the important topics which could be potential questions in the exam in the form of dermatopharmacology, where questions can come from biologics and small molecules like apremilast or jacquinets, artificial intelligence or nanotechnology, cutaneous manifestations of COVID-19, advances in the management of bullous diseases, teledermatology or reflectance confocal microscope. Some important tips on studying. The first point is study less and learn more. What this means is many students tend to read a lot of information, but what you're doing is you're not actually learning it. Learning means understanding the topic and retaining it. When you revise topics, see that you don't selectively revise those topics which you are comfortable with. Many times the easy topics are revised again and again, and the tough topics are left till the end. So this is something which you should abstain from. Space your revisions well so that you'll be able to recollect topics well. The next important mistake which most of the students do is whenever there is a source of information, they just tend to read the information and assume that they remember most of the things. So this is called as passive recall. What you need to really do is you need to close your book and start indulging in active recall. So active recall is much more powerful and much more effective than passive recall of information. Taking adequate breaks is very important to prevent a breakdown, which could be in the form of emotional, physical, or a mental breakdown. We move on to the next part on how to write a theory paper. Theory paper writing is an art, and this is something which you need to learn so that you do well in the examination. I will be discussing general principles and specific question-based approach. The most important aspect of an exam is time management. Most of the students will be writing a theory paper after a gap of almost 3 to 4 years. One thing which all of you need to remember here is the maximum time that you can allocate for a 10-mark question is 60 to 18 minutes. For a 20-mark question is 28 to 30 minutes. If the stipulated time for a particular question is over, you just need to leave adequate space at the end of the question and move on to the next question. So at the end of the exam, you can fill into these spaces and make your answer complete. Avoid paragraphs or lengthy sentences. Let's take an example of this question on cafe au lait macules. This is how most of the students would represent their answer in the exam. They would write what is a cafe au lait macule, what is the size variation, what are the associations, what is the histopathological finding, what are the types of cafe au lait macules, how do you diagnose it in the case of NF1, and what are the treatment modalities available. The better way of representing the same answer with the same content is by using structured subheadings. Once you divide your answer into definition, types based on the margin, associations, criteria for the clinical diagnosis of NF1, histopathological findings, and treatment, this type of method is going to have two important advantages. Number one, as a student, it gives you more time to write more content. And number two is it enables an examiner to easily go through the points, and thus you're likely to get more marks than a student who tends to write more in terms of a paragraph type of pattern. There are two types of flowcharts. One, the ones which are given in the textbook. Number two, you can make your own effective flowcharts. Let me now give you an example of a textbook flowchart. Now, this is a flowchart which I picked up from Bologna's textbook of dermatology. This talks about approach to a palisaded granuloma based on the type of infiltrate, based on the location of the infiltrate, and based on special features in the form of horizontal tires or prominent cholesterol clefts. You can actually answer 6 questions in the exam just through a single flowchart. Number 1, palisadal granuloma. Number 2, granuloma annulae. Number 3, annular elastolytic giant cell granuloma. Number 4, rheumatoid nodule. Number 5, necrobiasis lipoidica. And number 6, necrobiotic xanthogranuloma. The next type of flowcharts are the ones which you have made from your understanding of the subject. Now let me give an example for immunopathogenesis of psoriasis of a flowchart which I have designed. The NK cells and the plasmacytoid dendritic cells stimulate and activate the myeloid dendritic cells via different cytokines, and via the interleukin 12 and 23 pathway, Th1 and Th17 subset of T cells get activated. They liberate their respective cytokines, which in turn are going to activate keratinocytes. Now the same flowchart I'm going to use to remember the biologics in psoriasis. Ustekinumab, the TNF alpha blockers, the interleukin 23 inhibitors, and the interleukin 17 inhibitor. Next important point is to draw diagrams. First important principle here is to draw simple and easily reproducible diagrams. Let me give an example from Lever's histopathology textbook. This book provides the easiest possible diagram of the ultrastructure of the desmosomes, which you can easily represent and you can easily remember in the exam, and it's very simple to draw as well.
Hello.
The next important point here is
Madam,
to
I'm in
label
a
structures
meeting.
properly.
I will
Now you can see in this
meeting.
picture that anchoring fibrils have been wrongly labeled as anchoring filaments. So see that you label the structures properly. Whenever a question is asked on a laboratory technique, the best way to represent the answer is diagrammatically. Now here in this example, you can see that the different types of ELISA have been represented. The best source of this information is Google Images. So you go through the different images which are there on the internet and choose the easiest possible image. And what I would recommend here is you make a separate notes book wherein you draw all these important images. So the advantage is on the day of the exam, you'll be able to just go through it fast. And number 2 is whenever you're bored and saturated with your preparation, it's very easy to practice or go through diagrams. Whenever there's a question on histopathology, there should be a diagram in the exam. So see that you represent the epidermis and dermis and mark these structures adequately. The next important point here is to highlight in the exam so that you can draw the examiner's attention. So this can be achieved by either underlining, using inverted commas, or by capital letters. Though it's a theory exam, always think practically. If a question is asked in the exam, always arrange the causes based on the importance and always mention the common causes first and the rarer causes towards the end. For example, if there is a question on acantholysis, you should not be mentioning Grover's disease as the first cause. Always begin with the pemphigus and the pemphigus group of diseases and then move on to the other causes. Read the question properly. Many times what happens to students is due to anxiety or excitement, when they read the question partially, they come to a wrong conclusion and write a completely different answer. So this is an example where the question in the exam was fluorescent leprosy antibody absorption test, where most of the students marked it and wrote the answer as fluorescent treponemal antibody absorption test. Beware of synonyms. Many examiners like to use unfamiliar or uncommon names for diseases which you commonly know in dermatology. Urbach-Wiethe disease is the other name for lipoid proteinosis. Gom-Button disease is the other name for Sweet syndrome. And calcifying epithelioma of Malherbe is the other name for pilomatricopa. These are some common points which are missed out by students in the exam. Whenever clinical features are asked, you should make a note on differential diagnosis and write as to how do you distinguish it from the condition which is asked. Nowadays, dermoscopy is very important and you should try to incorporate dermoscopic findings in the investigations as well. And whenever treatment is mentioned, do write the name of the drug and try to mention the dosage per kg body weight with important side effects and monitoring guidelines whenever a particular disease is asked in the exam. Finally, don't leave any question blank in the exam. Try to think as to which chapter the topic is asked from. Try to draw structured subheadings and you will be able to write something about this particular topic. So moving on to a specific question-based approach in the exam. If the question is asked on the exam regarding differential diagnosis, let's take an example of clinical approach to a patient with a verrucous plaque on the foot. What you should do is you divide your answers like this. First, you classify the causes of patients with presenting with verrucous plaque on the foot, the points in the history, points in the examination, describe individual conditions, and mention about salient investigations and treatment. Now, first, what you can do is you can classify the causes of verrucous plaque on the foot into infectious and non-infectious, then viral, bacterial, and fungal. Under non-infectious, you can mention the eczematous disorders, papillospermous disorders, disorders of the blood vessels and lymphatics, malignancies, and miscellaneous disorders. When you're mentioning history, you need to mention points like duration of the disease, wherein you have to write longer duration is going in favor of chromoblastomycosis or elephantiasis verrucosa nostra cutis. Mention about why history of trauma is necessary, which conditions are pruritic, which condition can have associated atopy, why history of lymphedema is necessary, and history of arthropod bite going in favor of prurigo nodularis, and history of previous infection of tuberculosis going in favor of TBVC. So most of the students, what you do is we just mention what are the points to be written. You don't mention as to which disease is it indicating. So this is something which you need to incorporate in the examination. Approach can be followed in terms of the examination findings as well. Black dots are a feature of chromoblastomycosis, lymphadenopathy for melanoma, Kaposi stemmer sign for elephantiasis verrucosa nostra cutis, fissures for TBVC, loss of dermatoglyphics for verruca vulgaris. So always mention the finding and for which corresponding disease is it a clinical clue. So similar points can be made even for investigations and treatment as well. If a question is asked on procedural dermatology, it could be a clinical procedure or could be a cosmetic procedure. These are the important points which you need to focus on the exam. You define the procedure, how is it classified, what are the principles, and mention few general points like consent taking, documentation, photography, and counseling. So these are important points which you can include for any answer in the exam. And then you have to mention the indications. Indications can be further subclassified into aesthetic indication. If acne is an indication, which stage of acne, you can classify the indications. Mention the contraindications, and pertaining the procedure, you have to mention pre-procedure, the assessment and the workup which you're doing, how exactly you are doing the procedure, and post-procedure, what things need to be kept in mind and how will you follow up the patient. And always make a note on the complications of the procedure, which generally are classified into immediate complications and the late complications. If a question is asked on a drug in the exam, these are the subheadings under which. If a question is asked on a drug in the exam, these are the subheadings under which you will write the question. Classify the drug, mention the mechanism of action, pharmacokinetics and pharmacodynamics, route of administration, the formulations which are available and the dosing schedule, indications, contraindications, important drug interactions, side effects, and the pregnancy status. So if these structured subheadings are used, all the points will come into mind and you'll be able to write a comprehensive answer in the exam. Citing an example from Wolverton's textbook of dermatology, the best way to depict mechanism of action is again a image, wherein you can see in the first image how normally cyclic AMP is converted to AMP by phosphodiesterase 4, which increases pro-inflammatory cytokines and decreases anti-inflammatory cytokines in an inflammatory cell, whereas apremilast, by blocking this phosphodiesterase 4, how it produces the reverse effect. So finally, to conclude, most students in this phase tend to read theory exclusively and they lose practical touch. So see that you keep seeing and presenting at least a few cases in this phase as well. This will help you to write better answers in the exam and be oriented for practicals as well. I thank the staff and the postgraduates at Yanapoya Medical College, Mangalore for their help in this presentation. I wish all of you all the very best for your exams. Thank you.
Thank you, Dr. Malcolm. We will resume the inauguration shortly. Stay tuned.
Musabba sir, please join sir with video.
When I say speak, no, you click this and start speaking. Speak. Start.
Good morning, everyone. I welcome you all to the inauguration of DERMAADVANCE 2021. DERMAADVANCE is a unique program which is conducted by IIDVL Karnataka, where actual case conferences are held with involvement of the residents and best of faculty across India. I now request Dr. Manjunath Shenoy, Head of the Department of Yenapoya Medical College and the organizing chairman of this program, to welcome the gathering. Sir.
Can you unmute yourself?
Sir, can you unmute yourself?
Thank you, Dr. Ashmi. This program has well begun, DERMAADVANCE 2021, hosted by the Department of Dermatology, Yenapoya Medical College, Yenapoya deemed to be university, under the auspices of IIDVL Karnataka. It's a pleasant task which is given to me as an organizing chairman and the HOD of the Department of Dermatology to welcome the gatherings and as well as the inaugural ceremony officers. At this moment, I fondly recall the support given by the Chancellor, Mr. Yenapoya Abdullah Kunni, Vice Chancellor, Dr. M. Vijay Kumar, the Registrar and other office bearers of the university, Principal Dr. M.S. Musaba and the officers of Principal, and as well as the officers of Medical Superintendent, my department colleagues, and the postgraduates. So because of which we could host this event for the second time, the last one which we hosted in 2015. It's a pleasant surprise for me when I realized that we hosted Derma Basic, which is the entry-level program for the postgraduates when they enter the dermatology discipline, which we hosted for this batch 3 years ago. And it's the same batch which is joining for the DERMAADVANCE. It is definitely a very happy moment and also a pleasant surprise for me to notice this. And so I welcome you all once again. The last time it was physically, we welcomed you. This time virtually, we welcome you. For today's ceremony, inaugural ceremony, we have our Vice Chancellor, Dr. M. Vijay Kumar. He would be trying to join from the OT he's currently operating, but however, we have his video, the message which he has sent. I thank him for his best wishes and also for trying to join for this inaugural ceremony. We also have our beloved principal, Dr. M.S. Musaba. Dr. M.S. Musaba is a general surgeon. He's a very popular teacher, and he's been vice principal. He's been MS medical superintendent, and currently he's the principal. And his presence makes us so much of happiness, especially for my department, because I always felt he has soft corner for the Department of Dermatology. And thank you, Musaba sir, for joining us for this ceremony. I also welcome, I request Dr. Shashi Kumar. I don't see Dr. Savita. Are you there, Dr. Savita? I request them to join. Can somebody remind them, Dr. Shashi Kumar and Savita, to join for the ceremony? Send a message. Okay, I'm very happy that the IIDVL Karnataka has been the best support for our department, as well as by giving some of the very flagship programs because of which we have got a lot of opportunity to showcase some of the best of the cases that we have had in the last few years, and which is being projected today as a DERMAADVANCE. And also, I welcome the best of the faculties, which we have handpicked faculties from various parts of India, from All India Institute, from NTR Institute, Udaipur, from Child Institute, and from JIPMER. So we have best of the faculties across India who have joined this faculty. I welcome them all virtually. And also, I welcome all the residents who have actively participated in various discussions by being faculties, and they have showcased their talent and prepared themselves for for the program. I also welcome, we have close to 200 delegates across Karnataka and India for this program. I welcome you all. The best part of the program is about this Derma Advance is the real case discussion, wherein the students also participate. And apart from the case discussion, we also have short cases in the form of spotters. And also we have the instrument discussion. We also have X-rays. We also have the drugs discussion, which is basically a mock examination. And this is how this Derma Advance is different than many other CMEs which are held across in the fraternity of dermatology. So once again, and I welcome everyone who is involved in this program and to the inaugural ceremony. Thank you.
Thank you, sir. Our guest of honor for today is Dr. M.S. Musaba, Principal of Yanapoya Medical College. I request you to give your message, sir.
Very good morning to one and all. Am I audible?
Yes, sir.
Yes, sir.
Very good morning to one and all. Honorable Vice Chancellor of Yanapoya University, Dr. Vijay Kumar, sir. Respected dignitaries and participating delegates, respected HOD of Dermatology, Dr. Manjunath Kamath, my colleagues in the Dermatology Department, respected office bearers of Indian Dermatology Association, Dermatology and Venereal and Leprosy Association of Karnataka chapter, and all participating PG students. We have been going through a very tough time period in our social, economic and health aspects due to this devastating COVID-19 pandemic. Fortunately, most of the healthcare system, our nation, including the medical education system, utilized this period optimally in delivering the medical education and healthcare to the public. It is made possible by our superb IT system existing in India, especially in delivering the medical education. Yanapoya Medical College is not an exceptional to this aspect, and I confidently tell you that we utilized and been utilizing this period superbly in delegating the medical education, including conducting webinars, guest lectures, users, workshops, and advanced medical system through the IT platforms. Dermatology being a fascinating subject and our dermatology department being a vibrant department in academic activities, I congratulate our HOD and his team for organizing this event. From the welcome address, I came to know that we have been, the Yanapoya Medical College is hosting this Derma Advance program, second time in our college. I really congratulate our team and also the office bearers of the Indian Association of Dermatologists and Venereologists and Leprologists, Karnataka branch. I acknowledge my sincere gratitude to this team for making me as a part of this inaugural event. One of the most important thing I appreciate, I share in this, the most of the dermatology diseases are, it is a sporadic, or it is a pandemic, or it is endemic in some parts of our countries. And this platform, in this platform, we can, I think we can share the rare diseases for one part of the country, which is common in other part of the country. That is the one of the greatest advantage I think we can share in this platform. I acknowledge my sincere gratitude to the team in making me as a part of this event and wish you all the success in this event. Thanking you one and all. Jai Hind.
Thank you, sir, for your kind words. I now request our Honorable Vice Chancellor of Yanapaya deemed to be University, Dr. M. Vijay Kumar, to announce the inauguration of DERMAADVANCE 2021 and deliver his inaugural address.
Very good morning to all of you. I welcome the students, the residents, and the faculty members on behalf of the Yanapaya deemed to be University. It is indeed a pleasure to be here inaugurating the DERMAADVANCE. I was told this is happening for the second time. And I was also informed that this is one of the vibrant and flagship programs of the Karnataka branch of the Indian Association of Dermatologists, Venerologists, and Nephrologists. I congratulate wholeheartedly for their efforts to educate the younger generation. And I'm also happy as a teacher that in spite of the COVID pandemic, the teachers and the association are coming together, organizing such a wonderful program, bringing everybody under one umbrella. In fact, the COVID pandemic has given us a lot of different views, and one such view is to have this sort of digital platform for learning. At our university, the e-learning process is going on for a long time, and it has got accentuated thanks to the COVID pandemic situation. For those of you who may not know what is Yanapaya deemed to be University, is recognized under UGC Section 3A as deemed to be University for the past 11 years, and we are considered as one of the top 100 universities in this country for the last 3 years under NIRF ranking, and we are graded as grade A by the NAC. Having said about my university, I have to tell a few words about my department of dermatology, which is doing a wonderful job by not only educating 4 MDs and PhD scholars under them, but also giving a useful and wonderful patient-related services to all the patients who attend their clinics. As you know, a medical college usually caters economically backward group like BPL patients. In spite of that, our dermatology association is doing this job well, and our dermatology department in our medical college has come up with answers to them, even if it is required by high-tech investigations and treatment modalities. For instance, laser is one among them, dermoscopy is another, where our dermatology department is able to do a wonderful program, and they are doing a great service to the coastal Karnataka patients coming to us from all over. I compliment and congratulate the association and the organizers led by Dr. Manjunath Shana as the organizing chairman for organizing this program and trying to educate every one of you. Thank you very much. Jai Hind and Jai Karnataka.
Thank you, sir. I now call upon President of IIDVL Karnataka, Dr. Shashi Kumar BM, to give his presidential remark.
Good morning, everybody. I request co-host to enable my video.
Yes, sir.
Good morning, everybody. IIDL Karnataka is always in forefront in organizing academic activities, and we have a many unique program, out of which Dharma Advance and Dharma Basics are the two flagship program hosted by IIDL Karnataka, especially for the postgraduates. Dharma Basic for the first year postgraduates, and Dharma Advance for the exam going postgraduates. We are conducting this program for the last 6 years, and this is the first time we are hosting and in a virtual setup. But we have our academy chairman has not left any stone unturned in accommodating all the cases which are required for the exam going students, whether it's a spotters, it's a long case, short case, everything has been meticulously planned to discuss in this event. I congratulate Academy for this wonderful program which they are planning to organize. At the same time, I thank Yenapoya Medical College by Dean, VC, and for their giving this opportunity to host in this college. And I wish this program a grand success. Thank you.
Thank you, sir. I now request Dr. Vishal B. Yes, sir.
Dr. Savita to give her message, please. Brief message.
Yes.
Honorary Secretary General of IIDL Karnataka. Dr. Savita, please give your message as well. And thank you for joining.
Thank you, sir. Good morning, everyone. The program has started on time and it is going on well. I thank our Academy Chairman and the Chairperson of Derma Advance, Dr. Manjunath Shenoy, sir, for organizing it so smoothly, and the Department of Yenapoya. I hope all the students benefit from this program. I wish the program all the best. Thank you, sir.
Thank you, ma'am. I now request Dr. Vishal B., Professor and Organizing Secretary of this program, to propose the vote of thanks.
Yeah, good morning, everyone. Thank you, Ashmiya. It's indeed my pleasure to have been asked to propose a vote of thanks. I thank our Honorable Chancellor and the Honorable Vice Chancellor of Yenapoya University for their support and encouragement to conduct this program. I thank IIDL Karnataka, our President, Dr. Shashikumar, and Honorary Secretary, Dr. Savita A.S., for giving us the opportunity to conduct this program. A special thanks to our Honorable Vice Chancellor, Dr. Vijay Kumar, who, in spite of his busy schedule, has agreed to be the chief guest. I would like to thank our beloved Principal, Dr. Musaba sir, for his enthusiastic support and also for being the guest of honor. I would like to thank the Department of Dermatology, our HOD, Dr. Manjunath Shenoy, and all the staff, my colleagues, Dr. Malcolm, Dr. Spandana, Dr. Amina, and Dr. Ashfia, who have put all the efforts for the past few weeks to make this program successful. I also thank the PGs from Yenapoya, our department, for helping us out. I wholeheartedly thank the guest faculty, Dr. Somesh Gupta, Dr. Sujay Kanpur from AIMS, Delhi, Dr. Sandeepan Dar from Calcutta, Dr. Nandakishore sir, prominent leprologist from Mangalore, Dr. Asit Mittal from Udaipur, and Dr. Lakshmisha from Jipmer, Pondicherry. I also thank faculties from Karnataka Medical Colleges for agreeing to participate in this program. I also thank all the residents who have actively taken part in this program. And I also thank all the delegates who have participated in this program. Finally, I thank Sun Pharma for their participation in this academic. Finally, I also thank the IT department of Yenapoya Medical College for providing us the resources. Thank you, Anila.
Thank you, sir. We will resume with the next session shortly. Kindly stay tuned.
We'll have a 10 to 15 minutes break, I believe. So after that, the next session will begin. Thank you, Musabba sir.
Thank you. Thank you.
Thank you, Dr. Shashi, Sarvita, everyone.
Thank you, sir. Thank you.
Dear delegates, welcome back. We now begin with the first spotter session for the day. I request the host to connect with the faculty and the residents. Thank you.
So good morning all. I welcome you to the first session of spotters of DERMAADVANCE 2021. The esteemed faculty who will be conducting this session are Dr. M. Rangaswarup, who is the professor and HOD at Adi Chunchanaragiri Institute of Medical Sciences, Vellore. Dr. Parvati CN, who is the professor and HOD of Hassan Institute of Medical Sciences, Hassan. And Dr. Shashikumar BM, who is the associate professor at Mandya Institute of Medical Sciences, Mandya. I welcome you all to this session. The postgraduates who are participating in this session are Dr. Veena Ganiger and Dr. Aparna Anto from Hassan Institute of Medical Sciences, Dr. Bhagyashri SR and Dr. Bhanutej KL from Mandya Institute of Medical Sciences, and Dr. Rashmi R. Malya and Dr. MS Premika from Adi Chunchanagiri Institute of Medical Sciences. So we'll begin with the first spotter. Over to Dr. Rangaswarup and Dr. Veena Ganiger.
Yeah, good morning, ma'am. Welcome to one and all.
Good morning, sir.
Yeah, you can go ahead.
Here is a 40-year-old male patient who comes with a history of itchy dark skin lesions over upper extremities since 2 years. On cutaneous examination, on the upper limb, we can see on the flexor aspects of the forearm, there are multiple well-defined hyperpigmented plaques of varying sizes and shape present over the flexor aspects. And similar lesions are seen over the external genitalia, which are involved in the inner side of the thigh, the shaft of the penis, and the glans penis. Sir.
Okay. What is your clinical impression?
So my first clinical diagnosis will be lichen planus.
Okay. What is the one clinical finding you'd like to elicit to confirm that it is a lichen planus?
So clinically on bedside examination, we can see for the demonstrate for the Wickham striate, which can be accentuated by using any oil drop or a water drop, which is a thin white reticulate line present over the skin lesions.
Fine. What do you mean by Brock's phenomenon?
So in lichen planus, there will be excessive itching, but rather than scratching, the patient will rub the lesion. And there are no scratch marks are visible. That is called Brock's phenomenon.
So what exactly are the nail findings in lichen planus?
Nail findings are pterygium, dorsal pterygium, longitudinal ridges, violaceous lines, subungual hyperkeratosis, and few cases onychodystrophy and onycholysis is also seen. And
yeah, continue.
This pterygium is mainly because angel wing deformities, which is because of the thinning of nail plates.
Okay. What are the syndromes which are associated with lichen planus?
LELP syndromes are like lupus erythematosus and lichen planus syndrome, lichen planus and lichen sclerosis syndromes. Other than that, it is also associated with other autoimmune disorders.
Is it any associated with metabolic syndromes?
Yes, sir.
Syndrome?
Sir?
Metabolic syndrome? Association of LP?
Yes, sir. There is an association with the metabolic syndrome. And even...
Name of that syndrome. Okay.
I am not aware, sir.
Fine. What are the histopathological findings?
On histopathology of skin lesions, we will see compact hyperkeratosis, focal hypergranulosis, there is elongation of the retail ridges, and there is basal vacuolar degeneration, and there is separation of epidermis and dermis in few cases that will lead to the max Joseph's space. And that leads to pigment incontinence, and that means the melanocytes which are incontinent into the dermal space. And
now, what do you
and the cavate and colloid bodies.
How do you correlate Wickham striae with histopathological findings?
So histopathologically, Wickham striae corresponds to the focal hypergranulosis, which are wedge-shaped focal hypergranulosis.
So how do you treat this patient?
This patient. So in this case, I would like to do in the management, I'll do laboratory investigations and treatment, sir. In lab investigations, first I would like to do the routine investigations, the CBC, RFT, LFT, and rule out hepatitis B and C infections and urine routine, and for biopsy of the lesions to confirm the disease. And in treatment, topically, I would like to give potent topical steroids for the hand lesions, and if in case of itching, antihistamines I'll give, sir, and emollients. If it is not subsiding, I'll go with oral systemic drugs, that is oral steroids, betamethasone or prednisolone pulse therapy.
Okay, given in this case, anything you would like to examine in addition?
I would like to examine the other body parts which are involved, sir, like the common sites for the skin lesions, the oral mucosa, nail changes, scalp changes, sir.
Okay, what do you expect in oral mucosa? Fetal patient will have?
Most commonly, it is the reticulate pigmentation, reticulate type of lichen planus that is observed, sir. Other than that, the other erosive, atrophic, ulcerative lesions can also be seen.
Any variants you see?
Oral lesions.
Variants, yeah. Clinical variants.
There are 6 types of lesions that have been described, sir, like reticulate, bullous, erosive, atrophic.
Okay, any drug-induced drugs which can cause lichen planus?
Yes, few drugs like the old drugs like gold salts, bismuth, and mercury, beta blockers, AC inhibitors like captopril and ramipril, and carbamazepine, few cases chlorpheniramine, ranitidines, and other anticonvulsants.
Okay, which among the...
excuse me, sir. Yeah.
Yes.
Can we proceed to the next one? Yeah.
Sure, sure.
Yeah.
Thank you, sir.
Thank
you, Dr. Veena. Dr. Aparna?
Yes, ma'am.
Yeah. Good morning, Dr. Aparna.
Good morning, sir. Good morning, sir.
Yeah, you can proceed with the findings.
Okay, sir. Here is an 18-year-old female patient presented with asymptomatic skin lesion of a forehead for past 6 months. And on examination, we can see multiple comedones on forehead, along with multiple papules and pustules with surrounding erythema, and multiple atrophic scars of different morphology, that is rolling scar, box scar, and multiple hyperpigmented macules of different forehead.
Hello. Yeah. What is your impression?
My first differential diagnosis is acne vulgaris, sir.
Okay. Any other differential diagnosis you want to give? Other than acne vulgaris?
Occupational acne.
No, in this
occupational acne, floor acne.
No, other than acne. Any other probable diagnosis you would like to keep in mind? Fine, Pa. How do you?
Sir.
Okay. So how do you clinically grade acne vulgaris?
Acne can be graded as comedonal acne, mild, moderate, and severe acne, sir.
Okay. Okay. Well, so in this particular patient, what is the grade you would like to see? What is the grade of acne?
Mild to moderate, sir.
Mild to moderate. Okay. So comedones, what are the different types of comedones?
Open comedones, closed comedones, submarine comedone, sandpaper comedones, macro comedones.
Okay. Okay. What are the differential diagnosis for closed comedones?
Closed comedones, papular lesions on the face. There can be tinea faciae, rosacea.
No. Closed comedones.
Closed comedones.
Closed comedones.
Rosacea, sir.
Okay. Anything else? Okay, what about open comedones? What are the differential diagnosis for open comedones? For example, on the nose, tip of the nose.
Favre-Ricochet syndrome.
No, ma, tip of the nose.
Rosacea, phymatous rosacea, having dilated openings of sebaceous openings, follicular opening. Then,
no, but for example, in this case, especially since lesions are on the forehead, right over the glabella, anything other than acne, any other closest differential diagnosis you'd like to think of? Since it is over the glabella also, in and around the eyebrow, forehead line.
Seborrheic dermatitis, sir.
And anything else? Any folliculitis you can think of? Folliculitis?
Fine.
Fine. Okay. What are the other variants of acne?
Acne fulminans, acne conglobata, occupational acne, chloracne, then acne cosmetica.
Drugs can they cause, right?
Drug-induced acne.
So how do you differentiate acne vulgaris from drug-induced acne?
History of use of drugs, sir, and onset of disease after starting use of drug. Then
clinically,
sudden onset.
Morphology. Clinically, when you examine morphologically.
Most of the lesion will be of on the same types, rather than polymorphic lesions of acne vulgaris.
It will be more of monomorphic, right?
Yes, sir.
Any syndromes which are associated with acne?
Sappho syndrome, Saha syndrome, Papa syndrome, Pash syndrome, Pass syndrome, and then Apert syndrome.
Okay. What is Heran syndrome?
Heran syndrome, hyperinsulinemia with
what is HA?
Hyperagilism with insulin resistance and acanthosis nigricans, that is associated with acne.
How do you differentiate it from rosacea?
Comedones that is typical of acne won't be present in rosacea, sir. And site of the lesion for rosacea, it will be on the centrofacial area with more on the prominent areas, more like the central area of the skin of the face. And
any particular history you would like to elicit?
Like history of flushing and.
Okay.
Thank you.
Clinically, how do you? Okay.
And thank you, Dr. Swaroop and Dr. Aparna.
Yeah, thank you.
Thank you, sir.
Dr. Parvati?
Yeah, present.
And Dr. Bhagyashri?
Yes, ma'am. Present, ma'am.
Yeah.
Yes, start.
Okay. Good morning, ma'am. Here we present a patient, 45-year-old female patient who presents with two well-defined erythematous annular scaly plaques with central clearing and raised erythematous border since 1 month with associated itching.
On examination?
On examination, two well-defined erythematous annular scaly plaques with central clearing and raised erythematous border is present, ma'am.
Measuring?
Measuring about, the largest one measuring about 4 by 4 centimeter in size.
The small one?
Small one by 2 by 2 centimeter in size.
What's your diagnosis?
Now, my first diagnosis would be tinea corporis, ma'am.
Okay.
And other differentials which can be considered include the herald patch of pityriasis rosea, subacute cutaneous lupus erythematosus, other annular erythemas or figurate erythemas should also be considered, like erythema annularis centrifugum. And
So your first diagnosis is?
Tinea corporis.
Why do you say it's tinea corporis?
It is present over the trunk is involved, ma'am. The lesions are well defined. Scaling is present. The annular lesions which have central clearing and the active border which is present at the periphery points towards tinea, dermatophyte infection.
Oh, so central clearing and erythematous border. So with that, you made a diagnosis of tinea corporis. Wouldn't you think of Hansen's in this?
Yes, ma'am. Usually
leprosy.
In type 1
differential diagnosis.
Yes, ma'am. We can consider when there is.
Pardon?
Yes, ma'am. We can consider type 1 reaction where there can be papillosquamous lesions or psoriasiform lesions.
Okay. So how will you go about investigating this?
I'll first
confirm your diagnosis. What will you do?
Direct microscopy is done, ma'am, with help of KH mount, where the clippings are taken and examined under direct microscopy on adding 10 to 20% of KOH, on which you can see hyphae, which are septate hyphae or septate hyphae can be seen, branching, which are branching.
Okay.
Which can confirm the diagnosis, ma'am.
Then?
Or we can go for
any other?
Culture can be done, ma'am.
Culture with?
STA agar, seborrheic agar can be done, which reveal the species-specific mold growth is seen, ma'am.
Okay. Then? Any other?
Histopathology.
Other diagnostic things you will do? You finished with KOH, you finished with culture, then?
Histopathology is done, ma'am.
Before that?
Molecular methods can be used.
The method last, okay. DTM, dermatophyte.
Dermatophyte test medium, where due to the production of urease by dermatophytes, there is increase in pH and it converts the medium
to
red.
To indicate
indicator.
What is the pathology you will see? What is the pathology?
We can see the hyphae within the stratum corneum, and there is a slight edema within the stratum malfigi, and dermal infiltrate is seen, which includes perivascular and lymphohistiocytic infiltrate.
Very good, very good, very good. Then, how will you treat?
Based on the extent of lesions, and we should ask patient regarding history of prior application of or prior treatment, whether it's a naive case or history of prior treatment should be assessed. And then based on the extent, either topical agents can be used or adding systemic agents can also be given, ma'am. We usually consider to start with azoles, topical azoles. If lesions do not subside, then oral antifungals might be added, ma'am.
Okay, oral antifungals can be added. Now, what is the cause of recurrent and chronic lesions? What's the cause?
Usually, first maybe due to inadequate treatment, the patient might stop the treatment in between, or application of steroids, which can modify the lesion into recalcitrant tinea infection.
Okay.
Improper precautions which have been advised to the patient, and if they do not follow those instructions, there can be loss of the infection. And continuing the topical and oral antifungals even after complete clinical resolution should be considered for at least 2 weeks after.
Any immunological cause?
Excuse me, ma'am. Underlying immunosuppression should also be ruled out, ma'am.
Not immunosuppression. Anything to do with pathogenesis? Cell-mediated immunity?
Yes, ma'am. It usually provides the host.
Excuse me, ma'am. If we
Okay.
could proceed to the next one.
Yeah, sure.
Yeah. Thank you, Dr. Bhagyashree.
Okay, thank you, ma'am.
Dr. Bhanutej?
Yeah, ma'am. Hello, ma'am.
Hello. Yeah, present.
And here is a male patient, 18-year-old, presented with asymptomatic skin lesion over left index finger since 6 months. On clinical examination, we can see a solitary hyperkeratotic plaque over distal phalanx of the left thumb. With the normal surrounding skin, and we can appreciate the thick color at the periphery of the lesion.
What is the size? What is the shape?
And this is of size this is of circular to oval shape, of size varying from 1 over 1 centimeter. Present over the dorsum palmar side of distal phalanx of the thumb. Yes.
So what do you think it is?
This is the palmar wart, ma'am. Palmar wart.
Palmar wart. Any better diagnosis?
Ma'am, verruca vulgaris, you can say, ma'am. Hello, ma'am.
You're saying it is a Palmar wart. Okay.
Yeah, ma'am.
Why do you make a diagnosis of Palmar wart in this? Diagnosis for this?
Ma'am, warts, these palmar warts are usually seen in young patients, and the morphology of lesion is typical of what, that is hyperkeratotic or with verrucous surface, and usually seen over trauma-prone areas like fingers. And the lesion is asymptomatic and presents in 6 months, ma'am.
Okay. So, how do you confirm the diagnosis of verruca here?
Ma'am, here close differential can be considered as scar. We can differentiate it by first bedside investigations like pairing can be done. We can see on pairing, we can see the black dots representing thrombosed capillaries and even extravasated RBCs. Another can be seen is dermoscopy. Here in dermoscopy, we can see the homogeneous red globules are dots representing thrombosed capillaries, and even linearly arranged vessels can be appreciated with clear demarcation with the surrounding skin by white color, and we can also appreciate interruption of dermatoglyphic lines. We can confirm by this, and we can even go for histopathology.
Histopathology. What do you expect in histopathology in verruca?
Here in palmar wart, we have types of vertical types of parakeratosis will be seen, and hyperkeratosis with papillomatosis representing church pipe pattern can be seen, and in the stratum granulosum we can appreciate chylocytes, and stratum spinosum will show basophilic and eosinophilic inclusion bodies, and there will be elongated and flattened dermal papillae with capillaries, and these,
what is the phenotype causing verruca vulgaris? HPV.
Ma'am, verruca vulgaris, it is HPV subtype 1, 2, 427 usually causes verruca vulgaris.
14749. This is the one which causes verruca vulgaris. Okay. Okay. Then how will you treat this patient?
Ma'am, since it is the solitary lesion, we can go for cryotherapy or excision by electrocautery or surgical excision.
Electrocautery on palm?
Scarring can be then, but you preferred line of treatment is first line of treatment will be cryotherapy can be done.
You are going to go for cryotherapy. Okay. What are the other treatments for what's?
Other destructive treatment with keratolytic agents like salicylic acid, trichloroacetic acid, bichloroacetic acid, and even antimitotic like podophyllin and imiquimod can be tried.
Okay.
And and other destructive methods by cryotherapy, photodynamic therapy, electrocautery, surgical excision, and if there are multiple lesions, we can go for immunotherapy.
Yes.
Thank you, Dr. Parvati.
Okay.
Dr. Banutej.
Okay, thank you.
Thank you.
Good.
Dr. Shashi Kumar and Dr. Rashmi.
Yes, ma'am.
Dr. Rashmi, please proceed with the
Hello, good morning,
history.
sir.
Yeah.
Yes, a 45-year-old female patient presented with asymptomatic skin lesions over the trunk and extremities since 2 years. On clinical examination, there were multiple well-defined depigmented patches over the lower back, the largest ranging from around 11 into 7 centimeters and smallest ranging from 5 into 4 centimeters. And there were also similar patches located on both the legs on the extensor aspect, extending to the feet, dorsal aspect of both feet.
Okay. What is your provisional diagnosis?
So provisional diagnosis can be vitiligo vulgaris, sir.
Okay. What are the other DD you want to consider?
So if I want to examine the other areas of the body also, sir.
Okay.
If the forehead or above the eyebrows may be involved, we can think of piebaldism also, sir.
Okay.
And
what are the congenital causes of white patches?
Sir, nevus depigmentosis, sir.
Okay.
Then, so hypomelanosis of E2, so we can consider, sir.
Okay. Tell me 5 syndromes where you see leukoderma.
Sir, Wolff syndrome, Waardenburg syndrome, so Vogt-Koyanagi-Harada syndrome.
Okay.
Then, so teeth syndrome.
Teeth, okay. Conditions which are associated with photosensitivity and white patches.
Yes, sir. Oculocutaneous albinism, sir.
Okay.
Then, ataxia telangiectasia also, sir.
Okay. What are the acquired causes for leukoderma?
So chemical leukoderma, sir.
Okay. Can you name 5 chemicals which can cause leukoderma? Sir,
hydroquinone. Then, sir, monobenzene ether of hydroquinone. Then, sir, para-tertiary butyl phenol, sir. Steroids, sir, topical steroids.
Okay.
And topical psoralen, sir. No, sorry.
No.
Steroid. And,
what are the occupations which are associated with leukoderma?
Sir, tannery workers, sir.
Okay.
Then rubber factories, sir.
Okay.
And production of dyes, sir.
Okay. So the etiology of vitiligo.
Sir, there are multiple theories associated with the developmental of vitiligo, sir. Okay. One is the immune hypothesis theory, sir.
Okay.
Then neurological theory, neuron hypothesis theory.
Which condition can best describe this neurological hypothesis, neuroendocrine hypothesis?
Sir, segmental type of vitiligo, sir.
Okay.
It will be distributed along the blastoid or segmental pattern.
Okay.
And then, sir, composite theory, sir. Composite theory, which is a combination of all the other theories, sir.
Okay.
Then, sir, melanocytoragy also, sir, which involves transepidermal elimination of the melanocytes. Sir.
Okay. What are the autoimmune conditions associated with vitiligo?
Sir, there are dermatological as well as systemic diseases, sir. The systemic manifest autoimmune conditions associated, one is diabetes mellitus, sir. Then more commonly thyroid disorders, sir, Graves' disease, hypo or hyperthyroidism, sir. And pernicious anemia with intrinsic factor deficiency, sir.
Okay.
And dermatology conditions include DLE can be associated, sir. Scleroderma can be associated, or lichen planus psoriasis. And
there we don't
derm.
call it as vitiligo. Can be associated with leukoderma, but doesn't call it as vitiligo. Okay, what are the clinical types of vitiligo?
Sir, we have local and generalized and special types, sir. Local involves focal or segmental and mucosal.
Okay.
And generalized can be universalis also, sir.
Okay, what are the special varieties?
Special, sir, trichrome vitiligo, quadrichrome vitiligo, sir.
What is acrofacial vitiligo?
So acrofacial vitiligo is a type of generalized vitiligo, including just the palms, soles, and facial, the face around the orifices, ocular and perioral orifice.
Okay, acrofacial is a distinct variety. Okay. What are the management options?
Sir, it's usually resistant to treatment, sir, but we can go for phototherapy, and once it is stable, we can go for mini punch grafting or suction blister grafting, sir. Surgical methods.
Excuse me, sir. Can we proceed to the next spotter?
Okay, please.
Yeah. Thank you, sir.
Thank you, Dr. Rashmi.
Thank you.
Dr. Premika.
Can you, hello.
Hello, Dr. Premika. Please describe the lesion.
Good morning, sir. Here is a 40-year-old male patient presented with asymptomatic dark lesions over the face. On examination, we can see hyperpigmented, distinct patches over the dorsum of nose, bilateral malar region, and we can see diffuse hyperpigmentation over the forehead and chin regions.
Okay, what is your provisional diagnosis?
So my provisional diagnosis here will be melasma, sir.
You just remind me on Monday. What are the other differential diagnoses?
So other differential diagnosis here can be uchronosis, sir, exogenous uchronosis. And
how do you classify melasma?
So melasma is classified like clinically as centrofacial, malar, and mandibular types. And based on UTSLAMP, it is classified as epidermal, dermal, and mixed type. Okay. And histopathologically, epidermal and dermal.
Again, there is a mixed variety. Okay, what is the dermoscopy of melasma?
So on dermoscopy, epidermal variety, we can see a reticular pattern and brownish pigmentation. And in dermal variety, we can see pseudoreticular pattern with dark brown to black pigmentation, and black dots are seen.
Okay, what is the one sign which say it is melasma, which is helpful to diagnose with other pigmental disorders? What about the follicular? What happens to follicles? Okay, how do you manage?
So we can first we have to counsel the patient that this is like the treatment, like counsel the patient for the long course of treatment, and sunscreens initially we provide, and along with that we'll provide with the triple combination therapy or hydroquinone alone.
What do you mean by triple combination?
So triple combination contains hydroquinone, retinoic acid, and corticosteroid fluocinolone acetonide.
Okay, what's the original Kligman formula? Formulation of Kligman formula.
So it contains 4% of hydroquinone, retinoic acid 0.05%, and fluocinolone acetonide 0.01%.
No, please check. Okay, what are the other topical agents used?
Other topical agents like we can use the arbutin, we can use kojic acid, and we can use azelaic acid, and we can physical, like we can do the physical treatment through chemical peels. So,
What are the source? What's the source of kojic acid? What are the systemic agents used in the management of melasma?
so we can use tranexamic acid, sir, as a systemic agent.
It belongs to which group of this? Which group of drugs?
So it decreases the vascular component of the melasma by inhibiting the vascular endothelial growth factor.
Okay. Other mode of action? How lasers will help in melasma?
Lasers we should use in adjunct with the topical therapy, sir, as an adjunct with the topical therapy. And commonly used lasers will be fractional CO2 laser, copper bromide laser, and Nd:YAG, Q-switched Nd:YAG lasers.
Okay. What's the role of vascular lasers in melasma?
So it can be used to the melasma has a vascular component, sir. To reduce it, we can use the vascular lasers like PDL, pulse dye laser, and Nd:YAG.
What is external root rhonosis?
Sir?
Exogenous root
The
rhonosis.
sucranosis. Sir, on in melasma patients on chronic application of the hydroquinone, due to the it will get deposited in the melanocytes, sir. So it results in exogenous sucranosis. It presents the yellowish ochre pigment.
Sir,
Please check
you
again.
can conclude.
Yeah, thank you, Rashmi.
Thank you.
Okay.
Thank you, sir. Okay, we have come to the end of this session. Thank you all esteemed faculties and the postgraduates for your participation.
Alopecia areata, do you find the infiltrate around the...
In alopecia
We will resume with the next session shortly. Kindly stay tuned in. Dear delegates, welcome back. We proceed to the next case discussion on Hansen's disease. Kindly post your questions pertaining leprosy into the chat box. This will be taken up at the end of the case. I now request the host to connect with the residents and the faculty for this case on leprosy. Thank you.
Good morning, everyone. I welcome you all to the case discussion session on leprosy. Our respected faculty for today are Dr. Nandakishore sir, who is a consultant dermatologist and former professor and HOD Fadamulla Medical College. Dr. Jacinta Matis, who is a professor and HOD at Fadamulla Medical College. And Dr. Nandini A.S., who is an associate professor at KIMS Bangalore. Postgraduates who will be participating in today's session are Dr. Marriott and Dr. Megha from KIMS Bangalore, Dr. Aneta and Dr. Durga from Fadamulla Medical College, Bangalore. I now request Dr. Marriott and Dr. Megha to start sharing their screen and to begin the case presentation. If you can go ahead.
Yes. So a 30-year-old male patient hailing from Uttar Pradesh who is residing in Bangalore for the past 1 year. He works as an electrician by occupation, presents with the following chief complaints: of multiple reddish lesions all over the body for the past 5 months and pain over the existing lesions for the past 15 days. The patient was apparently well 5 months back when he noticed an initial reddish raised lesion over the chin, which was insidious in onset 5 months back, and it gradually progressed. Initially, the lesion was about 1 into 1 centimeters in size, and it progressed over the last 15 days to attain the present size of about 6 into 7 centimeters. It is also the number of lesions increased over the forearm, flank, and chest over the last 15 days. The reddish raised lesions are not associated with any itching or burning sensation. The patient also complains of decreased sensation over the lesions. He is not able to perceive hot or cold sensation in that area.
You said that initially small 1 into 1 centimeter. In the history, okay.
Yes.
It is not the patient who has he measured and told you that it's 1 into 1 centimeter?
So he said about pea size, sir.
See that. So you must always say like that, 50 paisa coin, a rupee coin, something like that, not a measurement.
Yes.
Right? Yeah.
Okay.
Fine, go on.
He also has history of pain over the lesions, which is dull aching type. It's moderate in intensity. There's no aggravating or relieving factors, and there's no diurnal variations associated with the pain. He gives no history of any fever. He gives no history of difficulty of buttoning of shirts. He gives no history of slippage of chappals. He gives no history of redness of eyes. He gives no history of swelling of feet, and there was no history of joint pain or bone pain. There's no history of any inability to perceive smell. There's no history of any recent travel, surgeries, medical illness, or hospitalization. He also has no history of difficulty in closing eyes or deviation of angle of mouth to one side. There's no history of nasal stuffiness. There's no history of cloudy urine. There's no history of pain over the testes. There's no history of photosensitivity or oral ulcers. There's no history of any drug intake. There's no history of any wound over the feet or other extremities. There's no history of fluid-filled blister at pressure points. And there's no history of coarseness of voice. Coming to his past history, there is no history of similar complaints in the past. He had a history of RTA 20 years back, for which debridement was done over the right lower limb, following which there was also a traumatic amputation of the second right toe that was 20 years ago. There's no history of associated comorbid conditions such as hypertension, diabetes mellitus, thyroid, asthma, or epilepsy. Family history, there's no similar complaints in the family or in the neighborhood. Coming to his socioeconomic history, he earns about 3,000 rupees a month. There's overcrowding present. There are 6 members living in one flat. There's no history of similar complaints in the roommates. Sexual history, he denies history of any coitus or any promiscuous sexual behavior. He consumes a mixed diet. His appetite is normal. His sleep is normal. His bowel and bladder habits are normal. He gives history of alcohol consumption since 5 years, and he has stopped it for the last 2 months.
Now, Dr. Megha.
Yes, sir.
Again, in your history, you have given a lot of negative negative history,
yes,
right?
Yes,
and it appears as if all the negative history are aimed at a particular diagnosis, as if the diagnosis is already, biased and made. So your negative history should also include points which favor a possibility of a differential diagnosis. Okay.
So I also thought of other autoimmune conditions.
We'll come to it later. Differential diagnosis will come later. But then your negative history should also highlight of at least one or two possibilities wherein you have thought of other conditions. Here, it is fixed. Okay, we are dealing with Hansen's. So whatever negative history pertaining to Hansen's, that should not be the way. All right. Fine. Go
Yes,
on.
sir.
Go on.
Examination, sir.
Before going to examination, Dr. Mayor, can you just briefly tell why you asked the negative history?
Ma'am, his main complaint was reddish raised lesion and absence of sensation in that particular area, ma'am. So the minute he said there's absence of sensation, I would like to take history in terms of Hansen's disease, ma'am. And he also complains of pain over the existing lesion, so which made us think of reactional states, ma'am. So to differentiate whether it was a type 1 reactional state or a type 2 reactional state. So there was no other systemic features involved, such as fever, testicular pain, or cloudy urine, or any other exacerbating factors such as stressful events such as surgical, recent surgeries, medical illness, or any drug intake, or travel, or even hoarseness of voice. So no systemic involvement.
What is the importance of history of nasal stuffiness?
Nasal stuffiness is again a earliest feature of LL Hansen's and going into type 2 reaction, ma'am. So that's why I asked him for nasal stuffiness.
Hoarseness of voice?
Hoarseness of voice is again involved in case of larynx is involved in type 2 reactions, ma'am. They can be fibrosis of the larynx and also perforation and ulceration can occur, ma'am. So which they'll present with hoarseness of voice.
What was the history of drug intake specifically asked for?
Ma'am, any immunosuppressive agents, ma'am, whether he was on steroids, any other immunosuppressants, or even chronic drug abuse can lead to immunosuppression and they can be more susceptible to Hansen's disease or reactional states, ma'am.
Any treatment history?
Yes, ma'am. No, ma'am, no treatment history, ma'am. He denies any drug intake or no recent treatment, ma'am, for the above complaints.
From the onset of the signs and symptoms,
Yes,
he has not taken any
5
treatment.
months, he has not taken any treatment, ma'am.
Till he presented to you. Okay.
Yes, ma'am, till he presented to us.
Can you just summarize briefly the history? Just a brief positive finding, positive history.
Ma'am, a 30-year-old male patient with reddish raised lesions since 5 months and sudden exacerbation in the size and number of lesions for the last 15 days. It's also associated with pain and decreased sensation over the reddish raised lesions, ma'am.
Okay. The existing lesions from the beginning till when they presented to you, is it the same number or anything extra history you will give?
The first lesion was initially over the chin, ma'am. That was present for a duration of about five months. And for the last 2 weeks, there's sudden exacerbation in the number and the size of the lesion. It's increased in size and also progressed to involve the forearm, the flank, and also the chest. And he complains of pain, which is dull aching type, over these lesions for the last 2 weeks.
Okay. Any other constitutive symptoms?
Ma'am, systemic symptoms were not involved, ma'am. There was no fever, there was no eye involvement, no testicular involvement, and no swelling of the limbs, ma'am, or bone pain.
Okay. No other comorbidity?
No comorbidities noted.
Patient is conscious, cooperative, well-oriented with time, place, and person. He is moderately built and adequately nourished. His BMI is 22.4 kg per meter square. His pulse rate is 75 beats per minute. His blood pressure is measured to be 110/70 millimeters of mercury. He was afebrile. His respiratory rate is 18 cycles per minute. He had no pallor, no icterus, no clubbing, no cyanosis, no lymphadenopathy, or no fetal edema. His higher mental functions were normal. His S1 and S2 was heard, and normal vascular breath sounds was heard bilaterally. Per abdomen, he had was soft, non-tender, and normal bowel sounds were heard. Coming to cutaneous examination, a well-defined erythematous plaque with irregular margin present over the face involving the chin, the right mandibular region, and the right submental region, and the anterior aspect of the neck around 6 into 5 centimeters with scaling. There was a few erythematous satellite lesions present over the anterior aspect of the neck, measuring around 2 into 2 centimeter to 3 into 3 centimeter on the lower aspect of the above mentioned plaque. Tenderness was present over.
Dr. Mary, can you just show it one?
Ma'am, this was the main lesion, ma'am, the erythematous tender plaque with a few satellite lesions from the main erythematous plaque.
Okay, can you highlight that satellite, because your satellite seems to come down and show me the satellite.
So here,
Does it? Okay. Does it not look like a continuation of the main patch? If there is this thing, and satellites are usually they are very small ones. Okay, this is vision there. Huh? All right. Maybe, of course, in the photograph we may not be able to appreciate to that extent, but then satellites are always very, very small ones, and there is a clear-cut gap of normal skin in between. Huh? All right. Yeah. Is there any hair loss over the lesion?
Sir, not in this lesion, sir. There was another lesion over the chest where the hair loss could be more well appreciated, sir. I'll show you a picture of that.
All right.
Over these lesions, the tactile and the temperature sensations was decreased. He had tenderness over the lesion. There was a similar, this is the same lesion from another angle, sir.
Okay. See, that's not really a satellite. It's too big for a satellite. Okay.
Okay, sir.
Yeah. And why are you mentioning only tactile and temperature? What about pain? Tenderness has nothing to no, pain has to be tested, because pain is from a needle prick is totally different from the tenderness, right? A tender patch is still anesthetic. So you should always test the pain. All right. Tenderness is a deep tenderness. It's on tapping. All right, on tapping, on percussing the lesion. Not really pressing the lesion. It's kind of a percussing the lesion. All right? Yeah. So pain has to be. I realize that you have not mentioned that in your PPT. Huh? All right. How did you test that thermal modality?
The thermal modality, we take a glass tube, sir, and in that we take a temperature of the water is taken, sir, with 37 degrees plus or minus of 5 of 37 degrees for the hot and cold temperatures.
No. And cold is what?
The cold is 37 degrees minus 5, sir. That will be 32 degrees Celsius.
And hot? 37
42 degrees Celsius.
Around 42. Okay. You cannot measure. You really don't measure ultimately. Yeah.
Yes, sir, but around that temperature, sir.
Do you have any device with which you can measure temperature, which has been a recommended device for Hansen's disease? Not sure. Not aware.
Not sure.
Okay. All right. So I think I always like to tell the answer, because you should know. It's just a training for you. There is a device called a thermal testing device. It is done by Dr. Srinivasan and Stump. Okay, it looks like a pen torch with the one end hot and one end cold. If there is a battery, you switch it on, it becomes warm at one end. All right. At the other end is, because it is a metallic tip, it is cold. So that is the one which has been recommended. Unfortunately, not available everywhere. That is the problem. Okay, go on. Yes.
So there was a similar erythematous ill-defined plaque measuring around 4 into 4 centimeter present over the lateral aspect of the left forearm. Again, the sensations, that is the tactile and temperature sensations, were decreased. The lesion was tender. The next is an ill-defined, well-defined erythematous plaque 2 into 2 centimeter present over the left flank. Again, it's a tender plaque with tactile and temperature sensation, which is decreased. The next is an ill-defined hypopigmented patch measuring around 9 into 6 centimeters with irregular margins present over the anterior aspect of the chest. Here, the decreased hair growth can be appreciated, and the sensations were decreased over this lesion. There is also an ill-defined.
Was there any erythema over the lesion?
No, sir. There was no erythema, and both the tactile, the temperature, and the pain sensations were decreased over this lesion.
What else do you observe on this lesion? Because this lesion morphologically looks different from the other lesions. Okay, so you should be able to say something more on it. Your opinion. Now, what exactly is it? A well-defined or ill-defined?
So it's an ill-defined.
So this stands this stands apart from all the other lesions. All right?
Yes, sir.
Isn't
Yes.
it?
Yes.
So this ill-defined lesion, and does it really have impaired sensation?
Yes, sir. It did have impaired
It
sensation,
had.
sir.
And
Yes.
again, you seem to be missing the pain everywhere.
So here the pain sensation was also decreased, sir. For this lesion, the pain sensation.
So it is a hypoaesthetic lesion, sure.
Yes, sir. Yes.
There seems to be follicular prominence there. For
Yes,
us
sir.
in this computer, I don't know, nothing like a live demonstration, which you can't do here, but there seems to be a follicular prominence. You see that and come to the normal skin when you see.
Yes.
You see on the chest, everywhere there's a follicular prominence.
Yes.
Is there any history of any application there?
No, sir. There was no history of any application of any medication, sir.
Because this is too ill-defined. It doesn't match with other lesions. Huh?
Yes.
Okay. So one should not be biased.
Was it
regarding
clinically also very, all the borders were ill-defined or any borders, because sometimes it may not be picked up in the picture.
Yeah, that's
No,
right.
ma'am. This was an ill-defined hypopigmented patch, ma'am.
Very, very ill-defined.
The sensation in that chest lesion or the chest?
Ma'am, the sensation was reduced, ma'am. The tactile, the
Reduced.
temperature, and the pain sensations was reduced, ma'am. And it was not tender, ma'am. This lesion was not tender.
Any difference in the hair growth?
Yes,
in the
ma'am.
chest
Yes, ma'am.
compared to the surrounding
yes,
area?
So compared to the surrounding area, on this lesion particularly, we could appreciate the decrease in hair growth.
How does the patch appears? Whether dry, absence
ma'am,
of sweating, anything you can make out?
It was shiny in appearance, ma'am, but otherwise we could not make out if it was. It wasn't really dry, ma'am.
Okay.
And there is also an ill-defined xerotic patch over the gluteal region, again where the sensations was decreased. Coming to the remaining cutaneous examination of head to toe, in scalp we had graying of hair present. Face, there was a media over the right eye, and photomelanosis was present over the face. Eyes were normal. There was no redness, watering. Ears were also normal. Oral cavity, he had a poor oral hygiene with dental caries and potato staining present. Neck, erythematous plaques with sac-like lesions was present. Along with that, the photomelanosis was present. In the trunk, apart from the hypopigmented patch and the erythematous plaque, there was a junction venous on the lower back. Upper limbs, a BCG scar was present over the left deltoid, and an ill-defined erythematous scaly patch over the left forearm. Palms were normal. Nails had longitudinal lines. Lower limb, there was a post-traumatic linear scar around 7 centimeters present over the right knee, and the right second toe was amputated due to a traumatic incident.
Where are the pictures? Where are the photographs of that?
So we just put the photographs of the lesions.
No. When you are positive, you are saying so much of positive about the what you call positive findings, right? The loss of toe. He says amputated, fine, but then he should be able, because amputation also has a connection. Why was it amputated? Was it a much older history? No,
yes,
no, all right. You are saying that it is accident, all those things. Everyone wants to give a coverage to it. Okay, does it have any relation to Hansen's? So and you should have shown a photograph of that. All these things need. All right. Anyway, there is a lot more to it. Maybe in your diagnosis and your substantiation, we can probably cross-question you again. Now, why did you, Durga? I just asked Durga about it. She gave a history of a lot of findings. Sorry, the BCG scar. Why did she mention that? What, according to you, is the reason for mentioning that?
So BCG has a role in leprosy because
what role?
It gives an immunity towards leprosy. So in
protective role. Okay.
Yeah, as a vaccination, it gives a protectiveness for this leprosy.
All right. Now, is it the reason why you mentioned Dr. Megha?
Sorry, sir.
No. Marriott was present in. Yeah.
Yes,
is it the reason why you mentioned?
So that, and as a positive physical examination finding, sir.
No, usually positive, usually you don't know where else. BCG vaccinations. Okay, no problem. For this, yes, there is some
Yes,
rule
yes,
you
it
mentioned.
has a
All right,
protection.
fine,
Yes.
good enough.
And as of now, still the diagnosis, it could be even other forms of, mycobacteria as well. So we should keep that in mind because we're not yet come to the nerve examination.
Yeah.
Yes. In the soles, there is fissures and nails transverse ridges in the lower limb, and lymph nodes were not palpable. The external genitalia was examined and found to be normal, but no testicular activity. Nerve examination, the supratrochlear nerve of bilaterally was not palpable. Supraorbital nerves bilaterally was not palpable.
You can probably highlight only whatever it was rather thickened inward, because we can see, all of us can see that your exam.
Yes,
will
sir.
be spending unnecessary time here. What is significant here? You just say palpability and thickening. Now you must tell us about
Yes,
it.
sir. So the infraorbital nerve on the right side was palpable. The greater auricular nerve on the right side was thickened, and left side it was palpable. In the supraclavicular nerve, the intermediate part, the right side was palpable. The medial part, both sides were palpable. Radial and ulnar nerve was bilaterally palpable. Radial cutaneous nerve was bilaterally palpable. Common peroneal
Now,
nerve.
palpable, I think it's not correct that you say palpable. It should be thickened or not thickened, because palpable, they're all palpable nerves. Palpability and thickening are different. So, is it thickened?
So it was thickened, sir.
No, then you should say that it is thickened.
Okay.
If ulnar nerve is both palpable, is it thickened? Every ulnar nerve is palpable. There is no ulnar nerve which is not palpable. Even in the most obese person, it is palpable, and provided you know how to palpate properly. So here you must highlight only whether it's thickened or not. All right. So the palpable does not have much significance. Yeah. So as per that, which are the nerves which are thickened here?
So the common peroneal nerve, the greater auricular nerve, the posterior tibial nerve on the right side, and along with that, the ulnar nerve on the right side was thickened, sir.
Ulnar nerve on the right side was thickened, but you have written both palpable, but it's thickened. Now you mentioned about anterior tibial nerve. Where did you palpate anterior tibial nerve?
So the anterior tibial nerve is palpated on, or the deep peroneal nerve is palpated on the anterior aspect of the foot, that is just medial to the lateral to the extensor hallucis longus tendon, sir.
The extensor hallucis longus.
Yes, sir.
Where is it on the ankle? Is it?
So the anterior aspect of the ankle, sir.
Anterior aspect of the ankle. So do you really can appreciate the thickening of the anterior tibial? No, I don't, because anterior tibial nerve is something which is not well recognized in Hansen's disease. Yeah?
Okay.
Is it routinely you do that?
So we do we do palpate it, sir.
It is. Are you mentioning the nerve which comes at the lower 1/3 of the leg? Is it that nerve, or what exactly do you? Is it a branch of the anterior tibial or the main anterior tibial?
So the anterior tibial nerve that continues, as it in the lower 1/3 of the leg, sir.
Lower 1/3 of the leg, anterior tibial nerve. I think you have some confusion regarding that, and you are also confusing us regarding this. I think, Dr. Nandini, do you have any explanation? Is she trying to say anything? Can you? No, because no problem. Each institution has its own way of it. I'm just trying to get more details of that. Dr. Nandini,
I'm not getting, can you please clarify what is your doubt, sir?
No, anterior tibial nerve, palpability. Yes, she is mentioning about the leg and all those things. Is it so? Do you find anything like that?
Yes, so sometimes whenever there's a big plaque on the leg, the leg or even the foot, and there's lots of sessions, we do find that the thickening of the nerve.
No, I think that is a musculocutaneous nerve. It is a musculocutaneous nerve, okay, which is a branch, all right, or it's also called as a superficial peroneal nerve. I don't know, but it's a branch of the anterior. So it pierces the deep fascia at the junction of the middle 2/3 and the lower 1/3. And then it comes out and it's beautifully palpable. It is beautifully thick. It's seen huge sometimes. Whether that has been confused as an anterior tibial. Anterior tibial is something like that. I have a feeling like that because this is what is done in nephrology, traditional teaching. Anyway, check with this. Okay, it's just for discussion. I have a doubt regarding what you have in mind. All right.
Okay.
That is the musculocutaneous, which supplies the peroneal compartment and then comes out and supplies the skin.
Yes.
Okay, it's called superficial peroneal or musculocutaneous. It's a branch. Just see, look into it. Okay, fine.
Yes.
The posterior tibial nerve. Where did you palpate posterior tibial?
So posterior tibial nerve is palpated on the medial aspect, sir, halfway between the medial malleoli and the tendoachilles tendon.
Okay. Okay. It's halfway. It's not actually. You can see the posterior border of the medial malleolus and the tendoachilles.
And the tendoachilles tendon.
Yeah, tendoachilles. That's exactly the midpoint.
Yes.
Okay, fine.
How do you grade the nerve thickening, Dr. Marriott?
Ma'am, the grade thickening of the nerves, ma'am, if it is grade 1 thickened, then it's said that it's thickened as compared to the contralateral side. If it has a rope-like consistency, it's said to be grade 2 thickening, and if it's beaded or nodular, it's grade 2 thickening, grade 3 thickening.
Okay, beaded or nodularity comes as?
Grade 3.
Yes, grade 3.
Is there any grade 4?
Not that.
No, only grade 3.
Grade 0 is if it is normal, bilaterally symmetric.
Grade 0 is normal. Yeah, I know. 1, 2, 3. I just
One, two.
These are the gradings which are being devised recently. I know that. Yeah, fine. Go on.
Yes, Annetta, while palpating the nerves, what else you have to consider other than thickening?
Ma'am, tenderness as well, ma'am.
Okay. Yes, then along the nerves you have to palpate. Okay?
Yes, ma'am.
Along the nerves. And you have to compare always with the other side.
Contralateral
side. Yeah, contralateral side. Yes. Yeah, go on.
The motor examination, in patient nerve, there was no wrinkling, there was loss of wrinkling of the forehead. There was no difficulty in closure of eye against resistance. There was no loss of the nasolabial folds bilaterally. Deviation of angle of mouth was absent. Blowing of cheeks bilaterally was intact. The osteoclasping test was normal. The pen test was normal. The opposing finger test.
What does osteoclasping test tell you? Indicate?
Sir, it indicates a median nerve paralysis, sir, where the will be one index when we ask the patient to clench the clasp the two hands together. The index finger will point upwards.
Sure. Okay. Then the index finger points out.
Yes.
Okay. All right. Yeah. Let us go into this later. These are all the theoretical tests you should do, no doubt. Okay, pen test, what happens? Yes.
So in pen test, sir, we can hold, we ask the patient we keep a pen on top, sir, so we are checking for the abduction, sir. So it has to be perpendicularly upwards.
Yeah.
So again, that is to check the median nerve, sir.
Okay, fine.
It's for the abductor pollicis.
Yeah.
And the opposing finger test, sir, it's when we ask the patient to oppose the thumb against the other finger, sir. And the card test is for the intrasci, that is the palmar intrasci. We place a card in between their fingers and we pull it out. So we try to check for the resistance, if they're able to hold the card in place between their fingers. The Igawa test is against the dorsal intrasci, that is to check for the adduction of the fingers, sir.
Adduction or abduction?
Abduction, sir. Abduction. Card test is for the adduction and Igawa test is for the abduction.
So palmar intrasci, adduct. Or abduct.
Palmar intrasci adducts, sir. Adducts.
Dorsal?
Dorsal abducts.
Okay. You know how to remember that?
Yes, sir.
What? How?
Pad and
dab.
Pad and dab. Yeah, that's famous. Yes. Okay. All right.
So then book test, sir. So book test, we place a book in between the thumb and the index finger, sir, and we pull it. And if the thumb is placed straight, that means the book test is it's normal, sir. The ulnar nerve is intact. If it is flexed, the flexor pollicis longus will take the action instead of the abductor pollicis. And because of that, we can say that the promen sign is positive or the ulnar nerve is not intact.
Fine.
And the lumbrical test, we ask the patient to place the metacarpophalangeal joints is flexed and the interphalangeal joints is extended. So this will be the lumbrical test, sir.
Yeah. When you say flexed, what is a flexion? What is the angle? You must mention that. Angle of flexion.
90 degrees.
90 degree. That is what it
90
is. It
degrees.
should be 90 degree flexion. And a fully extended IP joints.
Of the IP joints.
Yeah. Right.
And the dorsiflexion of the foot and the posterior plantar flexion of the foot and inversion of the foot is examined.
See, all these things, what you are seeing is, you will be seeing a totally damaged nerve, where there's total deficit takes place. Okay? Full parallelity. But in the early stages, for an ulnar nerve, what will be the test?
The Wardenberg test, sir. The Wardenberg, which is the deviation of the little finger, sir.
Very good. Okay. Yeah. All right. That is the first thing. When you see a mild deviation of the little finger, medially or laterally?
Lateral, sir.
No, it is not lateral. So you always imagine everything in an anatomical position.
Fine.
All right.
Yes,
It is medial. And why does this take place? Why does this take place? What is the mechanism of it? Not sure.
The introsure is supplied by the introsure, and also the
everything is supplied by ulnar only then. Everything is supplied by ulnar. There's nothing else which supplies. Anita, do you know this? No.
Weakness of the third palmar introsseous.
Weakness is there, but everything is supplied by ulnar itself, isn't it?
Yes, sir.
Interossa is supplied by ulnar. The whole hypothenar eminence, all the muscles are supplied by ulnar nerve. So it's basically abductor digitae minimi, which abducts and which is a stronger muscle in comparison to the interossa. Interosseous are weaker muscles. So early, always is. Later on, it doesn't. But the early is abductor digitae minima has some amount of more power than that. So minimal abduction. Okay. How do you test the early sign of a median nerve?
So median nerve, sir, we can ask the patient to make the OK sign, sir. So if depending upon the OK that they make, sir, if it's around 150 degrees, sir, if it's anything less than 110 degrees, then it's said to be abnormal, sir. If they're only able
are you measuring that?
It's said to be abnormal, sir.
Yeah, I know. These are all theoretical, but are you measuring that? No. What is the measurement that is used to measure these angles? Gonimeters.
Can the shift over happen easily?
There is nothing but a protractor with that. There is a scale, I think, in the middle. So you can put it and see the angle. Dr. Mega can sign for common peroneal nerve.
Foot drop, sir.
Foot drop is one which takes place when the complete nerve damage. Foot drop.
Shall I accept it off? Anyway, because I wanted that Malchandra cap.
Everywhere you must know what is the early sign of weak nerve. It is how you are benefiting the patient.
Smaller one. So given that, so I'll go for it then.
Inability to extend the extensor hallucis longus.
Yeah, extensor hallucis longus.
Difficulty in dorsiflexion.
They are not able to dorsiflex that mainly early. First is a
if I want this change to CBSE,
and what about the you mentioned that
my CSE.
Lag of thermus, how would you test early lag of thermus?
So the Bell's phenomenon. So we ask the patient to close
That's
their
all
eyes
later.
slowly.
That's all later. Early. It's not okay. Okay, you ask him to close. What happens? Yes, go on. Sorry. Oh, go on.
So the uprolling of the eyes will be visible.
That is a lag of thalmus. Early sign, when there's an early paralysis sets in.
So heaviness of the eyelids, sir. The patient
What is
of heaviness of the eyelids, sir.
No. You ask them to close the eyes gently, both the eyes very gently. The one which is early, it follows the normal one. It lags behind the normal one compared to. Okay. Let them close it together slowly like that. Now come to the point of the posterior tibial nerve. You are palpating the medial aspect.
And the tendon.
Yeah. That means you are palpating the posterior tibial nerve before it enters the flexor retinaculum. What happens once it goes inside the sole?
So it splits into the medial and lateral plantar nerves.
Good. Oh, yeah. So how does posterior tibial nerve contribute to the flexion of the foot? It doesn't. Tibial nerve, this is not the method of exam. Inversion and all is done by the extrinsic muscles. Okay. The tibialis posterior is an extrinsic muscle. Inversion. Eversion done by the peroneal muscles. Flexion done by the gastrocnemius. They are all supplied much higher above. So you should know anyone, one other
also the intrinsic muscles, sir. So we ask the patient to keep the foot flat on the ground and pull the toes back, sir.
Pull the toes back. No, you are almost close to it. But why have you not mentioned? You have to put the foot firmly on the ground, then ask them to dorsiflex the lateral foretoes. Okay. In doing so, if there is a weakness, that the IP joint of the big toe flexes. Okay. If there is normal power, it doesn't flex. That's a little difficult test, not so easy. Next simple test is full abduction, the spreading of the toes, toe spread. That is a simple test. Spread the toes. If it is able to spread, okay, it is almost normal like that.
So the muscle powers were examined that for the facial nerve, the orbicularis oculi and the muscles of facial expression, and the extensors of the forearm for the medial nerve, the flexors of the forearm and the interosseous muscles, and the medial two lumbricals, and for the thenar muscles for the medial nerve, then dorsiflexion and eversion of foot for the lateral popliteal nerve was examined. Corneal sensation were the medial nerve sensation was laterally, the ulnar nerve sensations was found to be normal bilaterally, and medial nerve sensations were found to be normal bilaterally. The superficial peroneal nerve, deep peroneal nerve, posterior tibial nerve, and sural nerve sensations were found to be bilateral normal, along with the saphenous nerve sensation. And, testicular sensations was intact. Come to a provisional diagnosis of borderline tuberculoid Hansen's in type 1 reaction with grade 2 deformity of the second toe, but that may be secondary to a road traffic accident that occurred 20 years back, and the patient is not on any treatment.
Now, why do you say it as Hansen's disease?
More than one nerve is palpable, hypoanesthetic path, sir, and pain over the existing path.
Okay, so you have 2 among the 3 cardinal signs. Good enough.
Yes, sir.
Why do you say it as borderline tuberculoid?
So, because of the large erythematous plaque and slight satellite lesions which were present surrounding the erythematous plaque.
Oh, so you mean to say that you catch a satellite and just say that it's borderline tuberculoid? I think your substantiation of the classification needs much more than this. Much more than this.
The lesions, the erythematous lesions were almost well defined, sir. They were well defined erythematous lesions, sir. And the number of lesions was around 5, sir. There were around 5 lesions, sir.
Number doesn't come into picture early at the classification. You must highlight the much better salient points. I agree with your erythematous.
Were all the patches and plaques that you examined similar, or were they varied morphology?
Very morphologically, ma'am. Over the chest, it was not erythematous, ma'am. It was just hypopigment anesthetic allophagic patch.
The other areas, it was a well-defined erythematous plaque were observed.
No, what about the sensation? See, the
Sensation
sensation
was
contributes,
impaired in
loss of
all.
sensation contributes to the classification. You must highlight that.
Yes.
Is there a gross loss of sensation or
Yes.
total loss of sensation?
Over the
Or
patches, total loss of sensation.
almost total loss?
Yes,
Isn't
sir.
it?
Yes,
That
sir.
is in favor of which type? Towards which type?
Tuberculoid.
Tuberculoid type.
Tuberculoid pole.
Nature of the plaque, good enough. Then what else? One satellite you said, fine, all right. What about the distribution of the lesion? You should highlight that.
So mainly over the trunk, sir.
Oh, no. The trunk and all distribution doesn't come. Distribution is, there are two types for classification. Which one? For classification purpose, the distribution helps you.
What kind of distribution do you see in
What distribution is this?
It's asymmetrical, sir.
They have highlighted this thing. And the nerve also, multiple, I don't know whether you said multiple, two nerves, and they are also asymmetrical.
Yes, sir.
That's how it contributes.
So again,
tuberculoid pole, sir.
Towards the tuberculoid, but it's not tuberculoid, but it is a borderline tuberculoid.
Yes.
Good enough. Now, how do you explain that different morphology now?
So if the
Because of
patient
the
was-
unstable immunity.
No. They are totally, see, so many lesions are severely erythematous, edematous, and also almost scaly, right? So
Yes,
are they?
yes.
Scaliness indicates, what does it indicate?
So an inflammation
Reactionary state.
Yeah, reaction and regressing reaction. Regressing reaction. Okay, otherwise, the scale has nothing to do with Hansen. Only the area where you can get a scaling is type 1 reaction regressing. Otherwise, if you see scales, it is not Hansen's. Okay, so it is a regressing. But how do you explain that ill-defined, totally ill-defined macules, isn't it? They're not raised, they're flat.
Yes.
Do you consider anything else, relatively ill-defined lesions, just for academic interest, unless we see the case? You say that ill-defined lesion, you see follicular prominence, okay? Similar lesions,
Indeterminate
and loss of hair there, and not loss of hair over the other lesions. Could it be some other condition associated?
Indeterminate.
No. Forget about
Not
it.
Hansen's, any other condition.
Any other coexisting.
Prominence.
Yeah.
Loss of hair.
Loss of hair, follicular prominence, ill-defined area, big ones. Oh, alopecia.
mucinous.
Okay, this stuff we don't know unless we see it in black and white. The cases, or three-dimensional view. Now, what we are seeing is pictures, but then just for academic interest, I'm asking. They look so much different. All right, let us assume that it is Hansen's. Can you have any explanation for this? So you must be able to substantiate. The whole post-graduation course is about finding and substantiating and finally drawing it towards the conclusion. Whole thing is about it. All of us make mistakes, no problem, absolutely no problem.
He's a 30-year-old man, right?
Ma'am, 30-year-old man, poor socioeconomic status with slight overcrowding present.
Anything that he has done for the follicles to look prominent?
Ma'am, he denies history of any local application or usage of any other thing. Ma'am, because of his age, his socioeconomic status, and where he hails from, we can, with his chief complaint of hypoanesthetic paths, we should think of Hansen's disease.
Why do you say it is type 1 reaction?
So because of the lesions were erythematous and tender, sir. Tenderness of the lesions.
Erythema, edema, more than the tenderness.
Erythema and tenderness.
Erythema, edema. Okay, that is the main thing, and the tenderness. Yes. Okay, but the only thing you have not explained why the two lesions are not reacting. If it is Hansen lesion, why they are not reacting? We are not coming to that. So the whole clinical discussion is clinical discussion. That has to be you have to really go into the clinicals. All right.
Investigations, complete blood count, his hemoglobin was 13.6 gram per deciliter. His total count was normal.
I think everything is normal, I think, no? I think
Yeah, don't go waste time here. Exactly.
it's normal, yeah.
Yeah.
Next slide.
His liver function tests were normal. Slitson smear was positive for lepra bacilli with a bacillary index of 2+, and on the biopsy findings, the epidermis was relatively normal. The dermis revealed epithelioid granulomas admixed with a few giant cells, and lymphocytes were noted, and perineural inflammatory infiltrate was present.
Biopsy from which lesion did you take?
Ma'am, biopsy was taken from the forearm lesion, ma'am. The left forearm lesion, the biopsy was taken.
Not with erythema, edema, not that lesion.
Ma'am, that was erythematous and edematous, slightly, ma'am. Okay. It was not as much as the chin, but it was slightly erythematous.
Because dermal edema is not seen in this, isn't it? Yeah.
Yes, ma'am. For type 1,
yeah, it has to be present,
yes.
Isn't it? Okay. Go on. Any special stain was done for the biopsy histopathology?
Ma'am, phytophoraco staining was done, ma'am. They have said it was possible, but not mentioned on this.
Okay.
Few bacilli.
Okay.
This bacteriological index 2+, does it support the classification?
So BT Hansen's usually have 1+ in the BI if you're suspecting borderline tuberculosis.
Is this the average BI of 4 sites or what is it?
So it's the 4 sites, the average BI of the
4 sites.
Yes, sir.
How many sites did you do? 4. Have
So
you done
the
that?
right ear, the right forehead, the gluteal region, and
okay, that is okay, significant, but it's still okay. It fits into BT, no problem. But then usually you get negative, not even positive. This very rarely we get positive, but you got it, no?
Yes.
Okay.
What are the differential diagnoses that you thought of in this patient?
Ma'am, because of the erythematous plaques, we also thought of subacute cutaneous lupus erythematosus, but there was no history of any oral ulcerations or photosensitivity present in him. And even tinea corporis, ma'am, but there was no history of any itching or any application of other medications for exacerbation of the lesion.
And the intertriginous
Areas were not involved.
What was not involved, you said?
The flexures, ma'am. The flexures were also not involved, ma'am. Then even because of the scaling and erythema, we should also think of other differences like atopic dermatitis, ma'am. That was also not present.
Why not lupus vulgaris?
Lupus vulgaris was the next differential, but he gives history of anesthesia, ma'am, which is not present in case of lupus vulgaris.
How, considering that if this patient did not have peripheral nerves or the sensations were very minimally impaired, how would you differentiate lupus vulgaris from leprosy?
Ma'am, one is the biopsy findings, ma'am. So there'll be more of well-defined granulomas and the more of neurotropic, like it's morely neural is more favorable in favor of Hansen's disease, ma'am. So in this biopsy, there was perineural inflammatory cells present, so that goes more in favor of Hansen's disease than lupus vulgaris. And central caseation necrosis is more pronounced in case of lupus vulgaris again, ma'am. In case of an epithelioid granuloma with central caseating necrosis, there's absence of necrosis in this biopsy.
Anything about the shape of the granuloma?
Oblong granulomas.
Yeah. Good. In
oblong granulomas in case of Hansen's disease.
Yeah, because they tend to go around the nerves. Okay,
yes,
right. Good. What about Gren zone?
Gren zone is usually be involved more in the leptomatous pole, so they'll be intact.
Yeah.
Intact, sir.
From which zone is, from which spectrum is it seen, the Gren zone?
From BT itself, it can be seen, sir, but it's more pronounced in case of the leptomatous pole.
Good.
What is, you said that the grade, what is the deformity you said?
Grade 2 deformity, ma'am.
Because there's amputation
there's a visible deformity which is present. If it is no deformity and no anesthesia, it's grade 0. Grade 1 is if there's only anesthesia with no visible deformity, and grade 2 is when there is a visible deformity.
What is the score that you give? What is it called?
EHF scoring system.
EHF stands for? Can you just
eyes, hands, and feet.
Okay, so what is the maximum score that you can get?
9, ma'am. 333. So it's totally 9, ma'am.
Is it 9?
12, ma'am.
It's 12. Why is it 12?
Ma'am, because the cornea, for the eyes, there will be up to 4, ma'am.
So it's like for right eye, left eye. So you
Right,
get right and left hand and right foot and left foot. Maximum is 12.
Treatment part, we can start him on MBMDT, multivascular multi-drug therapy. In that, initially it's given for about a year. Then it is like monthly we give rifampicin of 600 mg dosage, and along with that clofazimine 300 mg, and daily dosage of 100 mg dapsone, and also 50 mg of clofazimine daily. This is for 1 month, and this is repeated for another 12 months.
What is the exact number of days that these tablets blister pack comes for? Is it for 30 days, 31 days, or what is the total number of days that this blister?
28 days, ma'am.
Come again?
28 days, ma'am.
28 days. Okay. What are the instructions that you give when you give the blister pack to the patient?
Rifampicin has to be taken in the early morning, empty stomach. Dapsone at night. Dapsone should be taken at night, and discoloration of the urine, tears, sweat. Bodily fluids will have discoloration. So in case if they are wearing contact lens, that will also stain permanently.
We should also counsel them about clofazimine-induced pigmentation, because that's going to be a prolonged side effect, and the patient should be appropriately counseled.
What about dapsone? Yeah.
Dapsone, we have to look out for any anemia, or if there is any loss of deterioration in their orientation and sensation if they're going in for methemoglobinemia.
Yes.
And after 6 weeks, we should call the patient back to check if they have any dapsone hypersensitivity syndrome, if they develop any breast reaction or maculopapular rash.
Hemolytic anemia also. Yeah. Symptoms you have to ask whether the patient is having weakness. Okay. Then any other investigation you do before giving them?
G6PD levels.
Yes. They are more prone to develop hemolytic anemia.
How do you recognize dapsone syndrome? Dr. Anita?
There will be fever with morbilliform rashes, and hepatitis will be there with a derangement of the liver function with lymphadenopathy, and peripheral blood eosinophilia will be there with atypical lymphocytes.
What do you do?
Stop the dapsone.
Okay.
Stop him. And start him on steroids.
You're going to treat the reaction. Okay. First need, is there a need for admission of such patients, dapsone syndrome?
Yes, need for admission is there now.
Why do you want to admit?
Because liver function may cause that. It might lead to further failure of the liver. So we have to keep on monitoring that, and also the blood. He can go into hemolytic anemia. So
you want to monitor
to prevent further loss of at the dose of 1 milligram per kg body weight, early morning doses.
So how long will you give you're telling for this patient? I was asking for dapsone. Once the patient develops a dapsone syndrome, then further how do you continue with the treatment of leprosy?
And in case of paucibacillary, we substitute clofazimine in case of dapsone. And in multibacillary, we just omit dapsone and give rifampicin and clofazimine and continue the treatment.
With the rest of the drugs.
Yes.
That is sufficient. Okay. For this particular patient, you were saying, since he's type 1 reaction, what total duration of steroids that you would give?
Until the nerve function improves, we give at the dose of 1 milligram per kg body weight, and then slowly we reduce it by about 5 milligram per kg body weight and give a maintenance dose of about 50 to 20 milligram per kg body weight per day for a prolonged period of 2 to 3 months. And then we keep reducing the dose by every 5 milligram per week, and we give a maintenance dose of 5 to 10 milligram per day.
Okay.
How long do you want to give? Say, how long totally, stretching over a period of, what is the duration?
For borderline, like 4 to 9 months.
Is it the same in all cases, or what is the main aspect of the type 1 reaction which you are monitoring? Because the duration depends on that rather than on the appearance of the lesions.
Yes, sir.
What is it?
So as we taper the dose down, we have to see if there is any recurrence of the reaction, or if the patient is
Again, I am telling that rather than the erythema or the lesion, something else which you have to see. The neuritis, okay, it's a neuritis. If there's a neuritis, it may go on. If there's already early nerve function deficit, you will have to continue till the function recovers. If there's already an early paralysis, again you have to continue for longer time so as to probably hoping that the paralysis recovers, the early paralysis recovers. Okay, which is the one nerve which recovers faster with steroid, the fastest among all these nerve involvement? Which nerve recovers faster with the good course of prednisolone? Means facial, leg of thumb was improved very, very fast. Next in list is what? No, ulnar is the last. Ulnar doesn't. Foot drop. Common peroneal. Foot drop improves. Okay.
Thus, we conclude our session on leprosy today. I would like to express my gratitude to our faculties, Dr. Dandakishore sir, Dr. Jacinta ma'am, and Dr. Nandini ma'am for participating in today's session. I thank all the postgraduates for their active involvement.
I welcome Dr. Nandakishore sir, Dr. Jacinta ma'am, and Dr. Nandini for taking up the audience questions. Good morning, sir. So this is one audience question as to what are the parameters by which you decide whether a type 1 reaction can be managed by NSAIDs only, or when exactly do we need oral steroids in a patient of type 1 reactions?
Shall I say something?
Yes, sir.
Yeah. NSAID actually doesn't have much role. Okay, it doesn't have any role. Basically, the type 1 reaction is whether there's an associated neuritis or not. Now, neuritis again doesn't mean the nerve tenderness, nerve pain, or what the patient complains. Neuritis is nothing but a nerve function deficit. So look for the nerve function deficit. It's a nerve function deficit which detects a silent neuropathy. Okay, so that is the most important criteria based upon which you give oral prednisolone. Just erythema of the lesion without absolutely no evidence of neuritis doesn't warrant a steroid. And NSAID is more of a theoretical aspect of it, which doesn't have any role.
Nandini ma'am, this question is for you. Is there any documented mechanism for woolly-headedness which is produced by dapsone?
Document of evidence. There are a lot of some patients very rarely do complain that they feel little giddy kind of a thing, but not very common. Documentations.
Is there any mechanism per se, like why it produces? The student has asked why, because it's written that it's not given in the book. So why is there any reason like why dapsone produces woolly-headedness?
In any idea, sir?
I have not come across anyone complaining to me. Thousands and thousands of people have been started about dapsone over the what I know lengthy period of my service. As I said, some people talk about this woolly-headedness. No, but some people have insomnia. Okay, some people have that insomnia. They don't, what exactly is it, we don't know. And some people say, I don't tolerate this. Something happens to me. This has been very, very occasional complaints have been there. I don't like this drug. Something happens to me. So there is what is called intolerance. They are not able to explain. And woolly headed is a word which, some, I don't know, some textbooks might have used. I don't know whether there's any publication, I'm not sure. But then I would rather say that dapsone dependence is a real problem, because some people want dapsone, especially the good old days when we used to give for a lifelong dapsone and years of dapsone. They don't want you to stop dapsone. They want it to be continued. They say, without that, I don't get sleep, and something happens to me if I stop dapsone. There's a dapsone dependence was a real problem for the people who have seen those dapsone monotherapy era. And people on 7 years, 10 years, and lepromatous lifelong, it was like an addiction for them. Okay. Anyway, nowadays you don't have to worry about it because you don't give dapsone to that.
Jacinta ma'am, this question is for you. What is the best method to test for fine and crude touch? Like in the exam, what is students should do? Like what is the best method to test for fine and crude touch?
Fine touch can be examined or done by, you can use cotton swab, okay, for the fine touch, yes. Then other thing, what did you ask?
Crude touch, ma'am, crude touch.
Crude touch. Crude touch, I don't think so we do, okay. Only fine touch only it is done while examining, okay, yeah.
Nandakishore sir, this question is for you. One of the delegate wants to know, like usually the macules in TT leprosy, they are anesthetic. And why are the macules in lepromatous leprosy, usually why do they have normal sensation?
Oh, there's something basic in leprosy. One should know about it. See, it is a granuloma. This is a granuloma. In a anesthetic tuberculoid macule, when you say macule, it is what is known as maculo-anesthetic type of leprosy. Okay, it's called as maculo-anesthetic. The word is not being used. Otherwise, a tuberculoid, what you refer to, is not a macule, it's always a plaque. Okay, if it remains a macule, it becomes a maculo-anesthetic. And if at all you have macules in a borderline tuberculoid types, it is known as a macular type of borderline tuberculoid. Okay, I don't know whether the students need to know all these things at this juncture because it is going to complicate things for them. But if they know, it's well and good. Now, it is a granuloma which destroys the nerve endings, right? So it's a tuberculoid granuloma which destroys nerve endings, and not the lepromatous granuloma. Lepromatous granuloma, just the M. leprae happily multiplies inside the macrophages, become foam cells. It doesn't damage the nerve endings. It is a conversion of the macrophages into epithelioid cells, which is the one which damages. Okay, it is the CMI which damages the nerve endings. So that is everything about leprosy hovers around this. So greater the loss of sensation, greater is the tuberculoid granuloma, more does it go towards the tuberculoid end of the spectrum. Lesser the damage, more the lepromatous granuloma, and lesser the loss of sensation. So macular leproma has normal sensation. Okay.
Yes.
I hope I answered that.
Yes, thank you, sir. Nandini ma'am, this question is for you. Generally, if clofazimine is not available, what is the usual drug you would substitute it with? Because in some centers, at times, clofazimine is not available for multibacillary MDT. So what is the usual drug that you would prefer using, ma'am?
I would like to use minocycline, 100 mg, once daily.
Okay, ma'am. Nandakishore sir, this question is
for us actually, there are a lot of, if there's any government hospital, or for example, even in ours is a private, but still the government supply is there. Even clofazimine 100 mg, they give extra other than the MDT blister packs. If you request for it, they give like 100, 200 capsules of this clofazimine. One can make use of that. Okay. That's my suggestion. Okay.
Nandakishore sir, any additional input, like if clofazimine is not available, like which drug would you usually substitute
I
with?
feel that clofazimine non-availability is not there if the government supplies it. It supplies. It is not available in the market. But somewhere it may be. Right now in Mangalore we have the difficulty. But then the government has a supply and they are doing fantastic job because they are giving this. There may be a short supply here and there. A few days, some patients might have had that, but then it's okay.
there is no, as far as I know, there is no recommendation, but ofloxacin or minocycline, as madam said, is one of the drugs which can be given. And people who refuse clofazimine, there are some people, youngsters may refuse, you substitute it with ofloxacin. So that, one thing is that if at all the ofloxacin, you can always see, there is a way of seeing its resistance on a later date. There's a method. Okay. So, we have the Guairea gene, we know, which encodes for the resistance. So there's a way of knowing resistance. As far as minocycline resistance is not easily detectable. Okay.
And minocycline have the anti-inflammatory effects.
Exactly. Yeah. But you mean to say, ma'am, minocycline, right?
Yes, correct, sir.
Okay. Yeah, that may be there. Yeah, minocycline. And for the erythema may come down a little.
Yes.
Especially in a type 1 reaction. No, both of them are good enough. I'm not saying anything about it, but then good enough.
Nandakishore, sir, this question is for you. Is there any clinical test by which you can test all the nerves of the hand by a single test as a quick measure? Can you test all the nerves by any particular test?
Oh, is someone in a hurry? Okay. Someone in a hurry to test. All right. Doctor, always I show this. I think someone knows about it. I think that's why. It's Dr. Fritchie. It was Dr. Fritchie. He was my teacher. Ernest P. Fritchie, who is a Swedish surgeon. Now, he did this. I don't know whether you are able to see this?
Yes, yes. Your hand is visible.
Okay.
Yes.
Yeah. Just, I don't know whether. Okay. Now, this is a position.
Yes.
Okay. I don't know whether. See, in this position, you can see my thumb opposing the little finger. Okay, thumb opposing the little finger, something like a rabbit. Okay, bunny. Okay, or a peacock, whatever you call it. Right, something like this. Now, here the thumb is abducted and opposed. Right, that means your median nerve is fine. Now, your little finger is in a lumbrical position. In this position, the little finger is in a lumbrical position. 90-degree flexion at the MP joint and 180-degree extension at the IP joints. So that means your lumbrical is fine, your median nerve is fine, your ulnar nerve is fine, and your wrist is in a dorsiflexion here, right? So your radial nerve is fine. So within a few seconds, all the nerves are normal. So this we used to do when there was a heavy OPs, 100, 150 leprosy patients waiting for their dapsone. So we just asked them to do like this, good old days. Fine, you can't go on doing it. You can't go on testing individual muscles. So this is a shortcut. Yeah.
Yes. Okay, sir, we are done with the audience questions. So I thank Nandakishore sir, Nandini ma'am, and Jacinta ma'am for having joined us again and beautifully moderating the session on leprosy. Thank you very much.
Thank you.
We will resume with the next session shortly. Kindly stay tuned. We will resume the next session, which is going to be on sexually transmitted diseases, where genital ulcer disease will be discussed. Kindly post your questions pertaining STDs into the chat box, which will be taken at the end of the session. I now request the host to connect with the residents on the case of genital ulcer disease.
Good afternoon, all. I welcome you all to the case presentation of Sexually Transmitted Diseases, Part 1 of eDerma Advance 2021. The esteemed faculty who will be conducting this session are Dr. Somesh Gupta, who is the Professor of Dermatology at the prestigious All India Institute of Medical Sciences, New Delhi, Dr. Jaydev Bekkerur, who is the Professor of Dermatology at JSS Medical College, Mysore, Dr. Nanjunda Swami, who is the Professor and HOD of the Department of Dermatology at Mysore Medical College, Mysore. I welcome you all to this session, sirs. The case will be presented by Dr. Fahadullah Khan from Mysore Medical College. The other residents who will be participating in the discussion are Dr. Pujita R and Dr. Shazia Kalam from JSS Medical College and Dr. Amulya YS from Sri Devraj Aras Medical College, Kolar. Over to Dr. Fahadullah Khan.
Good evening, respected professors and my dear friends. I do present a case of a 38-year-old male who is unmarried, presented to our OPD with history of since 2 weeks. History of presenting illness. Patient was apparently normal 2 weeks ago. He initially developed a raised painful lesion on the dorsal surface of his glands, which over a period of 1 to 2 days developed into a pus-filled lesion, which over a period of 24 hours developed into an wound, which initially was the size of a gram, which gradually increased in size with the development of other new lesions in the surrounding area. The lesion was painful. There was blood discharge from the wound on manipulation. After a week of appearance of the genital sore, he noticed swelling in the right groin, which was painful, and it used to interfere with his daily activities. He says that there was difficulty in walking because of the pain in the groin region. The genital lesion started 7 days after an act of unprotected sexual encounter with a known lady. There was no, it was not under the influence of alcohol or any other substance. There is no history of similar lesions elsewhere in the body, that is oral, anal, or extremities. There's no history of fever, malaise, arthralgia. There's no history of lesions over skin, palms, and soles. There's no history of swelling of genitals, painful erection, difficulty in retracting the foreskin. There is no history of passing pain during defecation, discharge per rectum, or bleeding per rectum. There is no history of fluid-filled lesions on the genitals, burning sensation on urination, or discharge per urethra. There is no history of genital ulcers or ocular lesions in the past. There is no history of instrumentation or catheterization in the recent past. There is no history of drug intake, trauma, topical chemical agents used, or condom allergy. There is no history of multiple swellings in the axilla and neck. There is no history of weight loss, pain abdomen, loss of appetite, recurrent cough, or diarrhea. Sexual history. He's single, unmarried. He's heterosexual. First sexual encounter was at the age of 17 years. He's promiscuous. Last or recent contact was 7 days back with a known lady. It was a genital penetrative nature of a sexual encounter. It was unprotected. There is no history of oral sex or anal sex. The symptoms in the partner could not be elicited. Treatment history. No history of previous treatment or treatment for any feature suggestive of sexually transmitted diseases. Past history. Patient is not a diabetic, hypertensive, no history of atopy, no history of tuberculosis or epilepsy in the past, no history of undergoing any surgery or blood transfusion in the past. There is no history of urethral discharge or swelling of fluid-filled lesions over the genitals in the past. Personal history. Diet is mixed, sleep is good, bowel and bladder habits normal and regular, appetite is good. He is a smoker. He smokes 5 to 6 cigarettes per day from past 5 years. He has a habit of consuming alcohol. He consumes alcohol on weekends with
promiscuous. So what is the importance in this case? He's promiscuous.
Sir, he gives promiscuous. he's in the past. We need to know the sexual encounters in the past 3 months, sir, to know the maximum incubation period of some of the STDs, sir.
So apart from, what was the previous? When was the previous sexual contact?
Seven days back, sir.
No, after before that, after the 7 days. Contact was
that in the past 3 months, she had 2 counters, sir. Other one was an unknown lady, sir.
Okay.
The unknown lady was a protected sexual intercourse, sir. He had used condoms during that time. He was not under the influence of alcohol, any substance.
Would you like to know the place of contact in this case? Or what is the importance of that?
Route of contact, sir?
No. Place. Where did he have a contact? Do you want to know that? Would you like to ask why?
High risk group, we want to rule out if the person is.
Would like to clear in this case. Let's see whether you can
trace the contact. Okay.
So you should know where the place of he's promiscuous. He may be having contacts at different places. So,
commercial.
So last contact, at least you should know which place. Maybe you should be able to
trace back.
Contact trace. Okay. I'll leave it to Sumesh now.
What do you mean by promiscuous?
So promiscuous is a frequent change of partners. He's very frequent in changing his partners.
Okay, so what can you tell me the total number of partners, lifetime partners?
So partners in the past 3 months, he says that he had 2 partners, sir, but lifetime partners couldn't elicit that history from him, sir.
Okay, and the nature of sexual exposure, you said it was vaginal, right?
Yes, sir.
And no other kind of exposure?
No history of oral or no history of anal sex. He denies history of oral and anal sex, sir.
Okay, and did any exchange involved, exchange of money or gifts involved in the sexual exposure?
Sir, she is a known lady. She is a known lady, sir. She, during this act, there was no exchange of money or gifts, sir. She was a known lady to him, sir.
Okay, right. And the previous sexual exposure was with a different.
Sir, the previous exposure was with the same lady 2 months back, sir, and another lady which he didn't disclose the name, sir, but he says he was an unknown lady, and that was his first encounter with that lady, sir. It was a protected encounter. He had used condoms at that time, sir.
And when it was?
It was 2 months back, sir.
2 months back. So only 2 partners.
In the past 3 months, only 2 partners, sir.
Okay, that's why it is important to also ask and explore about beyond 3 months the number of partners. That will help you in the counseling in the end of your treatment, or when you start the treatment of the patient. Amulya, yeah. Amulya, sorry for being fussy on that, but the current terminology doesn't involve, it is not politically correct to call commercial sex workers. We generally call female sex workers or male sex workers.
Male sex workers, yeah.
Because we also work for money as doctors, but we don't call ourselves as commercial doctors.
Yeah.
Dr. Pujita?
Yes, sir.
Sir, what is your diagnosis at his history level?
Sir, history level.
Yes, sir.
Since there was I would like to go with my first diagnosis as chancroid, sir. Since after
Right.
sexual intercourse, after 7 days, he developed painful lesions, sir. So painful lesions, painful genital lesions, we can think first of chancroid, and the other one is herpes genitalis, sir. And also, there's also swelling of in the groin region, which is unilateral swelling, sir. So it's most commonly seen in chancroid. In herpes, it is mostly it's bilateral. So in history level, I would like to give my first diagnosis as chancroid.
Why not syphilis? Why not syphilis?
So syphilis mostly
Syphilis.
painless lesions, sir. The genital lesions will be usually painless until and unless there is secondary infection. That time it can become painful.
What is your opinion? Is this a normal presentation of chancroid or any atypical presentation?
It looks like a normal presentation.
Typical or atypical?
Typical, sir.
Genital ulcer disease, unusual presentation. Because we are in HIV era, so we have to expect some unusual atypical presentations.
Yes, sir. The lesions can be in if it is superadded with HIV.
For example, painless ulcers in chancroid.
Yes, sir. In case of HIV,
or painful ulcers. Painful ulcers in syphilis. These are the atypical presentations.
Yes.
In the HIV era. Possibly.
Yes.
Excuse me, sir.
Hemorrhagic.
Sorry to interrupt. If we could proceed with the examination.
Okay, sir.
Yeah.
Okay.
Examination part. A moderately built and nourished male patient, conscious, cooperative, oriented to place, person and time. There is no pallor, icterus, clubbing, cyanosis or edema. There is right inguinal named adenopathy, which will be described further. White pulse rate was 72 beats per minute, right radial pulse, regular, respiratory rate 16 cycles per minute, blood pressure 124 by 86 millimeters of mercury, supine position right brachial, temperature afebrile. CNS examination, higher mental functions are normal, no focal neurological deficit. Cardiovascular system examination, S1 and S2 heard, no murmur. Respiratory examination, normal vesicular breath sounds heard, no added sounds. Trunk appears to be normal. Upper and lower extremities, no abnormalities detected. Soles and palms, no lesions seen. Nails, fingernails were normal, toenails were normal. Ocular examination was normal. Visual acuity was normal. Genital examination, a male patient, uncircumcised, multiple ulcers over the coronal sulcus and inner prepuce with ragged edges, largest measuring 1.5 to 2 centimeters in size, present over the prepuce. Its floor shows yellowish purulent material and granulation tissue. It's surrounded by a rim of erythema. It's tender on palpation. There is no induration. It bleeds easily on manipulation. Urethral meatus appears normal. Penile shaft appears normal. There is no edema or ulceration. Scrotal skin is normal in color, no edema or swelling seen. Testis is normal in position, non-tender, firm in consistency, mobile, and normal testicular sensation appreciated by the patient. Perineum and perianal region, no ulcers, no warts, and no discharge. Per rectal examination, on inspection, there are no scars, there are no erosions, there is no discharge or hemorrhoids. On per rectal examination, there are no masses palpable. An anterior wall is smooth, lymph nodes were enlarged, they were tender and adherent. There was local rise of temperature over the swelling, and overlying skin appeared normal. Examination of the skin, there is no rash, no ulcers seen. Oral, anal, and conjunctival mucosa were normal. There was no redness, there was no discharge or ulceration. Musculoskeletal examination of bones and joints, there was no tenderness, there was no swelling or restriction of movement of any of the joints of the upper and lower limb. A provisional diagnosis of chancroid with inflammatory bubo was made.
Now, what more examination findings on the genitals you would like to elicit to make your because it's a virtual case. So there is a mention that there is some bleeding on manipulation. So do you think there should have been some other information available to you to make a diagnosis?
Sir, if there was bleeding on manipulation, maybe a photo of that would have helped also to know if there was
Yes.
actually any bleeding on manipulation.
Yes, that is one way of, see, you should have taken a photograph of manipulation, bleeding on manipulation, because you told the same thing in the history also, but there is no evidence, because that will add to your diagnosis much more than just saying that there was bleeding on manipulation. Okay, that is very important.
ಏನ್ ಇಷ್ಟಪ್ಪ ಕಾಣ್ತಾ ಇದ್ದೀನಿ.
Okay, I'm checking it. I don't know what the issue is. Let me check. Why is the volume not heard suddenly? After that Zoom got something happened then.
This is our recorded video.
Recorded video.
Did you optimize?
Yeah, I have optimized it. From morning it's working.
Yeah, I think video.
I know.
Necrotic base or the slough or the edges, how were the edges of the ulcer in this patient?
So the edges were ragged, and also there was erythematous hue around the edges. Most of the borders of the ulcers had erythema, sir. Most of the ulcers. Floor of the ulcer.
Sure. And could you appreciate
importance to or value to your diagnosis of whatever done. I'll now hand it over to Dr. Somesh or Manjun Swami to further.
Okay, yeah, thank you for elaborate examination. I agree that in a case of STI, sometimes you can just need not to elaborate on negative findings of systemic examination, but just focus on the positive findings on the genitals. It doesn't mean that you have to omit the systemic examination or general physical examination, but at least in the description it should be very clear that sometimes it is reverse. You present the mucocutaneous examination first and then say that the other systems are normal and the general physical examination is all right. Were there any kissing ulcers on the undersurface of prepuce as well as on the glans? Like any pattern, any such pattern was there? Even if it was not there, a sentence about it, a statement about it, its absence would be helpful. So, Fahadullah, what do you say about it?
Sir, I mean, in the first picture, there were two ulcers side by side, sir. And one ulcer was under the, around the prepusal skin that looked like a kissing ulcer, sir.
Okay, kissing ulcer. So that's an important finding which you should not miss. Then, okay, Fujita, can you tell us what are the part of the external genitalia of the men where you have to examine in such a case, particularly in the penile shaft, scrotum? Like, what are the? Just can you quickly enumerate on that?
So we should look at the coronal sulcus, prepuce, the subprepucial area, frenulum. They are commonly affected, sir.
Okay. What about external urethral meatus?
External urethral meatus we should look for any erythema or discharge from the
And skin of the scrotum you mentioned.
skin of the scrotum.
Okay. Perineum, perianal area, pubic region, buttock.
Yes, sir.
Right. You may find another STI, concomitant STI, in a person who has high risk sexual behavior, right?
Yes, sir.
So the examination should be complete. And did you, in the slides, could you appreciate the base, necrotic base, or the slough, or the edges? How were the edges of the ulcer in this patient?
So the edges were ragged, and also there was erythematous hue around the edges. Most of the borders of the ulcers had erythema, sir. Most of the ulcers, and there was yellowish slough on the floor of the ulcer.
Floor of the ulcer. And could you appreciate the depth of the ulcers? They were shallow or deep?
Most of the ulcers were shallow, sir.
Okay. Okay, Shadia, was there any pattern of distribution, like any kind of grouping, or they were randomly distributed, scattered?
Like randomly distributed rather than grouping.
Right, that is important. Was there any perilesional erythema in these ulcers?
Yes, sir.
Or was it mentioned by Fahadullah?
Yes, sir.
It was mentioned. Okay. Yes. Right. That's all from my side. Thanks.
How long the ulcer will stay? So the patient does not seek treatment. How long do you expect the ulcer to stay?
2 to 3 weeks, sir.
What is modified chancroid?
Amulya, sorry for interrupting here.
Yes, sir.
This is a very important question. How long these ulcers will persist if not treated? You said 2 to 3 weeks?
Yes, sir.
That's not correct. Chancroid doesn't heal spontaneously, unlike genital herpes or primary chancre, right? If your diagnosis is chancroid, then they will persist unless you treat them, because they don't. You should remember the chancroid doesn't have any subclinical stage in men, and the only source of infection is clinically appreciable lesions on the genitals, that's why chancroid always comes in clusters. You don't see sporadic cases. You generally see many cases coming together or in a span of few weeks to few months. That question was very important to address. Sorry for interruption. Yeah.
If not treated, what are the complications which the patient will land up? Complications.
Melanopostosis, sir. Phimosis.
Oh. Okay, phimosis.
Rupture of the bubosa. Fistula formation.
Yes, okay, good. Rupture.
Secondary bacterial infection can occur, sir.
Like which organisms are known for that?
Streptococcus. Fusospirochetes streptococcal infection.
Then? No. What is a pseudo-chancre? Pseudo-chancre. Pseudo-chancre.
Yes.
No, pseudo-chancroid. You first tell pseudo-chancroid. Pseudo-chancroid.
Like chancroidal ulcers, sir.
Okay. What is pseudo-chancre? What is chancroid redux? You have to read the word.
Excuse me, sir.
Chingon Nicole, huh? Okay. Over. Time is over.
If we can proceed.
Okay, continue. Proceed.
Routine investigations were done. Complete blood count shows hemoglobin of 17 grams per cent. WBCs were slightly on the higher side, 11,620, with the neutrophilic leukocytosis, and eosinophilia was noted. LFT, RFT, and routine investigations were done, which appear to be within normal ranges. ESR was 12 millimeters per hour, and RBS was 130 milligrams per DL. Urine routine shows 1 to 2 pus cells per high power field, 2 to 3 epithelial cells, and albumin and sugar were nil. HIV was test for HIV, ICTC was non-reactive, HbA-CG was negative, and VBRL was negative. A gram stain from the smear was done. Gram stain shows multiple gram-negative cocobacilli, which some arranged extracellularly, few intercellularly in clusters of short and school of fish appearance. And a hyperbo view showing gram-negative rods in typical rows in a smear of genital organs. Gram stains, multiplex PCR was advised but could not be done because of COVID issues, and culture was also advised but patient couldn't do it. IgG, IgM for HSV1 and 2 were advised because of financial constraints. Patient did not afford for it.
So, are you sure the inguinal lymph node qualifies for bubo?
So it was an inflammatory bubo, sir. It was on the
How
right.
you define bubo?
Right.
How you define bubo?
Swelling of the inguinal lymph nodes in general is called as
or a peculiar
superficial inguinal group of lymph nodes.
No, not really.
Yes,
underneath a fluctuant
yes,
pus, that
yes,
is known as bubo, right?
Yes, sir.
So now, after
Yes,
knowing this, are you sure it was a bubo?
Sir. It was just a tender inguinal lymph adenopathy, sir.
So call that adenopathy rather than a bubo. Yes, bubo is a very different. Okay.
Yes,
Can I ask? Yeah, one question to you. If so,
Sir, I go to the diagnosis, sir. First of all, history-wise, it is painful lesion, and also on examination, it is discrete lesions with yellowish slough and pain, tenderness is there, and unilateral lip node enlargement, which is also tender, sir.
okay. And incubation period fits well with the shrink?
Yes, sir. 7 days, it fits well. History-wise also it fits well, sir. So after 7 days of exposure, sexual exposure, he developed lesions in the genital area. And after 1 week after the lesions of a genital area, he developed lymph node enlargement, sir.
Okay.
Also there was tenderness
Right.
in both the...
Tenderness. Oh, okay, okay. Shazia, Fahadullah mentioned about MPCR. What?
And 2, all the 4.
Okay, so quadriplex PCR. Right. So quadriplex PCR, by just looking at the, because he could not do patient, this test could not be done, right?
In a mixed genital ulcer, they could have like simultaneously chancroid and chancre could be there.
Or any other combination?
Sir, herpes genitalis and chancroid also, sir.
So any of these 4, right?
Yes, sir.
Any of these 4, HSV2, HSV1, or Haemophilus ducreyi or Trichonoma pallidum, any of these organisms can present in different combinations, and when they present in combination, then the presentation, clinical presentation may not be very typical. Okay, my next question is to Amulya again.
Yes, sir.
Yeah, Amulya, can you tell me about these IgM and IgG HSV? What is that?
IgM indicates active recent infection, sir, and IgG indicates infection which was long back, sir.
Okay, so if a person is having positive IgG for HSV1 and 2, what does it mean in this patient?
He, in the past history, he has a past history of having infection with the HSV1 virus and 2 virus.
Okay, so you want to order a specific HSV IgG or a non-specific IgG1 for HSV1 and
IgG1 we would want to know, sir.
IgG1, HSV1 for IgG for HSV1?
Yes, sir. IgG1 of HSV1.
Okay, Shazia, do you agree with her?
Sir, for the current infection, you would have to look for IgM of HSV2 because genital ulcers more commonly are caused by HSV2.
But if you want to screen for HSV, which test you want to order?
Sir, other than the IgG?
No, in IgG. If you detect IgG for HSV1, what does it mean?
It means that the patient has had previous exposure to HSV, sir. So, considering it as a DD.
See, HSV1 is extremely common in adult population because you acquire HSV1 most of the time during the childhood. I may be carrying, you may be carrying HSV1 IgG antibodies without knowing. The study from Pondicherry suggests that even up to 60 to 80% of population carry IgG HSV1 antibodies. So when you ask for IgG antibodies, there is no point of asking for a non-specific IgG for HSV1 and HSV2. You have to specifically ask for HSV2 IgG, right? Because if that is positive, means patient had acquired HSV infection type 2 sometime in the past, right? But if you detect HSV1, it doesn't carry any meaning because it is transmitted through non-sexual routes, right? Okay, I will come back to again. I'm taking too much of time. In the meantime, carry on discussion. Yeah.
Fadula, you did VDRL
in
this patient. Are you justified in doing VDRL in this patient? If it is negative, and when would you like to repeat?
Sir, it was negative in this patient. It was
fine.
2 weeks
it is
after.
negative.
Yes, sir.
My question is, what is the importance of doing VDRL now in this patient, and when will you repeat this VDRL?
Sir, repeat will be done after 3 months, sir.
My first question, first part of the question. What is the importance of doing VDRL in this patient?
Sir, to know positivity, but as the infection was of 2 weeks duration, the titers would have been positive if it was.
You said 7 days back he developed ulcer. 7 days back he had contact. So it was 1 week
7 days
old.
was the contact. 7 days was the contact before the development of ulcer, sir.
Okay.
So
he came to you after 1 week after developing the lesion.
Yes, sir. Yes, sir. He had evolution of the ulcer, sir. It was he had that evolution period, and then because of the pain and blood tinge
2 weeks is enough for you to get a VDRL positivity.
Usually 2 weeks, it becomes positive, sir. But if it is negative at that point, we need to repeat it after 3 months of duration.
Okay. What if it was positive? What would be your inference if it was positive?
It would be a mixed chancre, sir.
Mixed chancre.
As
okay.
Gram stain showed positive. Gram chain shows the
Anybody want to differ? Pujita, you want to add anything for this?
Sir, if it is positive, then there's 10% of chances where there is chancroid and chancre which can occur together, sir. So mixed chancre is one possibility for.
There are so many other possibilities. This patient is a promiscuous patient, right?
Could have acquired afterwards.
So he must have had some infection earlier also. So VDRL positivity does not mean it is at present. It can be of older, this one for which he has not taken treatment, or it must have a transient lesion might have been there. So it does not mean that the VDRL positive in this patient indicates only the present situation. It could be an older one also. So you said, I asked you, when will you repeat? This patient is VDRL negative. So 2 weeks old exposure. So when will you repeat VDRL? Shazia?
If this test was negative, the next repeat is at 3 months.
After?
3 months, sir.
3 months. Okay.
If it was positive, sir, then we have to repeat after 1 month to look for fall in titer.
You are just saying, just suppose it. If after the infection, generally the VDR will become positive at about 1 month. So if it is negative, then repeat at 1 month. If it is positive, then repeat at 3 months.
You should repeat after 1 month. You should repeat after 1 month because it is negative. So 1 month from the history of exposure, you must repeat. That means 15 days from now, you should repeat, see whether it is positive or negative. Then you can do it after 3 months. Okay. So that is the way, because you said it is negative. It could be still negative because it's just 2 months. An added chancre here in this patient, it might be of an older exposure in which he might have had an probably a very transient lesion, or it might not have noticed the whole thing. So it does not mean that this patient, if it is
at 35 degrees Celsius, sir.
What? Is that the reason for that? Temperature can be controlled, no? Anybody else? What is the difficulty in Fadilla? What is the difficulty in culturing?
It needs a microaerophilic environment. It needs a microaerophilic environment of 5% carbon dioxide, temperature to be maintained between 32 to 35 degrees centigrade. It is a fastidious organism which requires a hymen or factor 5 for its growth. It is that is the so Muller-Hilton agar or chocolate agar supplemented with calf serum or lice whole RBCs are added to modify it, sir. Then we have factor.
So with all these, you can grow it easily, but that is not done. It's very difficult to grow, sir.
How do you take specimen in this? How to take specimen?
Yes, sir. So first we'll have to clean it with saline and hold the chancre, the ulcer between the index finger and the thumb, and using a cotton swab with calcium alginate, we need to take the specimen, and it has to be, since it's a fastidious organism, we have to transport it within 2 to 4 hours, sir. And then we'll have to culture it in Muller-Hilton agar.
How do you take specimen in LGV?
Sir, LGV, more than the inguinal swelling, we have to. It's more specific if we take it from the ulcer itself, sir. So we have to take the. If we are taking it from the bubo, we have to inject saline into the bubo, and after that we have to draw the contents and then.
Saline is injected for syphilis, not for this.
Distal.
Okay, it is saline is injected into the lymph node in a case of indolent bubo, okay, because you cannot aspirate anything. Why you are injecting saline in the this one?
Distilled waters.
Distilled water. You are talking about LGD, right?
Yes, sir.
Okay, Pujita.
Yes.
What is the role of dark ground microscope?
Sir,
Dark ground microscope.
to identify the treponema.
In this this particular case. Microscopy.
To know if there is a super added, I mean, if there is a mixed chancre also, if there is an added chancre, rule out that.
What are the classical movements of syphilis?
The jerky.
Dark ground microscope.
Jerky and rotational movements, sir.
Rotation. Corkscrew movements.
Corkscrew.
Screw movements are common.
Lastly, I think you should remember when we were talking about ulcer duration. Among the 4 ulcerative conditions, does not heal, and also the granulomagneurium. Okay, donomanosis. It also does not heal on its own. It tends to persist and extend unless it is treated. Of course, presently I don't think everybody considers donomanosis as one of the this one. So still, so in when you are taking the history, you should know about all these things, and while presenting also. Saying that it will heal on its own is not correct.
Yeah, and so, what we could not discuss because of the lack of time is about the treatment, syndromic management, and the kits provided by National Egg Control Organization, and how to follow up, do a follow up, when to call the patient back, and how to treat the partner, for how long the partner we have to treat, the contact tracing, call the partner, or if partner can't come, provide one kit for the partner also. So all those things are very, very important, and always screen for HIV and do the counseling. Counseling about HIV, counseling about STI, counseling about safe sexual behavior, so that patient doesn't get another infection in the future.
See,
very well done.
Anyway, what will be your drug of choice in this case, Dr. Fahadullah? Last question.
Sir, for a single dose, azithromycin 1 gram start can be given, sir.
Okay.
Drug of choice, we have azithromycin, they have ciprofloxacin 500 mg, a BD for 3 days, sir, or a single dose of a ceftriaxone injection 250 mg iron stat, sir, or you can even give a clindamycin 400 mg, 500 mg TID for 7 days for the patient, 7 to 10 days for the patient, sir. And even for the partner management as well, sir. When we go to kits, you can give him a kit, blue kit.
There was one discussion about it could be a mixed chancre, right? Chancre and
yes,
chancroid.
So, yes, sir.
Chancre
so
and chancroid. Which drug would you like to choose in this patient, in such case?
Cotrimoxazole. Cotrimoxazole can be given, sir.
Why?
If it was it would have cured the chancre, but not the chancroid, but not the chancre, sir.
Okay.
A trial trial like on the OPD basis, just to find out whether it's a chancre or chancroid or a mixed infection. When you give cotrimoxazole, chancroid would have been responded to the drug, but chancre would not respond to the drug.
Excuse me,
final comments by Somesh, I think.
No, it was very well done. But that so this case, chancroid is becoming uncommon. We discussed genital ulcer disease, and also if we treat in a syndromic management, we have to treat for both syphilis, chancroid, and unless the patient gives history of recurrent ulceration, than we treat for herpes. So anyway, good discussion. You covered most of the salient points.
Thank you very much, esteemed faculty, for your wonderful inputs. I also thank the postgraduates, Dr. Fahadullah and Dr.
I welcome Dr. Somesh Gupta sir, Dr. Jaydev sir, and Dr. Nanjan Swami sir to answer the audience questions. Jaydev sir, can you hear me?
Yeah.
Yes, sir. There's a question from the delegates. Why are the ulcers in syphilis painless and chancroid painful?
I think the PG should answer that question. They should be knowing it instead of asking me the question. Why? If it's a PG question, examination question, in the Viva, why this one is painful? Probably, I think they will find it. They may not find it in the textbook. Anyway, it is because of the intense infiltration, plasma cell infiltration, and also end arteritis obliterans that causes the death of the nerves in syphilis, and that's why it is painless. Whereas there is edema, severe edema, and inflammation in case of chancroid, and that is the reason why there is severe pain in the chancroidal ulcers. Whereas here it is a dense infiltration causing and arthritis also. I think Somesh is there.
Yes. Yeah, I agree with you. Yeah. Yes, sir.
Somesh sir, this question is for you. In syndromic management of genital ulcer disease, why partner treatment is not necessary in a patient of genital herpes?
Okay. So partner treatment is not necessary because genital herpes is not a disease which is one-time occurrence, and if you give the treatment, the patient relieves permanently because the herpes remains asymptomatic in many individuals, and even in some patients, in between the episodes, patient doesn't have any symptoms. So unless there is an active infection in the partner, unless there is an active infestation, infection in the partner symptoms,
Okay, no problem.
then only we treat the partner, otherwise we don't treat the partner.
Yes. The next question, sir, Jaydev sir. If a patient presents with genital ulcer and a concomitant bubo, which kit for syndromic management would be better in this patient, sir?
With bubo?
If a patient has a genital ulcer and a bubo concomitantly, which kit should be better?
I don't think I'll be able to answer this question. I think I'll refer it to Somesh for.
Yeah. So whenever there is genital ulcer, treat genital ulcer. That is the thing. Because the only other condition which can give rise to bubo is LGV, and in LGV the primary lesion is very transient. So generally you don't see any primary lesion in LGV. So in case if you see genital ulcer and inguinal bubo, give preference to the genital ulcer. Inguinal bubo can have two causes. One is that it can be because of the chancroid, or it can be because of the syphilis with secondary infection. And the third cause is lymphogranuloma venereum. So if you treat syphilis and chancroid, then your job is done, because LGV generally doesn't have the primary lesion on the primary lesion in the form of an ulcer.
Thank you, sir. Somesh sir, this question is for you. What are the? Is there any particular reason why a bubo in chancroid is unilateral and unilocular and LGV multilocular?
In a PG question. Again, a Viva question.
Yes. So multilocular and unilocular, because the chancroidal bubo is generally an abscess, originating from the lymph node. And in lymphogranuloma venereum, because of the lymphotropic nature of the organism, it causes lymphatic blockage, and that leads to a multilocular bubo. I'm not very sure if I'm very accurate in my answer.
Thank you.
It is said that it is periadenitis that occurs in case of chancroid, and that leads to destruction of the uh, mm, uh, lymph node wall, and that leads to an unilocular abscess. And in case of LGB, there is nothing like that. So it remains the in multilocular. So there is no destruction of the lymph node walls of the lymph nodes, and that leads to multilocular in case of LGB. Whereas in chancroid, there is the destruction of the walls of the lymph nodes, and that leads to unilocular abscess in case of, or unilocular bubo in case of chancroid. That is what is the older description.
Yes. Yes, sir. Jaidev, sir, there's another question. What is the difference between persistent urethritis, recurrent urethritis, and post-gonococcal urethritis?
Why this has come here? It should go to the genital discharged question, I think. Okay, so let them ask the genital
There is
discharge.
actually no session on genital discharge. There's only another session on genital warts.
Oh, okay. The expert is Somesh to answer that. He has written the chapter on that.
Yes, sir. So persistent urethritis can be because of because we have covered all the organisms with the exception of trichomonas. So persistent urethritis can be because of the trichomonas, or it can be because of the drug resistance. Now, generally, chlamydia is not a drug resistant. There may be drug resistance in gonorrhea because it is it is becoming very common and very troublesome. Or it can be because of non-gonococcal, non-chlamydial infections such as Mycoplasma genitalium, which may be resistant to azithromycin. So these are the causes of persistent urethritis. Now, recurrent urethritis can be because of if you treat the patient and if you don't treat the partner, there may be ping pong phenomena because patient gets infection again from the partner if you haven't treated the partner well. So, and the recurrent urethritis can be because of non-sexually transmitted infections as well.
It can be even herpes also, recurrent. So herpes also can be in the intraurethral infection. So you may get recurrent infection as and when there is a recurrence of herpes also. So that can also occur.
Okay, we thank Jaidev sir and Somesh sir for having answered all the audience questions. Thank you very much, sir, for your time and for excellently moderating the session. Thank you, sir.
Thank you.
Thank you.
Yeah, we
Enjoy.
break for
Thanks.
lunch. Yeah, thank you, sir. We break for lunch and we'll be back with the next session at 1:45.
What is there for lunch?
Packed lunch, sir.
At home?
No, sir, in the department.
For you, for us, it is at home.
Yes.
Thank you.
Yeah, thank you for making time.
Thank you.
Thank you. Yes,
Bye-bye.
thank you, sir. Yeah, bye-bye.
Dr. Ramina, are you there?
Hello, yeah, yes, I'm there. Can you hear me?
Yeah, I can hear you. But your voice is a little bit breaking. Is it? Can you check it once?
Yeah, just one second. Hello, is it better now?
Yeah, it is better now, doctor.
Okay.
So I'll put a timer of 7 minutes. So
Okay.
we start at the end of 7 minutes. Is that fine?
Yes, yes.
Yeah.
I hope my video is okay.
Let me see. Yeah, it's good.
Yeah.
And keep your WhatsApp on. I'll be communicating everything on WhatsApp, nothing on Zoom. I won't be speaking on Zoom.
Okay.
Yeah, that's it.
So I'll mute myself and start when you ask me to start.
Yeah. Now you can mute yourself. I'll be telling you the time. I have already set the timer.
Okay.
So it'll start in another 6 minutes.
Okay. Okay, fine.
Hello?
Yeah, Ashik.
Yeah, doctor.
Yeah, whatever you're speaking is heard on the audience link actually. Can you stop sharing it?
Yeah.
Yeah, I just stopped sharing because we can hear from your audience. Just hear them.
Yeah.
Good afternoon, everyone. I welcome you all to the post-lunch session of eDerma Advanced 2021. Our first session is case discussion on STDs, part 2 on genital warts. I request the postgraduates to send in their questions regarding the case in the chat box, and these questions will be taken up for discussion at the end of the session. I now request the host to connect with the faculty and the residents.
Good afternoon, all. I welcome you all back to the second session of case presentation of sexually transmitted diseases of eDerma Advanced 2021. It's a pleasure to have with us today Dr. Somesh Gupta, who is the Professor of Dermatology at the prestigious All India Institute of Medical Sciences, New Delhi, Dr. Suga Reddy, who is the Professor and HOD of Dermatology at JJM Medical College, Davangere, and Dr. Manjunath Hulmani, who is the Professor of Dermatology at SS Institute of Medical Sciences and Research Center, Davangere. I welcome you all to this session, sirs. The case will be presented by Dr. Vinuta from SS Institute of Medical Sciences and Dr. Somashekar from JJM Medical College. The other residents who are participating in this discussion are Dr. Supraja from JJM Medical College and Dr. Prachita from SS Institute of Medical Sciences. Over to Dr. Vinuta.
Good afternoon, everyone. I'll be presenting a case of genital lesion. History: a 41-year-old male patient, married since 14 years, manager by occupation at tractor trolley, Davangere, Karnataka, presented in our department with a chief complaint, skin lesion over genitalia since 1 month. On history of presenting illness, patient noticed asymptomatic lesion over genitalia a month ago, which was sudden in onset, gradually progressive in nature. Initially, lesion was noticed on the tip of the penis, which over a period of a month of initial onset, new lesions were noted near the surrounding areas. There was no history of genital discharge, no history of burning micturition, no history of fever or body ache, no history of genital swelling, no history of difficulty in retraction of foreskin, no history of difficulty in defecation. On sexual history, he is married since 14 years and history of extramarital exposure with female commercial sex worker 2 months in a hotel. It was prior to the initial lesion of onset, and they met while traveling in a bus. Nature of sex was penovaginal, 1 episode without any barrier contraception. History of contact with wife twice a week since the extramarital exposure. Past history: there is no history of similar complaints in past, no history of any diabetic mellitus. Family history: he is married since 14 years with 2 male children, youngest being 8-year-old, no history of similar complaints with the spouse. Personal history: he is a vegetarian by diet, appetite is normal and adequate sleep, bowel and bladder movement are normal and regular. Habits are he chews a gutka daily, 1 cigarette a day, and occasional alcohol use is there. And there is no history of separation, conflicts with wife or family members. And to summarize my history, a 41-year-old married sexually active male patient with a recent history of high-risk exposure presented with asymptomatic lesion over genitalia since 1 month with a multiple lesion around the initial lesion within a 1 month. No history of fever, genital discharge or burning micturition, and no history of similar complaints in the past and also with the wife. Thank you, sir.
Okay, Dr. Manjunath, you want to take?
Sir, you go ahead, sir. Okay. Yes.
Okay. So, Vinuta, you mentioned about sexual history, but I think you haven't mentioned about total number of sex partners, lifetime sex partners in past 3 months.
Sir, past 3 months, it was only with the 2 females. Sir, one is was 1 episode with the sexual worker, sir, and daily with twice a week, weekly twice a week in with a wife, sir.
Okay. Does wife has any complaint?
No, sir, she doesn't have any complaint. She's
okay. And how many days after the contact with the sex worker the patient developed these genital growths?
After 2 months, sir.
After 2 months, okay. Good. So, okay. And does the sex worker, did she have any kind of lesions on her genitalia?
No, sir. No, sir.
Okay.
She didn't had any lesions.
Okay. And the nature of contact was peno-vaginal only?
Peno-vaginal and only one episode. Yes, sir. Peno-vaginal on one episode, sir.
Okay. Right. I think it is. Yeah, Dr. Manjunath.
Yeah, why you asked history of genital discharge?
Sir, because of incubation period and all, sir, so it was like asymptomatic lesion and all, so I just wanted to rule out any gonorrhea or Gretter's disease, sir. So I asked about the discharge.
Okay. What about genital swelling? Why did you ask that?
Sir, genital swelling, it can be a growth or any tumor kind of lesion because asymptomatic. So I asked about the swelling, sir.
Okay.
And phimosis, because these are like asymptomatic kind of thing. So I just wanted to rule out if there is any association of those kind of diseases.
History-wise, anything you can think of, just like without seeing the lesions?
In history, sir, it could be molluscum contagiosum, sir, and also genital wart it could be, and asymptomatic it could be pearly white papules can be papules, and also lichen planus it could be, sir. Fordyce spot also it can be there, and also bovine papillosis. These are the conditions, and also syphilis also it can be included, sir.
Okay. Okay.
Bovine or bovinoid?
Bovinoid.
Bovinoid, sir. Sorry.
Bovine papilloma is entirely
different.
Yes, sir.
Yeah. You told the probabilities, no? That's what you can think without examination. That is, first you told is molluscum. What is the incubation period?
Sir? So one incubation period is like
incubation period for molluscum.
It's like 14 days to 6 weeks, sir.
14 days to 6 weeks. Okay. The second you told is condyloma acuminata, isn't it?
Yes, sir.
What is the incubation period for condyloma acuminata?
So it's like 1 to 8 months, sir, but average you can take it as like 3 months, sir. And usually the presence within like 2 months only the lesions will present, sir.
Okay. Coming to general physical examination, the patient was conscious, cooperative, and well oriented to time, place, and the patient was moderately built and moderately nourished. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. Cutaneous examination, there was multiple grouped pale to skin colored papules. These are the lesions seen. There are multiple grouped pale papules with verrucous surface. With the smallest measuring 0.1 centimeter and the largest measuring about 1 centimeter. The lesions were present over the glans penis, the coronal sulcus, and the mucosal surface of the shaft of the penis. The mucosal examination, the oropharynx was normal, eye was normal, anal mucosa on perrectal examination was normal. On systemic examination, CVS S1, S2 heard, no murmurs. CNS examination, normal higher motor function seen. No organomegaly. Respiratory system examination was normal vesicular breath sounds were heard, no added sounds. Investigations, HIV 1 and 2 was non-reactive, VDRL was non-reactive, HbSAg was negative, CBS complete blood count was within normal limit. Renal function test, there was no abnormalities. Liver function test, there was no abnormalities. The random blood sugar was 120 mg per deciliter. Provisional diagnosis, genital warts.
Okay, Somsekhar, did you mention about examination of lymph nodes, urethral meatus?
Yes, sir.
You mentioned, huh?
So, lymph nodes, there was no lymphadenopathy, sir. It was mentioned in the general physical examination, sir. There was no lymphadenopathy seen, sir.
Okay, but when you discuss about genitals, then you specifically have to mention about inguinal and femoral groups of lymph nodes. And also when you see some verrucous growth, you have to examine the perianal areas, scrotum, skin of the pubis, pubic region.
Yes, sir.
Right.
So there was no lesion seen anywhere, sir. The lesions were only confined to the coronal circles, the glands, and the mucosal surface of the shaft of the penis, sir.
Okay. Right, and there was no discharge.
No discharge, sir.
Okay. Right. So, based on this, you made a diagnosis of?
Condyloma acuminata, sir.
Okay. Well, what are the types of anogenital warts you know about?
The different clinical types of anogenital wart are condyloma acuminata, sir. Papilla type is also seen, sir. Verruca vulgaris type or the hyperkeratotic type.
Okay.
Type is seen, sir, and bovino papillosis are the different types of clinical variety.
Right, got it. Rachita, can you tell us what specific investigation you could have done in this patient?
Good evening, sir. So, sir, first clinical examination should be done under good illumination, sir. And then since we could have also done acetic acid 3 to 5% to rule out the... Hello?
Yes.
Yeah.
Go ahead.
Hello? And even the meatoscopy, sir, meatoscopy for intraurethral warts we could have done.
Okay.
And HIV 1-2 has been done, sir. VDRL was done, sir. Even HBS AG was done.
Okay. Any other screening test you know about for STI?
HPV DNA detection can be done, sir.
Okay. So,
Southern blot
guess?
hybridization,
Any
in
guess?
situ hybridization.
Any guess which HPV types these could be?
Sorry, sir, I didn't get you, sir.
What are the types of HPV which cause anogenital warts?
Sir, so 6 and 11, even 16 and 18, sir.
Okay.
They are the common causes for genital warts, sir.
Right. Supraja, can you tell us what are the high risk and low risk HPV types?
So high risk is 16, 18, 45 and 46, sir.
So how you classify, and why these are classified?
Classify the HPV causing genital warts into 3 categories, sir. High risk, intermediate risk and low risk. High risk strains are 16, 18, 45 and 46, sir. Intermediate are 31, 33, 35, 51 and 52, sir. And low risk are 6, 11, 42, 43 and 44, sir.
Okay, so which is the commonest on the genital?
Most common are 6, 11, 16 and 18, sir. Most commonly 6 and 11, sir.
Okay, which out of 6 and 11 is more common?
6, sir.
6. Okay, good. So, right. And here he has multiple warts on the undersurface of the tissues and on the genitals, on the glans penis. What could be the best treatment modality for this?
Podophyllin application, sir.
Huh?
Podophyllin application, so podophyllin resin 25%.
How you apply podophyllin and what percentage of podophyllin?
Podophyllin 25% in tincture of benzoic acid, sir. It is applied initially 25% resin is healthcare provider administered, and podophyllin can be self-applied by the patient. Podophyllin resin, the application procedure is we dip the medication with a cotton bud, taking care that the surrounding area of the genital warts is protected with KY jelly or Vaseline to reduce the risk of chemical injury, sir. So we apply the podophyllin resin over the lesion and wait until the color changes, and it's left to dry, and the patient is asked to wash it off after 4 hours, sir.
Right. Okay, good. What are the contraindications of podophyllin?
Podophyllin is a mutagenic and cytotoxic, sir, so it's contraindicated in pregnancy.
Okay. Vinuta, can you tell us how you classify treatment modalities for anogenital warts?
So it is classified as a physician and also the patient thing, sir. In the patient application, there are two drugs, sir. One is imiprimod, and also second one is podophylox, sir. So imiprimod is 5% cream, which is applied over the genital area. Alternate days, sir. Only 3 times a week is applied, sir. And contact period is only for 6 to 10 hours, and he has to wash it with mild soap, sir, so that there will be no irritant for it. It's better application do over the night, sir.
What are the side effects of imiprimod?
And it's irritation, sir. Local irritation, erosions will occur with that imiprimod, sir. And 16 weeks, and it also causes immunomodulator.
How it works?
So it is an immunomodulator, sir. It increases the immunity over the area which is already reduced in the what, sir? Toll-like receptors.
Somebody is prompting you.
Which type? Which toll-like receptor?
7.
Toll-like receptor 7. Okay, go ahead.
Yeah. So it also causes vitiligo-like depigmentation, right?
Okay, sir.
Yeah. Okay, Dr. Somshekhar, can you enumerate the other half of the treatment modality, that is provider applied or physician applied?
The physician applied, the most commonly used is the podophyllin resin, sir. It is usually most commonly used over the mucosal lesions, sir. So in the case which we have, sir, the treatment of choice would be podophyllin application, sir, which is applied weekly once, sir. TCA also is the doctor applied modality, sir. Cryotherapy, the cotton tip or the cryoprobe is also the doctor applied, sir. Certain procedures like electrocautery, sir, electrodesiccation is also doctor applied, sir, and excision is also doctor applied, sir. CO2 ablative laser is also doctor applied, sir.
Okay. Right, I'll come back in the meantime. I think Dr. Subha Reddy and Dr. Manjunath can take over. I'll come back with more questions if time permits.
Okay. Thank you, sir. Thank you. Somshek, a question for you. In investigation, you mentioned about LFT. Is it significant here? Why you want to get LFT after done in this patient?
So in case the patient doesn't respond to 6 weeks of podophyllin application, so I'd like to switch over to systemic retinoids, so that I'd like to start him on either isotretinoid or etretinate or acitretin, sir. For that, I'll have to get RFT and LFT done, sir, as a baseline investigation. So that's the reason why I've gotten LFT and an RFT done, sir.
No, is it effective? Retinoids are effective in all types of HPV, or any specific indication is there for retinoids?
So retinoids are specifically indicated for recalcitrant warts, which are not responsive to the conventional therapy, sir. And also indicated in widespread warts. They're also indicated in intrameatal or meatal warts, where procedures like cautery or surgical excision can cause scarring and cause meatal stenosis, sir. So these are the indication of systemic retinoid.
No, I think Somshekhar, it will be only immunosuppressed individuals you can use this one. Only immunosuppressed individuals.
Yes, sir, but the results are large.
Vinitha, what are... Okay, so Vinitha, what are sessile warts?
So sessile warts are very small in nature, sir, and they are present in grouped over the genital area, sir.
Supraja, what is...
These are non-pedunculated warts, sir. Pedunculated warts, sir.
Okay. Supraja.
Whereas the condyloma will be like pedunculated.
Okay. Supraja, what is papilloma virus associated melanocytitis? Papilloma virus associated melanocytitis, because previous slides we were talking about subclinical infection, isn't it?
Erythroplasia of Querette, sir.
No.
So it is seen in the males, sir, basically. It's subclinical stage.
It is basically a subclinical infection, sir, seen in men, sir, and it is characterized by recurrent painful fissures, sir. So to diagnose it, we can use aceto white test, sir. 3 to 5% we can use. to see if it's a subclinical HPV infection. So the particular lesion, sir, we'll see white. The papule will become white, sir. So this is a test to rule out subclinical HPV.
So, Shekhar, what are the regional predictions for HPV virus? There are a few predictions, isn't it? For example, what you told about genital warts, no? Like there are predictions for each virus to specific sites.
Yes, sir. So, HPV types of 6, 11, 16, 18 are more commonly associated with the aerogenital areas. Plantar warts HPV types 1, 2, 4, 17, and 27 are seen. That is seen over the plantar area. So, the common warts are 1, 4, 17, and 27 types. They are seen over the hand or the knees. And butcher warts, sir, HPV 7 at HPV 7 or 2, sir. And the Buschke-Lowenstein tumor, sir, which is in which the HPV 6 DNA is seen, sir, is again seen over the genitalia, so anogenital region, sir. A Bowenite's papillosis, sir, which is again seen over the anogenital region, sir, is associated with HPV 6.
Rachita, what are the different modes of spread of
the first is sexual contact, sir. That is skin to skin. Even from mother to child, that is vertical transmission. And even through in the laryngeal epithelium, if the patient has the infection, it can spread, sir. That is basically by HPV 11, sir.
What about perinatal transmission?
From mother to child, it is possible, sir. And basically, laryngeal, yes, sir, it is possible, but it is rare, sir. But if it occurs, it is due to HPV 11.
Manjunath? Dr. Manjunath?
Yeah. Supracha, can you tell histopathology features of what?
So histopathology, mainly we'll see hyperkeratosis. In case of common warts, we see basket weave type of orthokeratosis, and in case of genital warts, we see hyperkeratosis, sir, and papillomatosis, and coilocytes are seen in less number in case of genital warts, sir. And acanthosis is seen, sir. Marked acanthosis is seen, sir.
Can you describe coilocyte?
Coilocytes are keratinocytes, sir, which have hyperpyknotic nucleus and and are present in the stratum spinosum, sir.
Vinita, can you tell about immunotherapy?
Sir, immunotherapy, there are types. You can give the BCG, MMR vaccine, and also you can give one trichophyton antigen. It can be given. So these are the 3 things which are given for the genital warts. And for the common warts, the same things are given. So along with Candida albicans antigens are given, sir. Immunotherapy.
Okay. Somsekhar, can you tell about oral medicines which can be used in genital warts?
The oral immunomodulators like oral zinc can be used, sir. Oral levimesole can be used, sir. There's studies where oral cimetidine and antidine. Oral zinc can be used. Oral levimesole can be used, sir. And isotretinoin, acitretin, and etretinate also can be used, sir, in recalcitrant and widespread warts and in immunocompromised patients, sir.
Okay. Any role of cidofovir?
So cidofovir is used topically, sir. Topically, it's used over the lesion, sir.
Rachita, can you tell what is the treatment modality in a pregnant woman with warts?
The TCA 80 to 90% we can use, sir. So basically, it causes skin destruction by coagulation of cellular proteins, sir. And even cryotherapy can be used. The mechanism of action for cryotherapy is thermolysis. It will cause thermal cytolysis, sir. So even cryotherapy can be used. So liquid nitrogen minus 196 degree or solid carbon dioxide can also be used, sir. Even dry ice or cyclopropane can be used, sir, as a cryotherapy method.
How do you treat if there are lesions in the urinary meatus or within the urethra?
So we can use 5-aminolevulinic acid, sir. We can use 5-aminolevulinic acid. So basically, it will selectively accumulate and being a photosensitizer, sir, it will cause destruction of the lesions, sir.
Photodynamic therapy.
By photodynamic therapy, sir. Yes, photodynamic.
Anything other than that? Anything?
Other than that, cryotherapy can be tried, but it causes strictures, sir. So.
Somesh, sir?
Yeah. Okay, good discussion. So, would you like to do any test, Supraja, in the white of this patient?
So, HIV 1 and 2, sir, VDRL can be done, sir, in the white.
Any other test?
Maybe. And acetowhitening test can be done, sir, to detect.
Acetowhitening or something else, which a gynecologist can do.
Colposcopy, sir.
Pap smear can be done, sir.
Yes, pap smear, and these days they do molecular testing to rule out high-risk HPV, because this is an opportunity to detect any pre-malignant or malignant cervical lesion, cervical intraepithelial neoplasia, or any other lesion, high-risk lesion in the wife. If you miss that, then wife may develop a fatal cancer. So, it is good to get the wife to screen for high-risk HPV types. Right. So, Vinutha, can you tell us the cancers caused by HPV?
So, cancers, carcinoma in situ, sir, bovinoid papillosis can occur, sir, and
These are not
it can also
cancers.
causes Buschke.
These are
Buschke tumor can malignant, sir.
No, it's not malignant. It is locally invasive, semi-malignant tumor. But HPV can cause some invasive cancers. Can you name them?
In female, it is a CS cervix cancer. It can cause us in females, and
Sachita?
Sir, it can cause SCC, BCC, malignant, yes, squamous cell carcinoma, basal cell carcinoma.
No.
These are the cancers, and even malignant melanoma, sir.
No.
Epithelioma cuniculatum, sir, it's caused by HPV virus infection from the palmoplanta, lesions from the palmoplanta region. Caused by HPV 16.
Yeah, so it does cause squamous cell carcinoma, but not basal cell carcinoma, not melanoma. And it can cause oropharyngeal cancer, and there is orogenital contact. It can cause cancer cervix, it can cause vulval cancer, it can cause penile cancer. So penile squamous cell carcinoma, vulval squamous cell carcinoma. So these are the cancers which can be caused by HPV 16 and 18, and about a quarter of the patients with genital wart have concomitant high-risk HPV types. So you have to know these potential cancers caused by HPV. Okay, what is the natural history of genital warts? If you leave them alone, what will happen?
It will regress slowly, sir. It is a self-limiting and regress, and few patients it may grow also, sir. By 8 months, it will regress by itself, self-limiting disease.
Any proportion of the patients who will show spontaneous regression?
Well immunity patients, sir, and also any topical application.
What is the percentage of patients who show self-regression?
So it's like 60% of the patients, sir.
Excuse me, sir. We have 10 more minutes left for discussion.
Okay.
Anybody, rest of the 3 candidates who can tell us the natural history of genital warts? There are 2 things. One is natural history of HPV and natural history of genital warts. Even when the visible genital warts regress, HPV may persist in the skin, right? So, in 1 year, 70% of the patients show spontaneous regression, and in 2 years, almost 90% of the patients show spontaneous respiration. So not treating is sometimes an option, right? But these cause a lot of psychological problems as well. So because this patient has multiple genital warts scattered in a large area, so if I have to tell you to choose one treatment regime in this patient, what will be your preference, Supraja?
Sir, I would prefer podophyllin application, sir.
Okay, if it fails, then second?
Second option would be TCA application, sir, trichloroacetic acid.
Okay, good. Third?
Third would be cryoprobe, sir.
Okay. Cryo with probe or spray?
Cryo dip or cryoprobe, sir.
Okay.
Cotton bud can be dipped in liquid nitrogen and can be applied to that area, to the wart, sir.
Okay.
And the modality is cryoprobe, sir.
Okay, what is the temperature of liquid nitrogen?
Minus 190 degrees centigrade.
But Pratika, you said dry ice, isn't it?
Yes, sir.
What is the
Yes, sir,
temperature
yes,
of dry ice?
Minus 56 degrees Celsius.
Okay. So why it is called as dry ice? Why it is not used in a liquid spray form?
Sorry, sir, I don't know.
No problem. It is okay. But, who can tell us? Somsekhar, yeah?
Somsekhar.
Yes.
I'm not sure of the answer, sir. Why it's called dry ice?
Why dry ice? It's a very simple physics question. There is no liquid phase of carbon dioxide, right? Only it from solid phase it directly goes into air. There is no liquid phase. That's why it is known as dry ice. Okay, good. It's off the track question. Don't bother about it. Okay. Dr. Manjunath, over to you.
Yeah. Somsekhar, can you tell about vaccines for HPV?
So currently the vaccines are used prophylactically, sir. There's two kinds of vaccines which are available. So one is the bivalent vaccine and one is the pentavalent vaccine, sir. The bivalent vaccine provides 100% protection against HPV 16 and 18, sir. The quadrivalent vaccine provides protection against 6, 11, 16 and 18, sir. So it's usually given to the female child below 12 years of age or before the onset of the sexual life, sir. So the route given is intramuscular. Initially it's given, one dose is given, 2 months later the second dose, 6 months from the first dose, the third dose is given, sir. So the antigen here used is an L1 capsid protein, sir. It is non-infective because just the capsid protein is present and there is no genome present in the vaccine, sir.
What is nonavalent vaccine?
Nonavalent vaccine is Gardasil 9, sir. It protects against 9 strains of HPV, 6, 11, 16, 18, 31, 33, 35,
52.
35, 45, 52 and 58.
Right. Good.
So why these viruses are covered? Why these specific viruses?
They 6, 11, 16, 18 commonly cause anogenital warts, sir. Of 6, 11, 16 and 18, 16 and 18 are the most common causes of carcinoma, sir. So that's why these strains are covered, sir. And 16 is the most commonly encountered strain in India causing carcinoma, sir. So that these are covered under the vaccine, sir.
Protect against CS cervix, no?
Yes.
Female. What is the age group you want to give these vaccines in a female?
So it's usually indicated below 12 years of the age, sir. But the also says, sorry, sir.
Actually, we can give. We can start from 9-year-olds, 9 to 26-year-olds.
26.
Okay. 9 to 26 is the age limit.
Yes, sir.
Yes, sir.
Yes.
Why it doesn't work as a therapeutic vaccine intralesional? Anybody?
So because there is a local immunity, there is decrease in local immunity in the HPV lesions, and as such, this capsid doesn't give any immunity over this action. Right? That's the reason intralesion it's not.
Yeah, you are partly right.
Given.
So there's
you're
no
partly right.
stimulation of
Yes,
cell-mediated immunity, sir. So that's why there's no stimulation of cell-mediated immunity, sir. That's why there's no therapeutic value, sir.
Yeah. So you said that it is only capsid. It
Yes,
doesn't
sir.
have the DNA, right?
Genome is not there,
Genome
sir.
is not there, and in established infection, genome is already there in the basal layer of the epidermis.
Yes, sir.
So even if you have immunity against capsid, it doesn't eliminate the genome from the epithelium. Right? So it doesn't work. It is not a very good therapeutic vaccine. Okay.
Project,
Sorry,
can you tell?
Manjunath.
So, Project, can you tell about Bovinoid papillosis?
The bovinoid papillosis is a variant of variant of genital wart, sir. It is caused by HPV-16, sir. It has malignant potential. There are sessile warts are seen, sir. Non-pedunculated and seen over the and keratotic papules are seen, sir.
What proportion of these bovinoid papillosis turn into malignancy? It's very low, 1 to 5%. The risk is very, very low.
Clarity,
Excuse
sir?
me, sir. We have
Yeah.
2 more minutes left for discussion.
Yeah. So, clarity, sir.
What is the HPV vaccine efficacy, Dr. Prachita?
Sir, efficacy, sir, for quadrivalent, it is 90%, sir.
Yeah. Can you hear me? Can you hear me?
Yes, it's.
What is
Yes,
the
sir. For
HPV vaccine
quadrivalent,
efficacy?
it is
Prachita?
90%, sir.
What is the
It is
duration of
90%,
vaccine
sir.
protection? Okay, vaccine protection. What is the duration? How long it's going to protect the person who receive vaccine?
5 years, sir.
5 years.
So, sir, 4 vaccines
5
we
years.
have to three doses we have to give, 0, 1, and 6, and after that it will be effective for 5 years, sir.
Okay. How will you manage in pediatric age group genital warts in pediatric age group? You can see in
So
pediatric age group
TCA
also.
80 to 90% can be given, sir. Yes, sir. Yes, sir.
Okay.
So TCA 80 to 90% can be given. Even cryotherapy can be given, sir. So first we have to rule out if there is any sexual abuse with the child, sir, and then later we can give the treatment.
Because anything can add up? Treatment in pediatric age group.
Imiquimod can be given, sir. 5% imiquimod topical application can be given, sir.
Vinita?
So 5-fluorouracil cream can also be given, applied, sir. For the children.
Somshekar,
Yes, sir.
how will you manage anogenital warts in pregnancy?
So
In
anogenital
pregnancy.
pregnancy, sir.
In first trimester, second trimester, third trimester.
So the first trimester, sir, the chance of teratogenitality is more, sir. So agents like imiquimod and podophyllin should be avoided, sir. So I'd like to use TCA and cryotherapy in pregnant ladies of first trimester, sir. And in the later stages, sir, if the anogenital warts are large enough to block the birth canal, sir, I would like to go for C-section or complete excisions of the warts, sir. So to prevent the transfer of the infection to the neonate, or to prevent any kind of a cervical dystocia during birth, sir.
Vinita, how will you manage cervical warts?
So
You
cervical
can see warts
warts.
on this. Yeah.
Yes, sir. And usually those are excised, and also you can apply your 5% 5-fluorouracil creams, because even intrameatal and all, because of procedures, they cause strictures. So this is the cream which is applied over there, and also the excision. So this is the only 2 things which can be done for the cervical, sir.
Excuse me, sir. I'm
Yeah.
sorry to interrupt, but we are running short of time.
Yeah.
Any
Okay.
concluding remarks?
Somesh, sir.
Yeah, so it was a very good discussion and all of you performed very well. And so when a patient of genital wart is there, we covered almost everything. what are the causative agents, what is the incubation period, what are the physician applied treatments, what are the patient applied treatments, what is the efficacy of the treatment, what are the chances of spontaneous resolution, how to treat a meatal wart, how to treat warts in children, how to treat in pregnant women, what are the immunotherapeutic agents, what are the intralesional antigen therapy, what are the HPV vaccines available, and what is the schedule, why it is not effective as a therapeutic vaccine, whom to give, and when to give. So it was a very good discussion, and all of you did very well. Thank you. And these are the questions which are going to be asked in the exam. Well done.
Thank you, sir.
Thank you, sir.
Thank you very much for the very wonderful discussion. I would like to express my heartfelt thanks to Dr. Somesh Gupta, who has been with us for the 2 sessions of sexually transmitted diseases discussion. And thank you, sir, for your valuable time and giving your valuable inputs for this program. I would also like to thank Dr. Suga Reddy and Dr. Manjunath Hulmani for their time and participation. And also, last but not the least, all the postgraduates for being a part of this very informative session. Thank you, one and all.
I thank our faculty for the wonderful discussion. I request the faculty to answer a few questions from the audience. We have Dr. Somesh Gupta and Dr. Manjunath Hulmani joining us for this session. So our first delegate question is there a role for HPV vaccines in men? Dr. Somesh Gupta, sir, can you please give your inputs on this?
Yeah, so HPV vaccine, quadrivalent vaccine is nearly 100% protective for genital warts in men. And it also protects against genital cancers and anogenital cancers. So Australia is one country where this has been recommended routinely in the males also, because if you also protect men, the transmission chain is interrupted and women are also benefited out of that. So any man, any boy who hasn't initiated the sexual activity can be given an HPV vaccine, but quadrivalent, not the bivalent.
Thank you, sir. Our next delegate question is how do we manage intrameatal warts? Dr. Manjunath Hulmani, sir, can you please give your inputs?
Intrameatal wart, we can, that's what we discussed, that phototherapy can be dynamic therapy, applying ALA can be tried intrameatal warts.
Okay, sir. Dr. Somesh Gupta, sir, would you want to give additional inputs on this?
Okay, so meatal wart can be treated. I think we discussed, and one of these 4 candidates, they spoke very well on management of meatal warts. So it can be treated with, podophyllin can cause erosion and stricture. Still you can think of applying TCA in a lower concentration, or you can just apply little liquid nitrogen with a bud, or you can also at times treat with radio frequency ablation if you can precisely ablate it and without the risk of causing a stricture in the external urethral meatus.
Okay, sir. Next delegate question is, what are the serological tests that we can do in a case of genital warts? Somesh Gupta, sir, would you please give your input?
Which test?
Serological test, sir.
Serological test. Okay. So serological tests have no significant value in the diagnosis of human papilloma virus, because it doesn't distinguish the existing or the past infection. Basically, if you want to do a test, then you have to do the genetic testing, genotype testing of the HPV. So HPV DNA detection in the swab taken from the area. So generally we don't do serology.
Thank you, sir. Our next delegate question is, how do we differentiate a condyloma lata from a condyloma acuminata? Dr. Manjunath Ulmani, sir, can you give your inputs on this?
Yeah, condyloma lata, it will be more moist. It will be occurring on the mucosal surface, and it looks more moist on morphologically. And other things like histopathology also will help us in proving the condyloma lata from acuminata, differentiating that. Okay. And the serology VDRL, if at all we
Okay, sir. Dr. Sugareddy, sir, has just joined in. Sir, would you like to give your inputs on this? The question is how to differentiate condyloma lata from condyloma acuminata. Dr. Sugareddy, sir. Okay. I thank Dr. Somesh Gupta, sir, and Dr. Manjunath Ulmani, sir, for answering the audience questions. We will now resume the next program shortly. I request the audience to please stay tuned in. Thank you. Moving on to the next session by Dr. Ashwini PK, who will be speaking on clinical examination, how to perform. I request the host to connect with Dr. Ashwini.
Hello everyone, welcome to DERMAADVANCE 2021. So the moment DERMAADVANCE begins, you're already in the exam going or exam taking mode. So clinical examination is a very important part of your exam, that is post-graduation exam. So now we shall move ahead about some tips, or I can say how to prepare and perform in the clinical examination. So you're done with your theory now. However it was, let us not go back to it. So we are moving ahead towards the clinical examination. So once you're done with your theory, I think you're sort of done with catching up with your sleep, going out for parties, chilling out with friends, and by then your clinical exam is out. I mean, the dates are out, so you're into the clinical exam preparation mode, right? Okay, so let's get into the clinical exam preparation mode. It's last but not the least. So, it's the final bit, but it's definitely not the least bit. It's a very important bit of your clinical examination. So always carry your 3 C's when you're going to your exam. That is confidence, calmness, and your clinical kit, which has to contain a few things, which I'm going to tell you. So post theory, before clinical exam, okay, what would I do, or what would you be doing? You have to brush up your practical points, very important. Don't go into the details of theory and trying to analyze the pathogenesis altogether. You have to brush up your practical points. You've done with your theory exam. You have to brush up your case related things, differential diagnosis, management. How do you approach the case? That is very, very important in the clinical exam. So what will be your approach to the case? This is what you have to read. And go for a very speed reading, because you've already revised, read, and given your theory. Now you have to have the confidence that you know the knowledge. So you have to go for a speed reading and read up your self-made notes. We'll come into that. And preferably go for small group discussions. It definitely helps when you have a small group around you, 2 to 3 of you sitting together, throwing questions at each other and correcting each other. That would help, but make sure you have a good mental frequency to study along. And recall your case presentation sessions during post-graduation, your bedside clinics, the questions which were asked. Usually you make down some notes when you're attending ward rounds and all that. So just get back to those and prepare yourself for the exam. So when I come to footnotes, these should be ready by your exam actually. It should not be prepared later on. It will help your theory also. So what is a footnote? It's not a large notes. It's a small possible notes of a 10-page chapter. So that in one page, you can actually make out what is the entire outlay of the chapter. It should contain headings, subheadings, some important classifications and signs, some types and variants, some key points about the disease. It may have some flow charts and tables, or you can make a mind map sort of a thing. So that should be your footnotes. It's not like starting from epidemiology to the ending, you have everything written in paragraphs. No, it should be a small note which is representing your entire chapter in a very small pattern. So that should be your footnote. And running through your footnote really helps you to revise for your exam. So when you're reading for your practical, that is the clinical exam, this is how you have to plan. You know that you have spotter cases, you have long and short cases. So make a list of, whatever comes to your mind that this could be a spotter case. So make a long list of spotter cases and read up how are you going to manage with the differential diagnosis, how are you going to answer the management points, etc. And for long case, you have to have a certain set of points to defend your diagnosis, and you should have a list of differential diagnosis. So read up all the complete cutaneous examination, including hair, nail, mucosa. Okay, brush up all the examination points, examination skills, not to miss any signs. Okay, that is how your long case should be. And read up your approach, as I told you, the management, how is the prognosis, how would you follow up the patient, and if there are any, of course, recent advances. And coming to short case, it's actually a very, very important part of your exam, because these are like the fixed cases for your exam. Okay, you have an STI, you have a leprosy, so pick up these aspects and learn them thoroughly well, right? Because these are like your saviors. Because even if some other areas of your exam kind of goes not so great, these are like your saviors. So know your STIs and leprosies really well. To know these STIs and leprosies, revise all the examination skills. It's very, very important the way you examine a patient in STI and leprosy mainly. So know all the signs, every nerve examination. How do you do it? Sensory, motor examination. And in STI, of course, don't miss the ulcer. Each and every point to examine the ulcer, be it a swelling, be it a lymph node, and all these things. Right? Many of you may be doing it during your post-graduation. Some may not be really doing it and quickly sending to the lab and all that. But make sure you know to stain the slide, which is probably given to you. Okay. And of course, drugs. When it comes to drugs, usually in the long case or in the short case, when you plan to start the patient on a drug, you should know the indications, you should know the monitoring, you should know the interactions really well. Right? That is how we start the patient on any drug. So revise and read up all the drugs pertaining to the cases. And these are some of the things which you have to take it along. So give a read up, dissertation. They can ask you something about your dissertation in the exam. Keep your logbook well written, and it should be taken to the exam. And there can be questions from the logbook also. And pick a few topics of pedagogy. Pedagogy is like a topic is given to you and you can speak about the topic. So sometimes it can happen that the examiner might ask you to speak on your favorite topic, anything other than your dissertation too. So pick up a few topics where you're confident and comfortable to talk about, and read up everything about the topic, like how do you plan? When you plan to talk about a topic, it should be in a very systematic way. Right? Starting from what is it to the epidemiology or the burden of the disease, then the etiopathogenesis, how does it present, what are the differentials, that's how it goes generally when you talk about any disease, and the management, prognosis, etc. So pick up a drug or a disease or anything of your interest for pedagogy. And do revise your theory paper. It would be a blunder if you have not revised your theory paper, if you've written something wrong in your theory paper and again you come unprepared for the clinical exam. So do revise it. And of course, not to miss, for Viva OC, you need to know your instruments, x-rays, the equipments like your cryo machine, your cautery equipment, or your phototherapy equipment. See whatever is presently there, your laser equipments there in the department which you have been using. So these things you should know really well, okay? And when you read your histopath slides, make sure, other than just diagnosing the histopath, know what could be the histopathological differentials for the slide, okay? That can be the way your Viva would go. So when you come to the exam, ask this question to yourself: will I be able to manage an OPD for a day if I'm allowed to, right? See, basically that is what is being judged, okay? If of course your answer will be yes, and that itself will help in bringing up your confidence. So will you be able to manage an OPD for a day if you're allowed to? Definitely yes. So go for it. So always think, I'm going to be assessed regarding what I know, not what I don't know. See, examiners or whoever seniors are coming to you to examine or assess the candidate will want to know how much you know, how much well you can manage a particular case. Not like, okay, this person does not know this particular thing. It's not like that. Don't go with the negative attitude. Always go with the positive attitude to the exam. So how will you be assessed? You'll be assessed on the knowledge parameter, skill parameter, attitude parameter. Okay. We describe these things in the medical education system, like how much the candidate knows. That's the knowledge. Knows how to do it. Knowledge and skill. Shows how to do it or does. So that is the skill and attitude together. So that is how a assessment is done in long case or short case or spotters or pedagogy. Or sometimes you do have this OSCE pattern also, though it may not be followed in the MD exam at some universities. Okay. So basically your knowledge, your skill and attitude, these are the main domains where the assessment will be done. So the day has arrived. So finally, I would like to say, when you go for the exam, always the previous day, stay calm, sleep well, eat well, sleep well, have a basic calm mind. If you are into some meditation or something, do that and get up with a very positive affirmation and then reach your exam place. And basic etiquette, dress well, be neat, have a good shave, etc. And, have a humble greet and all that. So that is more important. Basic etiquette is needed. And stay calm. Of course, some amount of adrenaline rush is there, that is exam, but not to the extent that you're, crying or weeping or sweating and actually forgetting everything what's around you. Not to that extent. Just stay calm. As I told you, it's just to assess how much and how well you know. So be confident, but be humble. Okay. Humble is the word. You have to be humble. And when you answer, please be clear and loud enough. Whispering answer itself sounds like you're underconfident. And if you want to quote something, do quote, but never argue with the examiner. Always remember, an examiner is a person who's senior to you with a bundle of experience ahead. So do not argue, just quote that, sir or ma'am, this is what I have read in this particular thing. I can recheck it. Remember, it's a lifelong learning thing. We are all learning. So even on the day of exam, there are times when you are actually learning from the examiner. So be humble to take the tip and learn. And when the questions are asked, don't answer in a jumbled way. Always answer in a systematic way. Okay. Prefer to classify things rather than just enumerate. Answer the common classical things first rather than bring the rarest possible syndrome about which you do not know much. And quote the recent advances, if any. If suddenly asked, okay, where you found it, you should know that, sir or ma'am, I read this particular thing where it was given like this. Okay. And things which are practiced, as I told you, in your setup, what is practiced, that you should not miss. You should know it really well, be it a procedure, be it a pulse therapy, be it a, rituximab, or be it a laser, whatever is practiced in your setup, you should always know it really well. And answer only when the question is well heard and once the question has ended. Before they end their question, do not jump into the answer. Respect every question. It can be the most basic question. They can just ask you out of the blue, define a papule. Okay, define it. Okay, so respect every possible question. And I was talking about the clinical kit. Make sure you have these things handy because you cannot run around in the exam hall. Okay, your magnifying lens, slides, pins and pens, measuring tape, especially when you are probably seeing a case of, say, a scleroderma, you would want to see the, respiratory movements and all that. So have your stethoscope with you, etc. And now we are in the COVID era, have your sanitizer, extra pair of masks, and your general kit, which contains some water bottle, medicines, if any. Chocolates, of course, helps to bring out the hyperglycemia. So make sure you have all these with you. So to wind up in a nutshell, I would take a relevant history. I would do a detailed examination, and then I'll think for myself, what could it be? The diagnosis, okay? And why do I think so? These are my points to defend my diagnosis. Why not something else? Okay, this is going to tell me my set of differential diagnosis and why is it not those conditions? And what should I be doing now? What's the bedside investigation? What's the investigation I want to send? Or what should be the further line of management? How will I approach this particular case? How do I go about it? How will I treat this patient? How will I counsel this patient? What medications I'm going to give? And is there something better I can do? Read up some more literature. Maybe I can do that. Maybe I can do this. Does he have a drug interaction? I need to cross-check. Okay, does he have any other psychosocial problem? I need to counsel him. Or if he has any other medical issue, I need to check for the interdisciplinary action. So these are, in nutshell, these are your questions to yourself when you are ready to present your case to the examiner, because this is how the examiner would also take the discussion. And always remember, you are a learner, we are all learners. Okay, so that always keeps you humble. So the take-home gyan at the end of this short topic is hard work. There is absolutely no substitute for hard work, and it always reflects in knowledge, right? So when you have hard work and knowledge together, there is always confidence. But make sure your confidence is right amount, it's not overconfidence. So always have the humbleness that the learning continues. Okay? And all the best for your exams. Thank you so much.
Thank you, ma'am, for the wonderful talk. We will now resume the next program shortly. I request the delegates to stay tuned in. And now we move on to our second session on spotters. I request the host to connect us with the faculty and postgraduates of the next session.
Good afternoon. I welcome you all to the second session of Spotters. I would like to introduce to our esteemed faculty for this session, Dr. Ravi Rathod, Professor and Head of the Department of Karnataka Institute of Medical Sciences, Hubli, Dr. Naveen K.N., Professor of SDM College of Medical Sciences, Dharwad, and Dr. Bhavna Doshi, Associate Professor, Jawaharlal Nehru Medical College, Belgaum. The postgraduate residents participating in this session are Dr. Swati and Dr. Ranjita from Karnataka Institute of Medical Sciences, Hubli, Dr. Dhanraj and Dr. Uma Maheshwari, STM College of Medical Sciences, Dharwad, and Dr. Anisha, Dr. Daisy from Jawaharlal Nehru Medical College, Belgaum. We will begin with the first spotter. Over to Dr. Bhavna Doshi and Dr. Swati.
Okay, Dr. Swati, can you describe the lesions?
Ma'am, I am presenting a case of 42-year-old male who has complaints of recurrent painful lesions over the lower extremity since 4 years. Ma'am, he on examination he has multiple pustules which are follicle oriented with surrounding erythematous base and few are exfoliating.
Okay, so can you tell me your diagnosis or differential diagnosis for the same?
Ma'am, my diagnosis would be chronic folliculitis of leg.
Okay, any other name for it? What is dermatosis cruris pustula atroficans?
Ma'am, our dermatosis are nigricans. It's a chronic follicle.
Yeah, go ahead.
It's a chronic folliculitis of the leg. Other name for it.
Okay, what is the pathophysiology?
Ma'am, it is mainly staphylococcal mediated infection.
Okay, can you tell me the other staphylococcal mediated infections?
Others are like Staphylococcus scalded skin syndrome, carbuncles, furuncles.
Okay, what is the cause for staphylococcal scalded skin syndrome? How is it mediated?
It's a exotoxin mediated.
Okay, very good. If I do a biopsy from the skin lesions of SSS, what can I expect? What is the level of split?
Subcorneal level split can be seen.
Very good. Can you tell me non-infectious causes of follicular lesions, of non-infectious causes of folliculitis?
Non-infectious pruritic papillary eruptions can be in HIV.
Okay.
And
have you
drug-induced
AGP?
Yes, ma'am.
Okay. What are the drugs causing AGP?
Like terbinafine can be terbinafine, sulfonamides, pristinamycin.
Okay. Oh, can you tell me other causes? Have you heard of eosinophilic folliculitis?
Yes, ma'am. Yeah, eosinophilic folliculitis, follicular oriented.
Another name for the same?
Schulman syndrome.
Okay. How will you investigate bedside investigations?
Gram stain can be performed, ma'am.
Okay. What will you expect to see under the microscope?
These are gram positive cocci can be seen, ma'am.
Okay, fine. Can you tell me other Bacteria which can cause folliculitis?
Usually Streptococcus can cause folliculitis, ma'am. Other gram-negative organisms can cause Propionibacterium acne.
Okay, gram-negative
treatment.
folliculitis. Okay, fine. Pseudomonas?
Hot tub folliculitis is caused by Pseudomonas aeruginosa.
Okay, very good. Are there any viral etiology for folliculitis?
Ma'am, herpes can lead folliculitis.
Yes, very good, very good. Okay. What is pride complex?
Ma'am, it is a drug reaction, ma'am. Like when we give, when the patient is on EGFR, erlotinib, they have that pride complex. They have pustulosis, abnormal hair growth.
Yeah, itching, dryness.
Yes, itching, dryness.
Okay, fine. What are the causes of recurrent folliculitis?
If they are carrier of Staphylococcus aureus infection, they can have recurrent folliculitis. And in immunocompromised condition.
Yeah.
Immunocompromised condition.
Okay,
HIV, diabetes.
Very good. So if the patient is MRSA positive, how will you treat this patient?
Ma'am, in MRSA positive patients, we can give topical silver sulfadiazine, ma'am. Or if a patient, if they is very sick and the infection is severe, IV vancomycin can be given, ma'am. Or oral linezolid can be given.
Okay, but if the patient is having recurrent lesions, would you like to treat some other areas?
Yes, ma'am. Staphylococcus carrier should be treated, ma'am. Like they have to be given mupirocin ointment application over the anterior nares for BD for 5 days in a month for consecutive 3 months.
Sorry to interrupt, ma'am. Shall we move on to the second spotter?
Sure.
Dr. Ranjita, the next spotter is for you.
Yes, ma'am.
Go ahead, Dr. Ranjita. Yeah.
Here I am presenting a 15-year-old male patient with itchy lesions on hand and genitals since 1 week. On examination, multiple erythematous papules are present in the web space as well as in the genitalia.
Okay, so what is your diagnosis?
I would like to consider the diagnosis of scabies.
Okay. What is scabies? What is another name for it?
7-year itch.
Very good. What is it caused by?
It's caused by mite, Sarcoptes scabies var hominis.
Okay, good. Can you tell me the size of these mites?
Female mite is around 0.4 cross 0.3 millimeter and male mite is smaller. It is 0.2 cross 0.1 millimeter in size.
Okay, what is the incubation period?
Incubation period in the primary infection, it is around up to 3 weeks, and in case of reinfection, it can be as less as 3 days.
Okay, good. So can you tell me what is the classical lesion of scabies? Can you describe it?
Classical lesions are the papules which is present in the flexures, in the web space, volar aspect of the wrist joint, cubital fossa, anterior axillary fold, nipple and areola in case of females, umbilicus and periumbilical area, groin, and inner aspect of thigh and legs can be seen.
What are burrows?
Burrows are the special lesions. These are the tunnel-shaped serpiginous tunnel within the stratum corneum in which the mite harbor.
How deep can the burrow go from stratum corneum to what level of the epidermis? Okay, suppose I do a biopsy from one of these lesions, what will I see?
Pigtail appearance.
Where?
Within the epidermis.
Where in the epidermis? And what is the meaning of pigtail appearance?
It is the burrow which is formed by the
No, it's not the burrow. It is a remnant of the egg of the mite. What is scabiella?
It is a fecal matter of the mite.
Okay, which cells will you see predominantly in histopathology of scabies? Okay, tell me, how will you diagnose this case? Bedside diagnosis. Any bedside investigations you would like to do to confirm your diagnosis?
I'd like to take the scrapings from the lesions and examine under the microscope after applying KOH or mineral oil.
Okay. Any other bedside investigations if you don't have a microscope?
Dermoscopic examination can be done.
Okay. Okay. What will you see? What sign you will see in the dermoscope?
Jet lag sign can be seen in the dermoscopy, which is a
jet liner.
It is a mite with triangular, opaque triangular head and relatively translucent body with a tail that's a burrow.
Okay, what is burrowing test?
Burrowing test is a test where we apply the ink on the papule and then wipe it off to to demonstrate the burrow.
And any use of Wood's lamp for the same?
Wood's lamp. No.
Okay, can you tell me the complications of scabies?
Scabies, there can be secondary infection, impetiginization or eczematization. There can be post-streptococcal glomerulonephritis and vasculitis, leukocytoclastic vasculitis.
Okay, how will you treat nodular scabies?
Nodular scabies is quite resistant. It can be treated with a permethrin. Later on, the nodules persist for months to years, so that I'd like to give the intralesional steroids for the patient.
If I do a biopsy from the nodular lesion, will I see the mite or will I see something else?
It is a hypersensitivity reaction.
Okay, what is pseudolymphoma? Can you tell me an oral drug for treatment of this?
Ivermectin.
Dosage?
Dose of
frequency?
200 microgram per kg body weight.
Frequency?
One dose followed by the second dose after 2 weeks.
So why do you require the second dose?
It does not kill the eggs. Eggs will hatch after around 3 to 5 days, so repeated dose is required.
Can you tell me the efficacy of ivermectin versus efficacy of permethrin?
Permethrin is efficient in around 90 to 95%.
97%. Yeah, and ivermectin?
It's around 98%.
We move on to the next spotter. Dr. Dhanraj.
Yes. Good afternoon, sir. I am presenting a case of a 33-year-old female coming with a asymptomatic discoloration over the nail since 5 months. My provisional diagnosis is distal and lateral subungual onychomycosis. There is a brownish discoloration over the distal and lateral nail plate.
Dr. Dhanraj, am I audible? Okay.
Yes, sir.
Okay, this is a spotter you are given, and you described the nail condition already, and you told the diagnosis as well. Will you substantiate your diagnosis? So, what made you think that it is onychomycosis, that is distal lateral subungual?
Sir, since there is a brownish discoloration of the nail plate, sir, and it's involving only the distal and the lateral part, and over the index finger, sir, there is a slight subungual hyperkeratosis that is noted. So therefore, my provisional diagnosis is distal lateral subungual onychomycosis.
Okay, if you are permitted to ask one or two questions, what questions you would like to ask the patient?
Sir, I would ask the patient if they have involvement of the feet or toenails. Usually there can be, or there are prolonged exposure to water. And if the patient is having a prolonged occupational exposure to water, then there's a chance of them developing onychomycosis.
Okay, how do you classify onychomycosis?
Onychomycosis can be classified morphologically into distal and lateral subungual onychomycosis, proximal subungual onychomycosis, white superficial onychomycosis, and endonyx, and total dystrophic onychomycosis, and the mixed forms.
Okay, why can't it be candidal onychomycosis?
Sir, if the patient is having, if it is having a pain over the digits, and there is a white exudate, and there's a social paronychia, then it can, then we can think of candidal onychomycosis.
Paronychia is not a must, isn't it?
Yes.
It's not mandatory that the patient should have paronychia to develop candidal onychomycosis. So the history counts a lot. Huh?
Yes.
A lady who works in the kitchen all the time, or a person who is working as a bartender in a restaurant, or the one who frequently immerses their hand in the water. Huh?
Yes.
They are the one who are more prone to get candidal. In addition, the underlying immunosuppression like diabetes mellitus.
Yes.
That history also you should ask.
Yes.
Because the candidal onychomycosis will also start from the lateral nail fold, isn't it? Gradually, discoloration of the skin. What are the other differential diagnoses you can think of?
Other differential diagnosis, sir, it can be, if there was, it can be lichen planus psoriasis can be other possible differential.
But lichen planus, what nail changes you get?
There'll be thinning of the, mainly there'll be thinning of the nail plate on onychorexis. There'll be transverse, there'll be transverse.
The classical lesion, what you get is pterygium, isn't it?
Pterygium, yes.
Pterygium. And in psoriasis, what type of nail changes you expect?
Classically, pitting will be noted, sir. Pits will be noted over the nail plates, sir. Until the subungual hyperkeratosis.
How do you confirm your diagnosis?
Sir, we can confirm a diagnosis by doing the KOH, sir, potassium hydroxide, 40%. The fungal scrapings can be taken from the under the nail plate at the most proximal end after doing the nail clipping, or the nail clippings can be used. And if the fungal elements are noted, then we can confirm our diagnosis. If still it is not confirmed, then we can do a culture of the clippings, and it will take up to 1 month for the reports for the results to come. And still, if it is negative, we can go for a histopathology of the nail unit.
Which is the commonest organism isolated if you do the culture?
Commonest is Trichophyton rubrum, sir, if we do the cultures.
Till now, rubrum. Now, off late?
Don't know, sir.
Mentagrophytes, more common, isn't it? And consider. And how do you treat after confirming it?
Sir, depending on the extent of the involvement, can give either topical or systemic therapy. In this case, you can start systemic as well as topical therapy. Topical therapy, we can give amorolfin 5%, given once or twice weekly for up to 1 year. And we can also start with cycloperox, or we can start with cycloperox 8% nail lacquer. Systemic therapy, we can give terbinafine 250 mg, that is given for up to 6 weeks for fingernails, and if the toenails are want, then up to 12 weeks. Pulse therapy, we can give terbinafine, that is we can give it 250 mg BD for the first week of the month, for 2 months for the fingernails, and for 3 months for if the toenails are involved. And for itraconazole, we can give 200 mg. We can give up to 2 months for the fingernails.
Sorry to interrupt. Shall we move on to the next spotter?
Okay, Dhanraj, thank you.
Thank you, sir. Thank you.
Over to Dr. Uma Maheshwari.
I'm presenting a patient of age 23 years, 23 years male, presented with painful lesions on lips since 2 weeks. On examination, multiple crusted lesions are present over the lips, involving both upper and lower lips. With this, I would like to come to diagnosis of pemphigus vulgaris.
Just looking at the crusted lesions on the lips, how we can say that it could be pemphigus vulgaris?
Because of the crusting.
Crusting can be seen in so many other conditions as well, isn't it?
Yes, sir.
Where do you get the involvement of the lesions? In which part of the oral cavity? Is it on the lips most commonly seen, or is it in the oral
cavity? Oral cavity is also involved.
Of course, you have a limitation that you cannot examine the oral cavity. And okay, fine. Pemphigus vulgaris is one of the differential diagnoses.
Yes,
and what are the other differential diagnoses you can think of?
It could be drug reaction also, sir, involving the mucosa.
Drug reaction. Yes, good. That's important. Fixed drug eruption. Or it could be part of another drug reaction.
SJS syndrome, Stevens-Johnson syndrome.
NTN. Okay, then. See, there are two scenarios. One is where only the lips are crusted. Crusting, thick crust, lasting for 2 weeks, and they're all painful lesions. What are the things you can think of? If the lesion is just confined to the lips, what are your differential diagnoses? If there is involvement of the other parts of the body, what are the other important differential diagnoses you can think of?
It could be actinic cheilitis also, sir. If exposure to UV light is there.
Actinic cheilitis, you get such thick crust like this and painful lesion. What common conditions you get in and around the lips?
Herpetic lesions.
Yeah, herpetic. Herpetic lesion has to be thought as one of the commonest because they are painful also and they are crusty. Quite extensive, not normally seen, but if it's a primary attack, it can happen like this. Okay, then apart from herpes, fixed drug eruption is the one you thought of, or could be part of Stevens-Johnson's T in overlap. Okay, then actinic cheilitis you told. What are the things you can think? Pemphigus also you already told.
Yes, sir.
So how do you confirm your diagnosis?
To look for other lesions over other parts of the body, sir.
Yeah, that is most important. When you look for the lesion, you have to look for the lesions, isn't it? Depending upon the differential diagnosis, what you have in your mind, you have to look for the lesions. Globulous lesions in the oral cavity as well in the other parts of the body. Can there be pemphigus which is just confined to the oral cavity?
Initially, it will be confined to the oral cavity, and then the skin lesions will be seen, sir.
Yeah, over a period of time, skin lesions can develop. To begin with, it can be just confined to the oral cavity. Fine. What is recurrent erythema multiforme and how does it manifest?
Recurrent erythema multiforme, it's most commonly related to HSV infection, sir. The patients will present with recurrent EMF-like lesions involving the oral mucosa and also involving the palms and soles with target lesions will be seen. So the treatment will be to suppress the HSV infection.
Okay, how do you confirm that HSV infection?
HSV, IgM and IgG assays can be done.
Directly if you have an active lesion?
Active lesion, then you can do Zank smear.
So what do you get there?
Their multinucleated giant cells will be seen.
Okay. So you can do that. And if you are suspecting pemphigus, what's the bedside investigation that we have?
Zank smear can be done, so, which will show the intraepithelial suprabasal split will be seen.
No, the Zank, do you see suprabasal split?
No, sir.
What you are going to see in the Zank, sir?
acantholytic cells will be seen.
Acantholytic cells, isn't it?
Yes. Yes, sir.
Left and all in histopathology we see.
Yes, sir.
Supposing if it is a herpetic etiology.
Symptomatic treatments, mainly saline compresses can be advised to remove the crusting. Then the lignocaine, topical lignocaine can be given. And even and for herpes, mainly the 5% acyclovir ointment can be given. And if HSV etiology is suspected, then oral acivir 400 mg TID or 200 mg 5 times a day can be given for 7 to 10 days.
Okay, what about if it is a recurrent lesion? What is can you give long-term suppressive therapy?
Yes, a long-term suppressive therapy can be given, sir. Acivir 400 mg BD can be given for 6 months to.
In addition to that, in fact, rather than the topical antiviral, so what the other thing which is more useful?
Antibacterial creams like Fusidic cream.
Good afternoon. I'm presenting a case of 34-year-old male with patchy hair loss on his beard area since 2 months. On examination, I examine multiple well-defined patches with hair loss, which are present over the beard areas, along with a few gray hairs. With this, I come with a diagnosis of alopecia areata involving the beard area.
Okay. Can you classify alopecia areata, ma?
Yes, sir. Alopecia areata can depend. There are two classifications. The first is ICARA classification, and the second based on the extent as well as the pattern involved.
Yeah, your ICARA classification, you please tell.
There are four. In ICARA classification, there are 4 types. So the most common is the common type, which is present in 80%. The second type is the atopic type, which is present in 10% of the individual. The third one is the pre-hypertensive type. Then the fourth one is the autoimmune type, which is involved, which has a bad prognosis. Atopy and the pre-hypertensive have reticular pattern of alopecia and has bad prognosis.
Okay. What is the other classification?
The other classification is based on the extent and the pattern, sir. So based on the pattern, they can be patchy, they can be reticular, they can have Uffiasis pattern, Sisypho pattern, they can have, then based on the extent, it will be alopecia totalis, subtotalis and universalis. Also, there are alopecia
pattern?
So Uffiasis means snake pattern, so where the patient will have on the periphery that is involved, the central area has the hair, but the periphery has a hairless patch starting from the occipital and involves the temporofrontal area, and it has a bad prognosis.
Yes, bad prognosis. Okay. So in which group of alopecia this alopecia areata will come under?
In non-cicatricial type of alopecia.
Other non-cicatricial alopecia, can you give example?
Yes, other non-cicatricial alopecia include androgenetic type of alopecia, then telogen effluent, then anogen effluent, then trichotillomania, then even pressure or frictional alopecia.
Okay. How do you differentiate trichotillomania in this case?
One is that in trichotillomania, the hair will be broken at different lengths. And also they can be having perifollicular hemorrhages, and dermoscopy or trichoscopy will help in differentiating the two conditions. In case of trichotillomania, you're going to have V-shaped hair or flame hair, and also you're going to have hair dust or hair powder, which is characteristic of trichotillomania.
Okay. So what are the trichoscopic feature of this alopecia areata?
Yes, the trichoscopic features are mainly presence of white dots and black dots. The black dots are nothing but the broken hair which at the level of the scalp. Apart from that, you're gonna have the characteristic regrowing hair or the pigtail hair, which will have which are nothing but regular coiled regrowing hair. Then we are gonna have the cordiality sign, that is the hair will kink at near the scalp area. The hair will have a bend or a kink.
Okay. So what are the treatment options?
Sir, first is the topical treatment. If the area, depending on the area of involved, topical treatment and the systemic treatment. The topical treatment mainly includes topical steroids, which can be in the form of foam or under occlusion. Then intralesional corticosteroids can be done, can be applied, and then contact sensitizers contact sensitizers like TNCB or DPCP or the squaric acid. Acid, and then we can also use anthralins, 0.5%. Then minoxidil can be used as an adjuvant treatment. Coming to coming to the systemic treatment, we can use steroids. Either you can give in the form of oral mini pulse, or you can give if the extent of area is more, you can give even pulse therapy. Then other steroid sparing agents like cyclosporin, methotrexate has been tried. Then even sulfasalazine and JAK inhibitors like tofacitinib. And then you can also give phototherapy in the form of turban puva.
Okay. Contact sensitizer, can you elaborate what is the mechanism of action?
Yes, sir. The contact sensitizers work on the mechanism of antigenic competition. They themselves produce an allergic type of allergic contact dermatitis, and that's why the suppressor T cells are recruited, and that's why it decreases the inflammation around the patch. Also, it will decrease the CD4 count around CD4 count, therefore normalizing the CD4 to CD8 ratio. It decreases the inflammatory cytokine release from the neutrophils and the lymphocytes. Sir.
How do you do it?
Sir, we have to dilute it. If in case of DPCP, you have to give at a dose of 0.001% and gradually keep
beginning.
By doing a small patch tester. I will keep it. I will apply it in the retroauricular area or on one of the patches and observe for 48 hours. If there is no sensitization, then I can proceed with the treatment. Where I gradually increase the dose and keep it for around 20 to 30 minutes or till the erythema appears.
The procedure is a little different. You have to go through it.
Okay, sir. Okay.
So out of these three,
DPCP is better, sir.
Yeah. Okay.
Shall we proceed on to the next spotters?
Yeah, sure.
Dr. Daisy.
Yes. Presenting a case.
Okay. I explain the lesions.
Male with itchy lesions on the scalp. I can see multiple atrophic patchy areas over the scalp, and there are some tufts of unaffected hair.
Okay. So any color changes are you seeing in the slide in the affected area? Is it a normal scalp color, or is there any little variation in the color are you seeing?
Violaceous.
Okay, violaceous changes you are seeing. So why do you tell it's a atrophic patch? So atrophy means what features you will see? Okay. So based on your finding, what could be the diagnosis?
So I would put it as pseudopellidae of Brock.
Okay. So what is the pseudopellidae of Brock? So what is the other name which can be given for the pseudopellidae of Brock?
Snow prints in footprints in snow appearance.
Okay. So pseudopellidae of Brock is a variant of which condition?
So cicatricial alopecia.
Yes, cicatricial alopecia. How it is classified?
So there are two classifications. One is according to the infiltrate. So the Norwegian Research Society classification, where there can be either lymphocytic, neutrophilic, or mixed infiltrate. Lymphocytic, it can be further classified into discoid lupus erythematosus and lichen planopilaris, which could be classical lichen planopilaris, frontal fibrosing alopecia, or Graham-Little-Picardy Lossier syndrome. Then it can be centrifugal cicatricial alopecia, keratosis follicular spinulosa decalvans, and pseudopellidae of Brock. and the neutrophilic would be dissecting cellulitis of the scalp and folliculitis decalvans and mixed acne necrotica or follicular necrotica and acne keloidalis nucae, acne keloidalis. And the second classification according to the causes, it could be either developmental or hereditary. It could, for example, cutis, epidermolysis, dystrophic epidermolysis bullosa, incontinentia pigmenta, and it could be traumatic in case of some lymphomas and squamous cell carcinoma, basal cell carcinoma, or it could be any traumatic conditions like any thermal injury and even persistent trichotillomania or persistent traction alopecia, or it could be folliculitis with follicular inflammation with pustules and without pustules. In with pustules, there will be tinea capitis, folliculitis decalvans, and and without pustules, frontal fibrosing alopecia and pseudopelludia of Brock.
So I will make a statement that pseudopelludia of Brock is a variant for lichen planopilaris. I am telling the true or false.
No, sir. So there is no.
So it is not.
No, sir. So in pseudopelludia of Brock, there is no follicular plugging and there is no perifollicular inflammation, and and the elastic tissue, it is preserved here. Whereas in frontal fibrosing alopecia or LPP, there will be a wedge-shaped superficial scar if we stain with elastin.
So in the classification, you told pseudopelludia of Brock comes under lymphocytic infiltration.
Yes,
and
sir.
you are telling that there is no peribulbar inflammatory infiltrate. Are you not contradicting your statement?
So it's a diagnosis of exclusion, pseudopelludia of Brock. So we have to first rule out, like according to the diagnostic criteria, only then we can confirm the diagnosis.
So you mean to say there is no inflammatory infiltrate around the lesions?
For lymphocytic, it's there, but it is not so much.
Okay. In alopecia areata, do you find the infiltrate around the?
In alopecia areata, the infiltrate would be peribulbar, and in these cicatricial alopecias, it will be in and around the upper follicle, the bulge area.
Okay. So that is the reason why you get cicatricial in this case, because it will affect the stem cells. Whereas in the alopecia areata, it doesn't affect the stem cells, so it will regrow. The hairs will. So what is Gram-Little Picardy-Loser syndrome?
It's a triad
of
components? Yes, sir. It's a triad of cicatricial alopecia of the scalp, a non-cicatricial alopecia of the axilla and the groin, and there'll be a follicular spinous papules over the scalp or the body, or it can involve both also.
So why did you make a diagnosis of pseudopelludia of Brock in this case when you are seeing a violaceous lesions? Could it be a lichen planopilaris also? No?
So lichen planopilaris, classical one. So there will be perifollicular erythematous papules to begin with in lichen planopilaris, and perifollicular erythema and scaling will be there.
Here, erythema is seen and violaceous is also seen.
Yes, sir.
Okay. So what are the biopsy findings?
In pseudopelludia of Brock, sir?
Yeah.
So there'll be a lymphocytic infiltrate around the the bulbar region, and and there'll be follicular fibrosis.
Okay.
Yes, sir. And also the elastic tissue will be preserved here. It will not be involved. And yes, sir. And there will be
How do you
Yes,
treat?
sir.
Yeah.
Yeah, we have.
Yeah.
Time limit is over. Sir.
Okay, no problem.
Thank you, Dr. Daisy and Dr. Naveen Kane. We have come to the end of the spotter session. I thank Dr. Naveen Kane, Dr. Bhavna Doshi, Dr. Ravi Rathod, and all the postgraduate students for their participation. Thank you.
We shall now take a short break. Please join us for the next session at 3:45 p.m. Good evening, everyone, and welcome back. We now resume our program. Our next session is case discussion on connective tissue diseases. I request all the postgraduates to send in their questions in the chat box, and these questions will be taken up for discussion at the end of the session. I request the host to connect with the faculty and residents of the session.
Welcome all of you to this case discussion on connective tissue disease. Our esteemed faculty for this session are Dr. Lilavati, Professor and Head at Bowring and Lady Curzon Medical College, Bangalore; Dr. Mary Augustine, Professor at St. John's Medical College, Bangalore; and Dr. Lakshmisha Chandrasekhar, Professor at JIPMER, Pondicherry. The postgraduates who will be participating in this session are Dr. Sharon and Dr. Ansi from St. John's Medical College, Dr. Soumya and Dr. Ujjwal from Bangalore Medical College. I now request Dr. Ansi to share her screen and start presenting the case.
Good evening, everyone. Starting with the history, a 35-year-old female patient, a homemaker by occupation, hailing from Raithur, Karnataka, presented with chief complaints of swelling of both hands since 5 months, tightness of the skin since 4 months, difficulty in swallowing and restriction in opening the mouth since 3 months, discoloration of the skin since 2 months. History of presenting complaint: the patient was apparently well till 5 months back when she presented with swelling of both hands, which lasted for 1 month's duration. It was gradual in onset, and then it subsided gradually, resulting in tightness of the skin that started from fingertips, gradually progressed to both hands, forearm, neck, and to the face in 2 to 3 weeks duration. Patient had no restriction in carrying out movements of the hand, except for the right hand little finger, that is secondary to trauma. I'll be explaining in detail in the past history. And patient had difficulty in swallowing solid food for the last 3 months. No history of difficulty in swallowing liquid foods, regurgitation of food, retrosternal pain. No diarrhea, bloating sensation of the stomach, or abdominal pain or constipation. History of restriction in opening the mouth for the last 3 months. It was gradual in onset. History of painful and bluish discoloration. Patient reported that it was initially when she washes clothes and vessels, it turns white in color, then gradually to blue, and then to red. The whole the episode takes about 5 minutes, and patient has 5 to 10 episodes each day. History of whitish discoloration of the skin over the neck and upper back for the last 2 months. No history of difficulty in breathing, chest pain, palpitations, or dry cough. No history of blood in urine, reduced urine output, headache, or blurring of vision. No history of chalky white discharge, ulcer, hard lesion over the joint. No history of drug intake prior to the onset of the skin problem. No history of repeated fever, oral ulcer, joint pain, or photosensitivity. No history of dryness of the mouth, foreign body sensation of the eye. No history of difficulty in combing hair, getting up from squatting position, or swelling around the eyes. Patient has not received any treatment so far for the above mentioned complaints. Past and family history: the patient gives history of trauma to the right hand little finger 10 years back, following which he has difficulty in extending the right hand little finger. No history of diabetes, hypertension, asthma, or tuberculosis. No significant other family history. Personal history: patient's diet is mixed, sleep and appetite normal, bowel and bladder movements are normal, no substance abuse, and no known drug allergies. Menstrual history: patient is unmarried, periods are regular, 5 days flow every 28-day cycle, normal flow.
Now the forum is open for discussion by the examiners.
Nancy, you said history of photosensitivity. It's there. So why did you ask for photosensitivity?
Yeah, ma'am. The negative history of photosensitivity is important, and we should be asking regarding photosensitivity because in a case of connective tissue disorders, quite often we can find overlap between the syndromes. So even when we are suspecting one connective tissue disorder, we should be asking negative history regarding other connective tissue disorders as well.
Yeah, that's exactly correct. But is it of, primary importance looking at her, like you have other points, important points in negative history, like when you know the probable diagnosis.
Yes.
You said overlap, that's fine, because even in a large cohort which was conducted, they have found out that diffuse, systemic sclerosis per se occurring, it's very, very rare. Some features of, as you said, overlap will be there.
Yes.
So what are the other important negative points or history you should be eliciting when you know the probable diagnosis?
Yes,
so what are the other negative
probable negative history will be, we'll have to look for the other systemic involvement in case of systemic sclerosis, ma'am.
Okay.
Like GI involvement, if it is there, we have to ask regarding regurgitation, dyspepsia, constipation, etc. Then in case of respiratory system involvement, we should be asking regarding the exertional dyspnea, any breathing difficulty. To look for renal crisis per se, we can ask for history of any headache or blurring of vision or edema of the and for heart involvement, cardiovascular system involvement, arrhythmia can be there, so we can ask ask the patient regarding any palpitation.
Okay.
Can I ask a question?
Yeah.
Dr. Soumya?
Yes, ma'am.
Yeah. Do you think an occupational history is important for this patient?
Yes, ma'am.
Why?
Yes, ma'am. Those who are involved in work related to vibration, ma'am, and multiple trauma, types, and those who work in cold environment, they are also predisposed to developing this type of lesions, ma'am.
Anything else? Any other exposure? Dr. Ujjwal?
People who work in factories which produce hydroxycarbons, especially chlorinated hydroxycarbons or vinyl chloride, they also are predisposed to have scleroderma-like lesions, ma'am. And as Soumya told, they can also have vibratory function, mechanics, or people who use hammers and jackhammers or machines are predisposed to scleroderma, ma'am.
Any drugs you can think of?
Drugs like bleomycin, taxanes, paclitaxel, cisplatin, carboplatin, especially this the ones used in cancer treatment, can cause scleroderma.
Pentazocine. Yeah, pentazocine. Also silica. PVC.
Yeah. Okay. And you said repeated fever, Nancy?
No, ma'am. There was no history of fever.
No
history of fever or oral ulcers is what I had mentioned.
It's negative history, is it?
Yes, ma'am.
But why do you say repeated fever? What do you understand by repeated fever?
That was in case of systemic lupus erythematosus, ma'am. Like since those people, since they are immunocompromised, the history of recurrent fevers will be there.
Can you reframe that word? Soumya? Systemic lupus erythematosus. What type of fever, Ujjwal?
Ma'am, according to ARA criteria and SLIC criteria, ma'am, for the definition of For diagnosis of SLE, fever is one of the major criteria, and the patient is supposedly have an undulating continuous fever, or it can be a quotidian type of fever, ma'am.
ARA doesn't have fever. ARA criteria?
There is no fever for system.
No, sorry.
No, you're talking about SLE, I think. No, are you talking about SLE? Yeah.
SLE, ma'am.
ARA criteria doesn't have.
SLE.
Okay. Yeah, basically it is to rule out
SLE.
overlap with other conditions, other connective tissue disorders. Lakshmisha?
Yeah, so I have one question. So you have asked Dr. Ansi about all this history to rule out overlap, right?
Yes, sir.
You asked about photosensitivity, oral ulcers, etc. So but my question is, why do you think it is scleroderma to begin with? So you will ask these questions if you suspect scleroderma, right? So,
yes, sir.
And I think there was a discussion on jackhammers and vibratory tools, which basically cause Raynaud's phenomena.
Yes, sir.
Raynaud's is you get, in number of conditions, whether it's primary or secondary.
Yes, sir.
And it is associated with scleroderma, and it's one of the major criteria. But just having Raynaud's doesn't make it a diagnosis of scleroderma. So
yes, sir.
I think the first question which you should elicit in your history is whether it's scleroderma or not. For example, I could say, without going to further, that you're talking about generalized morphe, or a type of extensive morphia, and not scleroderma or some other condition. So how do you know that this is scleroderma? I mean, there are some criteria. See, you need to think about first, am I dealing with scleroderma or not? If I'm dealing with scleroderma, is there overlap or not? And the third thing is, are there any triggers? So whether it is infection, whether it is drugs, whether it's exposed to pesticides, etc. And the fourth thing in history would be, are there any complications? So I would like to know about the lung, I would like to know about the CNS, I'd like to know about the heart. But the first question is, I might say the indication of it is scleroderma adultorum.
So to start with the first question, sir, my patient had swelling of both the hands initially, and which then progressed to have tightness of the skin, which started from the fingertips and then progressed. And the other thing is, this patient had tightness of the face and difficulty in opening the mouth, along with history suggestive of dysphagia to solid food was there, sir. So to rule out scleroderma diabeticorum, that my patient did not have any foci of infection or any other comorbidities like diabetes mellitus.
I think you got confused with scleroderma adultorum of Buschke versus scleroderma diabeticorum.
Yes.
The adultorum of Buschke is the one which is associated with streptococcal infection. So that's one. But that's usually in children. You don't get that in this age group. Here, if you get, more likely to be a paraneoplastic one, and that is usually due to paraproteinemias.
Yes, sir.
I would argue that what you are saying is eosinophilic fasciitis. It usually starts at the extreme at one limb, but it can be symmetrical.
Sir, but there is history of difficulty in opening the mouth with dysphagia, sir, which might not be seen.
That can also occur in scleroderma adultorum. It can even involve the tongue. Up to the upper esophagus can be involved.
So history suggestive of Raynaud's phenomenon was there in the history, sir.
Okay. Yeah, that's a very, very important thing, and you need to stress Raynaud's phenomena, because in many of these conditions, for example, even generalized morphia, you usually, I won't say never, usually Raynaud's phenomenon is absent, and that you need to stress on that. So what I'd like to suggest is you need to avoid these questions coming. So you need to take care of them in your history itself, so that somebody doesn't start asking. You have gone for scleroderma and somebody starts questioning you on a different line altogether. That should not happen. So whether it's eosinophilic fasciitis or it's a generalized morphia, you need to take that into account. Okay.
Yes, sir.
So also make sure that you have conveyed the impression that that we are talking about scleroderma.
Yes, sir.
So that's what the 4 questions is: whether it's scleroderma or not. Make sure that you have decided that scleroderma doesn't come in a differential, so use that as sort of negative history, especially in a younger age. In older age you don't have this problem, but in a younger age you need to keep this point in mind. Okay, so that's something which you need to come. Then complications.
Yes, sir.
Then overlap. And then etiological agents, whether pesticides are a very common thing which usually are associated with it, but in many of these cases Raynaud's phenomena is not present. That's something which is a very, very important clinical clue. And you could even talk about the way it is starting. For example, the hands are usually relatively spat when you're talking about sclerodema. So you need to focus on some of these points before the examiner starts asking you a multitude of questions, right? So that's always a good idea to divide what are the 4 things you would like to convey to the examiner in your history itself.
Yes.
Thank you.
Coming to the examination of the patient, general physical examination. Patient is conscious, cooperative, well-oriented in time, place and person, moderately built and nourished with a height of 154 centimeter, weight of 48 kilogram and BMI of 20.2. Vitals, pulse rate is 84 per minute over the right radial artery, regular in rhythm, normal in character and volume. All the peripheral pulses were well palpable. BP is 118/76 millimeters of mercury measured over the left hand in supine position. Respiratory rate is 18 per minute and saturation is 97% in room air. Temperature is 97 degrees Fahrenheit. There was no pallor, no icterus, no clubbing or cyanosis, no generalized lymphadenopathy and no peripheral edema. Coming to the systemic examination, the respiratory system, trachea was central. Chest movements were equal bilaterally. Chest expansion was 4 centimeter measured at T4 level. Normal vesicular breath sounds were heard bilaterally on all lung feeds or auscultation. There was no bibasilar repetitions heard. Per abdomen examination was soft, non-tender, and there was no organomegaly. Cardiovascular system examination, S1, S2 were heard normally. P2 was normal. There were no murmurs. Coming to the central nervous system examination, higher mental functions were normal. There was no focal neurological deficits. And coming to musculoskeletal examination, there were no tendon friction rub. Power of the muscles were 5/5. The range of movements of all joints were normal except for the fixed flexion deformity of the right little finger and the proximal interphalangeal joint. There were no swollen or tender joints. Cutaneous examination. Skin over the forehead and the malar region appears shiny and indurated with loss of wrinkling of the forehead. There is inability to retract the lower eyelid bilaterally, that is, Ingram sign was positive. There were no evidence of peaking of the nose. The lips appear thin and taut. There is difficulty in opening the mouth and the mouth opening is 3 fingers. Hence, the patient had grade 1 microstonia. There was no evidence of telangiectasia noted. Indurated, shiny, hyperpigmented skin noted extending from the neck region to upper chest till T4 level. Focal areas of salt and pepper pigmentation was noted over the upper chest and right shoulder region. There was no evidence of telangiectasia, and when the neck was extended, ridging and tightness was noted on the neck in the platysmal region, which was palpable. Hence, Barnett's neck sign was positive. Over the back, induration of the skin noted extending from the back of the neck till the lower part of the scapula. A linear patch of salt and pepper pigmentation noted extending from the lower part of the hairline till the upper back. Skin over both the arms and forearms appear taut, hyperpigmented and shiny with induration of the skin extending from the dorsum of the fingers and hands and till the shoulder region. Loss of hair were noted on both the arms. There were no evidence of calcinosis noted. Examination of hands and fingers. Color and temperature of the fingers were normal. Induration of the skin were noted over the dorsa of bilateral fingers and palms extending beyond the wrist region. A fixed flexion deformity of the little finger of the right hand noted. No evidence of pitted scars or fingertip ulcers were present. The pulp of the fingertips appear rounded, hence Misutani sign is positive. No evidence of dilated nail fold capillaries noted on examination with a magnifying lens. No evidence of telangiectasia. Examination of the nails, the cuticle, the nail plate, the nail bed and the hyponechium appears normal. There was no periungual pallor. Raynaud's phenomenon could not be elicited and the nail fold capillaroscopy was not done. Skin over the legs appear shiny and taut with induration of the skin noted extending from the ankle region till just above the knee joint bilaterally. Loss of hair noted over the region. The toes appear normal. Oral mucosa appears normal and moist. Protrusion of the tongue was normal. There were no evidence of dental caries or loosening of the teeth. Genitalia was normal. Eyes appear normal. There were no evidence of conjunctivitis or xerosis. Hair was normal. Breast and thyroid examination were normal. There was no evidence of calcinosis or telangiectasia noted. Hence, with the above history and examination, the provisional diagnosis I would like to give is diffuse cutaneous systemic sclerosis with a possible involvement of GIT, and the modified Rodnan score for this patient is 28.
You can stop sharing your screen. The session is open for discussion now.
Yeah, Dr. Sherin?
Yes, ma'am.
Just like we did in the history,
yes, ma'am.
Came to the final diagnosis of diffuse systemic sclerosis.
Yes,
First of all, why did you make the diagnosis of systemic sclerosis?
For diagnosing systemic sclerosis, according to the ACR Euler criteria, the sufficient criterion was satisfying, meaning there was thickening or induration of the skin extending beyond proximal to the metacarpophalangeal joints, which was positive for this patient. Hence, I made the diagnosis of systemic sclerosis. In this patient, I made the diagnosis of diffuse systemic sclerosis because the induration was extending beyond the elbow joint and also beyond the knee joint. So, hence, I made the diagnosis of diffuse systemic sclerosis in this patient.
Sorry, just to ask, but did you make it just based on that one criteria that there is induration proximal to the metacarpophalangeal and metatarsophalangeal joint, or did you have any other clinical findings which you used to support your diagnosis of systemic sclerosis?
So, one sufficient criteria was there which helped me to diagnose. Other findings, history of Raynaud's were there, sir, in this patient to support my diagnosis, which also...
Sorry, but I saw in your thing that you said that you could not elicit it.
Yes, sir. I could not elicit it during my clinical examination.
Is there any particular reason you felt that you could not elicit a Raynaud's phenomena when you had a strong history of it?
Maybe the temperature I elicited this was not adequate, sir.
Okay. Anything else? Do you think that why you could not elicit?
Maybe the patient had already been started on treatment, sir.
Yeah, that's also an important thing which I wanted to ask, whether the patient was already on treatment. That's the
yes,
other
yes,
important thing.
Yes, patient was already started on treatment, sir.
But suppose if I say no, I don't believe your thing and there's no evidence of Raynaud's, what would you do?
Sir, I can ask the patient to immerse her hand in a cold water, sir, at around 10 degrees Celsius.
I assume you tried that?
Yes, sir, I tried that.
So it didn't work?
Yes, sir.
Okay. You can use thermography in such a situation.
Yes, sir.
So that will give you a simple clue and it's very easy to do it. You could use thermography. So otherwise, but still your score has to come, no? So you're only having one major criteria. So from where are you getting the other criteria from?
Sir, one major criteria is sufficient enough to diagnose, sir.
See, you have to remember there is in the small columns down. After make sure that all other things are ruled out. There's one small line, it will come in between. So right, so you have taken one thing and say that is systemic sclerosis. There are many other, that is...
Yes, sir. Other criteria means it should come in the investigation part, sir. Okay. Like for this patient, autoantibodies were positive, sir.
Okay, fine. We'll discuss that later. So that's what I want to convey, that it's not sufficient just to have one criteria. It may be there, but you have to rule out other conditions. That will be in the small lines below. See, you did not examine for nail folds?
I examined for nail folds, sir. I did not do the nail fold capillaroscopy. It was not available with me, but with the magnifying glass I examined.
You don't need a capillaroscope. You can borrow it from your colleagues in ophthalmology. You can take an ophthalmoscope, shift it to +10, and just add a drop of oil. And I'll tell you why it's important, because suppose if you do a nail fold capillaroscopy and it is normal.
Okay, sir.
You understand? Then you have to think of other conditions.
Other conditions, yes, sir.
You are not. It's very unlikely that you have systemic sclerosis without the primary pathology is in the vasculature, and without demonstrating nail fold changes, or if it's a normal nail fold change, then it is very difficult to proceed further, isn't it?
Yes.
Right? Sometimes if it is very advanced, then it's easy. You can make it out with the lens.
Yes, sir.
That is, you add a drop of oil and examine. But if it is not, and if it's very, very subtle, there is a few dropouts, then that you cannot pick it up.
Can you tell me how you elicited, how do you for Raynaud's?
Ma'am, I gave in a tumbler, I gave the patient water, ma'am, cold water at around 10 degrees Celsius. I asked the patient to immerse her hand and ask for any pain or color change. Like I'll actually observe after 10 to 15 minutes, ma'am. Ma'am, initially the patient will perceive a sensation of pain, and when we observe, we should actually first see the pallor. And ideally it should be pallor, which is followed by cyanosis, ma'am, and then comes the redness. But in some cases it can be biphasic Raynaud's also, pallor which will be followed by redness alone. That cyanosis part might not be elicitable in all cases.
I mean, did she say what is the frequency of this Raynaud's attack she had?
10 episodes per day.
She had 10 episodes.
See, sorry, ma'am, to interrupt, but if you're having 10 episodes per day, no, I'm just talking about theoretically, I have not seen the patient. Do you really think that she will not have a pitted scar? I mean, this is hypothetical, I have not seen. So, if you're having 10 episodes per day.
Yeah. Did she really have this color changes, or what exactly the actual color change? What exactly did the patient have?
Patient gave history of color change, ma'am, when she's doing daily activities like washing clothes and vessels. She gave history suggestive of bluish discoloration associated with pain.
Okay, I mean, it's possible. I mean, it's possible, but just keep in mind that when you have so many episodes per day, that you don't have a pitted scar. That's slightly odd, but maybe she's on treatment or something.
Yeah, what's the duration of Raynaud's?
3 months duration, ma'am.
Maybe it's a bit too short.
It's possible. It's possible.
So she has 3 months history of Raynaud's and 5 months history of the other things, the swelling and all that, right?
5 months back, she had swelling of both the hands for 1 month, following which tightness of the skin, that was for 4 months.
Yeah. So Dr. Ujjwal, how do you interpret that? That is the onset of Raynaud's phenomenon in relation to her other symptoms.
Ma'am, the skin tightening in scleroderma usually starts with edema and the swelling of the fingertips, ma'am. Raynaud's phenomena is usually accompanied, but it can occur before the skin tightening, or with the skin tightening, or after the skin tightening has occurred.
It can happen either way, but how do you interpret it with respect to the onset? When the Raynaud's started in relation to the rest of the skin features, is it important? Does it help you differentiate one from another?
Ma'am, in limited type, Raynaud's phenomenon will precede the skin tightness, ma'am, for many years, whereas in secondary Raynaud's phenomenon.
And as a system diffuse type, it can be at a short period or even along with or after the onset.
So your diagnosis was on ACR criteria or EULAR classification, Nancy?
EULAR classification criteria, ma'am.
So scoring, how did you do the scoring? Can you just tell me what scores?
Okay, ma'am. Ma'am, it has 8 points, ma'am. It's a score-based criteria. So first will be skin thickening bilaterally extending proximal to the metacarpophalangeal joints. It will carry a point of 9. The second point will be skin thickening of the fingers. In that, puffy fingers will carry a score of 2 and the whole finger thickening will carry a score of 4, ma'am. Then next point is fingertip lesions. If it is a digital scar, means it will be a score of 2, and if it is a digital tip ulcer, there will be a score of 3. Then the next one.
Ulcer is 2 and scars are 3.
Okay. Then telangiectasia will carry a score of 2. Then abnormal nail fold capillaries will carry a score of 2 again. Then if the patient have systemic features of pulmonary artery hypertension or interstitial lung disease, it will again carry a score of 2. Raynaud's phenomenon carries a score of 3. And if patient has scleroderma related antibodies, it carries a score of 3, ma'am.
Okay. So now coming to your patient, how did you come to the score? You said what was the score? 28. Huh?
No, ma'am, that is modified Rotnan, ma'am.
Yeah.
This is classification criteria you asked.
Okay. So your patient had as per modified Rodnan.
28. 28. Yeah. Hello, ma'am. Yeah. So modified Rodnan criteria is a scoring system for systemic sclerosis where the body is divided into 17 anatomical sites like the face, the neck and the upper chest, face, the chest and the abdomen, and on the hands, the fingers, the hands, the forearm and the arm both sides, and on the legs, the thighs, the legs and the feet. And in each site, we have to measure the induration from a scale of 0 to 3, where 0 will be no induration, 1 will be indurated but pinchable but not movable. So 2 will be, 2 will be pinchable but not movable, and 3 will be very severe induration.
Second is not pinchable. But
not pinchable but movable, and third is very
not movable.
Dr. Shireen,
yes, sir.
Can I ask you a question? Yeah. Yes, why do you need to do the Rodnan score?
The Rodnan score is important because one way, if the Rodnan score is high, it means the patient has a very poor prognosis, and it can indicate that if the higher scoring said that they will be having underlying systemic involvement as well. And second is to monitor the treatment, sir.
Okay.
In this patient.
Okay. What do you think is a natural cause for scleroderma? You don't treat it. What would happen to the skin? What will happen to your Rodnan score? Say today it is 28. Maybe say 3 years later, what do you think it will be? You don't treat, don't do anything.
It can remain the same or it can worsen also, sir.
But what is the natural cause?
It will worsen, sir.
Always worsen? The skin tightness per se, what happens to that?
It can remain the same, ma'am, or it can...
No. See, it has 3 stages, isn't it? You have the edematous stage, then the indurative, and then the atrophic.
Yes,
so this doesn't, even if you don't treat the final course, it tends to improve over time. So in some patients, it becomes really, really bad. That's a small minority. So the question is, are you going to treat it based on your Rodnan score?
No, sir.
So what are you going to treat systemic sclerosis patients by?
By their systemic involvement mostly.
So that's the most important thing. So you don't treat based on skin involvement, and that there is sometimes you do it, but mostly it is you're directed towards your organ involvement, and that's something which is really, really important, that you need to understand that whatever treatments we do, you may say 28, 24, whatever it is, but your treatment plan doesn't change depending upon the severity of skin, right? So that's my problem with this Rodnan score. I mean, you do it, it's good for trials. You can do phototherapy, and then you can measure that, but it doesn't reflect what happens internally. One more question which I want to ask you is, do you think if a person has Raynaud's phenomena, would you like to look into the drug history? No,
Yes.
I'm not talking about drugs which cause scleroderma. I'm asking what is the significant drug history you would look for? I'll give you an example. Suppose the same person had migraine. What would you do? What did you look for in the history, and maybe modify it so that the Raynaud's phenomenon doesn't worsen?
So I'll have to. There are certain drugs which can precipitate Raynaud's phenomena.
Name three. Name three of them. Most important ones.
Okay,
There
so
are many others, I agree, but name three.
beta blockers, ergotamines.
Yes. Okay. Smoking in men and OCPs in women.
OCPs.
So you need to be very, very careful about these three. They worsen it.
Yes.
And especially beta blockers, which are used for hypertension, they worsen Raynaud. So you need to take them off.
Yes.
And normally we don't consider. So that's a very, very important thing. So thank you for pointing that out.
Sorry to interrupt, but did you mention anything about peripheral nerves, Nancy?
Sherin, ma'am. No, ma'am, I did not mention anything about peripheral nerves. Actually,
is it important?
Yes, ma'am, because the nervous system involvement of systemic sclerosis can be, there can be peripheral neuropathy can be associated with systemic sclerosis.
Did you do it or you didn't?
I did not do it, ma'am.
Coming to investigations. Investigation CBC showed low HB of 10 milligram per deciliter. Others were normal. LFT and creat were within normal range. ESR was elevated to 70 mm per hour. Blood urea, serum electrolytes and FBS was within the normal limit. Urine routine microscopy was normal. Chest X-ray in this patient was normal. ECG was normal. Histopathology, epidermis was normal. Dermis showed collagen bundles closely packed and homogeneous with few blood vessels seen within the sclerotic collagen. They had a fibrotic wall and narrow lumen. ANA showed 2+ speckled pattern, and ANA profile showed SEL 72+. Investigation, barium swallow showed there was constriction at the lower esophageal sphincter level, and the esophageal manometry showed aperistalsis at the lower end of the esophagus. Other investigations like 6-minute walk test, PFT and CT scan done was normal in this patient. That's all with the investigations.
Is there a difference between barium swallow and barium swallow through?
Yes, ma'am. Barium swallow is done to visualize esophagus, whereas follow through is for intestine.
So which one would you advise?
Barium swallow, ma'am.
Swallow through, actually you should be seeing. It's a dynamic, what you see. Swallow through, like, you can see the peristalsis and all that.
Okay.
So it's follow through which is important than barium swallow.
Okay.
Yeah, I'd just like to make one comment, and I think is that this regarding the peripheral nerve involvement, and I was really impressed when you honestly said that you didn't do it, and I think that's something which more than other things, learning from that and being very honest about it is something which every examiner is really happy and appreciates that. So I think that's really a good thing to take off from, other than all the learning material, that the fact that when you have not done, just say that you have not done instead of coming out something. So I appreciate you for that. That's something which is it's really a good thing.
Yeah.
Why did you ordered for an ANA test? Because you thought of thing. So why did we have to do the SEL 70? I mean, do you do it routinely, both of them together, or do you order for the ANA test and then do the ANA blot?
Sir, I would like to order both. the SEL70 and the other one is to differentiate whether patient has limited scleroderma and diffuse. Although clinically we'll be able to diagnose that as well. Like few patterns like SEL70 is associated with diffuse. Few like centromere pattern is seen mostly with limited scleroderma type.
Okay, I'll tell you why I asked you that question. See, the problem, the greatest test which is misused is the anti-nuclear antibody test.
Yes, sir.
If you send an nuclear antibody test, there is a high probability that in the population which you send it, it will turn out to be positive. Now, once it turns out to be positive, then sometimes you really don't know what to do with it. Now, having ANA positive, then you ask for an ANA blot. So you'll have SM positive, you have ACL70 positive, you have dopa emissaries positive, you have RNP positive. What do you do with them? So, see, this is the problem. Okay? So one thing is, the first thing, I mean, there are many ways you could do it, but the first thing is to do an ANA by immunofluorescence. It is very important that you know the patterns. And each pattern corresponds to a particular set of antibodies. For example, in this case, you got speckled. So when you have speckled, what are the antibodies you have? You have anti-Rho, you have anti-La, you have anti-UNRNP. Right? So you know these are the antibodies. So then you could make a decision whether I want to do it or not. Or what are the subsets of the extractable nuclear antigen I could order for. Okay, in this case it's okay. I do agree with you, anti-ACL70, 70% of it you do get it. But please keep in mind that please order in sequence, because sometimes you don't know what you do with it. Suppose if I added I will say that I will rule out myositis also. Maybe CPK is mildly elevated. Then I will find another set, anti-Rho 52 positivity, anti-U3RNP positivity, anti-Jo1 positivity. But you don't know what to do with them. And once you get a positivity, you are stuck. So always remember, you must be very familiar with your ANA patterns. Then order for it depending on what you think clinical symptoms are. That's extremely important.
Yes, sir.
So my question to you is this. Suppose if your ACL70 was negative, would you treat this patient differently?
So I would still treat the patient, sir, based on history and examination.
So that's the answer to the question, right? So always ask for the ANA by immunofluorescence, not by ELISA, by immunofluorescence. Okay? And then depending upon the pattern which you see, ask for the respective ENA.
Yes, sir.
Okay? Otherwise, it's the same problem. So if you are going to treat irrespective of the result of the test, why order the test? So that's the reason why I just wanted to make it a point as to why order both of them simultaneously. Just think about it.
Yes, sir.
And you said 6-minute walk test. I think, so why would somebody do a 6-minute walk test? What does it indicate?
So that is mainly to see if the patient has lung involvement, sir. So basically a normal person will be able to walk 6 minutes without taking a break. Whereas if patient with systemic sclerosis has lung involvement, they would hardly walk for maybe for 2 or 3 minutes, and then they'll feel breathless. They wouldn't be able to complete the 6 minutes.
Do you think 6-minute walk test is the poor man's PFT?
Yes, ma'am. Yes, sir, it is.
So if you already have a PFT, then there is no need for the 6-minute walk test?
So that is to look if there is lung involvement.
It's a functional capacity.
Yes, sir.
It elicits your functional capacity. And it's not only that you do for the 6-minute walk test. The other reason is you could also monitor. It's very easy to do it, isn't it? On the bedside you could monitor 6-minute walk test. Okay, you do it, then 3 months later you could just ask him to do the 6-minute walk test. It's so easy. It's reproducible. Right?
Yes, sir.
Whereas in the PFT, sometimes this effort tolerance is a problem. They're not able to blow properly. So sometimes quality control issues are there in a PFT. Sometimes. So those are things one needs to. It's not a substitute for a PFT, but yes, it is something which is reproducible. It's something which it's easy to do. And you said you did a chest X-ray?
Yes, sir.
And you did a HRCT, high resolution computed tomography also. Could you have been satisfied with the X-ray?
So X-ray might not pick up early changes of the lung source. That's why we went ahead with CT scan, sir.
So why are you so particular about picking it up early?
So because patient once develops lung complication and goes into lung fibrosis, that is the most common cause of death in patient with systemic sclerosis. So that is why it's very important to pick it up early, sir.
Yes, so that's why do not be satisfied, and by the time you get your X-ray findings and it shows your opacities or honeycombing, by the time already quite a bit of damage has already happened. So that's a very, very important thing. What about, did you do an echo?
So echo.
See, the other morbidity is pulmonary arterial hypertension, which you already alluded to. I think even in your clinical examination you mentioned P2 was normal.
Yes, sir.
I mean, I assume that the reason you did look for the second heart sound was because you wanted to look into pulmonary hypertension. So yes. Did you? We are not. I think most people do not do the catheterization to confirm. If you're doing that, that's fine. But if you're not doing catheterization, what are the indirect markers that clue that the person could be having pulmonary hypertension? Okay, Dr. Swami, I'll ask you this question. You are the person who is suspecting systemic sclerosis. You want to know whether a patient has pulmonary arterial hypertension or not, and that's a very, very important question. So what will you tell the radiologist to do? What do you look for? You send for an echo heart, that's fine, and he does an echo, but what parameter would you look for?
Right ventricular hypertrophy. Then
so basically it's a right ventricular systolic pressure. That's called as RVSP. So you ask for them, please give me the RVSP values, and that's what you ask for. Okay.
And you said HRCT too. You want to do HRCT so that you can identify the early disease, right, Sharon? So are there any preliminary criteria, clinical criteria for early diagnosis?
I'm doing a chest X-ray and
no, apart from investigations, your clinical examination, can you
chest expansion, ma'am?
Okay. Puffy swollen digits and DNA positivity. So even they indicate they are, early disease you can catch up.
Yeah, who else? Okay, Dr. Ujjwal, you are the physician and you asked for a HRCT. What will you look for in the HRCT? Forget about, I'm not asking you the patterns, but grossly, what would you look for?
Lower lobe involvement, sir.
Which one?
Lower lobes involvement.
Lower lobe involvement. So it's basically, I'm talking the area. So it's around 20%. See, basically the way to say it is less than 20% or more than 20% involvement. Okay, the area. There are many other findings I'm not talking about. Is atelectasis, honeycombing, all that. I'm not talking about that. But it's less than 20% or greater than 20%.
Chest X-ray, what will be the finding?
Fibrosis, if it is a late stage. Otherwise,
on glass appearance, that's character. On the honeycombing is on HRCT only. It is not X-ray.
Okay.
Those are the patterns what you see on HRCT. Honeycombing, then what they call crescent form in the lower lobe of the lung involvement. So X-ray you see ground glass appearance.
Okay.
And see, in your history, you had asked for difficulty in following more solid food, right?
Yes, ma'am.
Specifically. Why did you ask that? And is it correlating with your findings?
Ma'am, I asked that especially because to rule out between scleroderma and dermatomyositis, ma'am. Whereas in scleroderma, they'll have dysphagia to solids, and in dermatomyositis, they'll have to both solids and liquids. So history-wise, to differentiate between the two connective tissue disorder, and also to look if there is any overlap, those questions was asked.
Dr. Ansi, I have a question.
Yes, sir.
Do you feel that a barium meal should be done? What are the pros and cons of doing
So
Isn't
I
it
think
to
it
the
can
patient?
be done if we are thinking if there is an esophageal involvement, sir. Like since my patient had history of dysphagia to solids, I wanted to do a barium swallow to see if there is like esophageal involvement.
Okay, you did that, and say 2 weeks later, patient has high fever.
Okay, sir.
What do you think would have happened?
Esophageal rupture.
Hey, you're not vomiting, she's not pregnant or something like that, huh? We'll have esophageal rupture and then you have mediastinal thing. Aspiration.
You manage this patient. Patient has come to you with all this. You've done the investigations. How would you manage it?
Ma'am, firstly advise them to avoid cold exposure, ma'am, and avoid if they are in some occupation which are involved in this thing, avoid them, ma'am. Then if they have any other drug history which triggers or predisposes them, tell them to be careful and inform them, ma'am. And then since this patient has Raynaud's phenomenon, ma'am, so patient should be started on tablet nifedipine, ma'am, 10 to 20 mg TID, ma'am. Then patient also has here GI involvement, ma'am, so should start them on proton pump inhibitors, ma'am. Then since the patient has skin thickening, ma'am, so patient can be started on tab methotrexate after the investigations, ma'am.
Sharon, would you like to add something to it? Or any comments? Whatever was discussed so far?
Ma'am.
What is nifedipine?
Ma'am,
Nifedipine is
I would
calcium.
like to. Calcium channel blocker is not given when patient has esophageal issue, ma'am. So maybe another alternative for Raynaud's, like endothelial receptor blocker or prostacyclin analogs. I'll be looking for another alternative than calcium channel blocker in this patient.
Yeah, Dr. Soumya, you said 10 to 20 milligrams TID, right?
Yes, ma'am. Yes, sir.
Okay. Have you given 20 milligrams TID to any patient?
No, sir. 10 mg TID, sir.
So what do you think when you give 20 milligram TID to a patient, what do you think will happen?
They will have hypotension, headache.
Then why do you want to see? So every patient who comes, will you give them 10 to 20 TID blanket? You understand? So it's very important because some people don't tolerate it, and there are two reasons. One is hypertension, and second is you have reflux, right? And many of them don't tolerate it. Okay, so I think you must be careful with giving blanket responses like 10 to 20 TID, because for me then it tells me that you have not given, right? So one needs to be careful about doses. So you always start low and then titrate to the maximum possible. Suppose you cannot tolerate calcium channel blockers, then you go for other ones. If you cannot give nifedipine, you can go for amlodipine if you want. Okay, or you have to go for a different class of drugs.
Yes.
Okay.
Yes.
So which is, if you suppose you cannot give calcium channel blockers, because what other drugs would you give?
Sildenafil, sir, phosphodiesterase 5 inhibitor. Then IV iloprost, sir, can be considered.
Normal Raynaud's phenomena, would you give iloprost? Iloprost always is given in an emergency when you are going to lose a digit, right? Sildenafil, the problem with sildenafil is it is short acting, so you'll have to keep on giving repeatedly, right? So and then you'll have a horrible headache. So if you want to use something like tadalafil, which is longer acting, right? So that is something which you need to keep in mind. Or sometimes you can combine calcium channel blockers with tadalafil. So you can also use combinations. Okay. So that's extremely important to consider.
So if on HRCT or if you find that the patient is having ILD, then what would be your treatment approach? Sharon?
And if the patient have lung involvement, then I would like to consider strong immunosuppressants like cyclophosphamide, ma'am.
Okay.
Cyclophosphamide, I can give it in monthly pulses along with daily doses, ma'am. Monthly pulses of around 500 milligram per month, ma'am, along with daily dose.
So how much would you give for induction phase? So other than cyclophosphamide, anything else you want to give?
If there is interstitial lung ILD involvement, then I can also consider steroids, ma'am, but I should be very careful in administering steroids in this patient because it can precipitate scleroderma renal crisis.
Okay. But this patient, does he have renal involvement?
No, ma'am, this patient doesn't have renal involvement clinically.
Okay. So what other options other than steroids? Then what else can you give?
Cyclophosphamide, other options like mycophenolate mofetil can be considered for this patient. Then cyclosporin.
Cyclosporin, do you consider? What are the disadvantages of cyclosporin?
Cyclosporin.
Renal involvement.
In case of, it can increase the BP, ma'am. Can cause hypertension, but we have to be very careful. Other options like
azathioprine would be a better option.
Sorry, ma'am.
Azathioprine would be a
Yes,
better
ma'am.
option
Yes.
than cyclosporin.
Yes, ma'am.
Fine.
We are out of time, so can we have final comments from the examiners?
Yeah, overall it was a good presentation and discussion, and both Dr. Nancy and Dr. Sharin did well. Yes, Dr. Lakshmisha.
Yeah, I just want to correct some things for lung involvement: cyclophosphamide, rituximab, mycophenolate mofetil, and tocilizumab. Steroids are not often usually indicated. So these are the four.
Okay, sir.
Right?
Yes, sir.
So that's something, and you have to monitor with forced vital capacity.
Okay, sir.
Anyway, all patients with suspected systemic sclerosis, most important, should be evaluated for ILD and pulmonary hypertension. And of course, renal evaluation, very important. So that is the things. And as already, like HRCT, you said to catch up the patients early in the early stage. So you have to clinically also, you have to assess them. So you should keep in mind the preliminary criteria for early diagnosis so that all these complications can be avoided.
So as we conclude this session on connective tissue disease, I would like to express gratitude to our esteemed faculty, Dr. Lilavati ma'am, Dr. Mary Augustine ma'am, and Dr. Lakshmisha sir. I thank all the postgraduate residents, Dr. Ansi, Dr. Sharon, Dr. Ujjwal, and Dr. Soumya for their active participation. Thank you all. Welcome all of you.
I thank our faculty for the wonderful discussion. And now we move on to the audience questions. We have Dr. Lakshmisha sir and Dr. Mary Augustine ma'am who will be joining us for the discussion. So my first question is to Dr. Mary Augustine ma'am. Ma'am, how do we elicit the ice cube test or the Raynaud's phenomena?
Yeah. So like I think like Dr. Sharon said, you have to immerse the hand in cold water for about 5 minutes and then take it out and wait for a few minutes and then watch the color change. Initially pallor, cyanosis, and redness.
Okay, ma'am. My next question is to Dr. Lakshmisha sir. Sir, Stapner's sign is widening of the periodontal ligament space in systemic sclerosis. Does it manifest clinically or is it an incidental finding? Sir, can you unmute yourself, sir?
I think this is more of an exam curiosity rather than anything else. I don't really look for it. I'll be really bothered about the lung rather than the stagnation sign. That is more of an exam. That's more something which an exam peculiarity which some examiners are fond of asking. I personally have never really looked for into consequences of the stagnation.
I think it's only a radiological finding. That is my understanding.
Okay, ma'am. Thank you, sir. And our next question is, how do we differentiate vitiligo from the depigmented macules that we see in scleroderma? Dr. Mary Augustine, ma'am, can you give your inputs on this?
Vitiligo, you find a well-defined patch of depigmentation. Whereas in scleroderma, you get what we call a salt and pepper appearance. You have an ill-defined area of depigmented spots along with some hyperpigmentation in the background. So as it's called pepper and salt appearance. That's different from the patchy depigmentation that you see in vitiligo. Even if there is a repigmentation in vitiligo, it is just perifollicular hyperpigmentation within that well-defined depigmented patch.
So do you want to give some additional inputs?
Yeah, I think that it's all the salt and pepper pigmentation is one of the important manifestations of scleroderma, but it's very rarely that one mistakes it for a vitiligo per se, because there are usually other features will be there. And the other one is the distribution of many of these salt and pepper pigmentation. That is over the sides of the cheek, the nape of the neck, sometimes over the forearms. They're also slightly different from that of classical vitiligo. And even the repigmenting lesions, as ma'am said, you cannot mistake it for salt and pepper pigmentation.
Okay, sir. Thank you, sir. Our next delegate question is, why are the oral ulcers in SLE painless? Dr. Lakshmi Shah, sir, can you give your input on this?
I have absolutely no idea.
Ma'am, would you like to give any input?
I don't know either. The reason for it, I don't know.
Okay, ma'am. Okay, our next delegate question is, how do we identify calcinosis cutis clinically? Ma'am, would you like to take this question?
Yeah, it's usually seen over in scleroderma, it's usually seen over the bony prominences, and it manifests as stony hard papules from which chalky white material, on ulceration, those papules will break down, releasing a chalky white material, and then there'll be a small ulcer left behind. That's on clinical examination, and of course on X-ray you can find these calcified areas. That's in scleroderma, whereas in dermatomyositis you can get calcification, calcinosis elsewhere also, including in the muscle planes, large sheet-like calcinosis you can get in the muscle planes also.
Okay, ma'am. Thank you, ma'am. Sir, would you like to add something else?
The only thing is that you need to keep in mind that the calcinosis, it can occur in the acral areas as well as it can occur in the lungs also. That's one feature which you see in systemic sclerosis. It's more of a dystrophic calcification. That's the other thing, because there's damage to connective tissue, calcium gets deposited, so it's a dystrophic calcification. And especially over the fingertips and when it occurs and the dots, you can mistake it for vasculitic lesions. So as a postgraduate, one should definitely ask for discharge of chalky material. In the absence of that, one should also consider a vasculitic ulcer. So that can sometimes happen.
Thank you, sir. Thank you, Dr. Lakshmi Shah, sir, and Dr. Mary Augustine, ma'am, for joining us in the discussion of the audience questions. Thus, we conclude our day one session of eDerma Advanced 2021. I thank all our faculty and postgraduate residents for participating in today's program. Please join us tomorrow for day two of eDerma Advanced, which will begin at 9 a.m. Thank you, everyone.
Thank you.